5, 4, 3, 2, 1, go. You're only supposed to blow the bloody doors off.
It's great to be here. What an amazing facility we've got. Really good.
Yeah.
Very happy to be here. That all sound okay?
Yeah.
Excellent. Thank you.
Morning, everyone. I'll just get started as the last people come in the door. Welcome to CGDent Scotland Study Day 2025. As always, many thanks to all of you who are our regular attenders, those who are here for the first time, our VDPs, our final year dental students, and the significant number of hygienists and therapists who have joined us today. The mission of the College of General Dentistry is to be inclusive of the entire dental team, so we are delighted to have you with us. A mention to our special guests, Professor Aileen Bell, Dean of Glasgow Dental School, Billy Cameron, Assistant Postgraduate Dean for Vocational Training, Thomas Lamont, Associate Postgraduate Dean for Workforce Development, and to Dr. Gillian Leslie, who has just been announced as the new Chief Dental Officer for Scotland after serving 5 years as Deputy. Many congratulations, Gillian. Welcome also to those joining online. I'm sorry that we couldn't accommodate everyone in the room, and I know that there are people joining us who are now not well, but they're still joining online, so thanks for keeping with it. I hope you all have a wonderful day. A reminder, just in case you don't know, CGDent Scotland is a community interest company with an affiliation to CGDent UK. We are a small, independent, non-profit making organisation run by volunteers, and we exist as an educational enterprise specifically offering a home to the community of practice. Any profits that we generate from this are given to the dental charities, which you'll all be familiar with. If any of you feel like joining our committee, we are always looking out for new enthusiastic members, so please approach us. As always, we keenly acknowledge the presence and support of the dental trade. Their generous sponsorship allows us to limit the delegate cost. We have long breaks in the programme, so please visit the exhibitor stands as well as taking the opportunity to network with colleagues. We'd also encourage you to speak to our cohort of VDPs and students. They need our support and mentorship, and this is an excellent opportunity to introduce them to our community of practice. As an organisation, we're presently working through Thomas Lamont's leadership with NES and the Royal Colleges in Scotland to try to find a better way to support our colleagues in the first 5 years of practice. In another aspect of our recent activity, we've become affiliated to Professor Subir Banerjee, who is a former Study Day speaker. Subir has brought his esteemed postgraduate diploma leading to Masters in Advanced Aesthetic and Restorative Dentistry programme to Glasgow for the past 2 years. This is conducted online by highly respected tutors, but includes an intensive 6-day hands-on course held each of the 2 diploma years at GDEC in Sauchiehall Street in Glasgow. Subir offers the opportunity to upgrade to a master's degree in the 3rd year through the University of Portsmouth. He's with us today in the exhibitor hall, and we also have a number of his current Scottish students with us that you can speak to. This is an excellent opportunity for Scottish dentists to access this qualification without the expense and inconvenience of travelling outside Scotland. In addition, the exciting news for therapists is that Subir is bringing his hands-on diploma leading to Masters in Advanced Restorative Dental Therapy to Scotland in March 2026. If you wish to gain more information about either of these programmes, please visit the ADE stand in the exhibition hall and have a look at the information in the brochure. Now, unfortunately, Roshni Korea, National President of CGDent UK, can't be here today due to teaching commitments. So in our place, I'd like to mention the College of General Dentistry UK. Would you please consider joining this organisation? It has ambitions to gain Royal College designation, elevating our professional status to that enjoyed by other branches of medicine, and advocating on our behalf. It's open to all members of the dental team. Many of us here today are members or fellows, including our speaker, Ian. As usual, we've got a packed programme. Can I urge you to listen to the request to return to the IMAX Theatre at the end of the breaks? We're at full capacity today, and it's a huge challenge for the staff to feed everyone in time. And, in the time available, so we'd be grateful if you could follow the instructions given. You may have noticed that we have a group of fourth-year students in attendance who are scanning you into the theatre. We're running a pilot today to check that the technology works. Obviously, we can only give CPD hours for the lectures that you attend, so please be aware that if you leave the event early, you won't be able to re-enter as the door becomes one way in the afternoon. Whenever you leave, please hand in your lanyard. So now we'll move on to the programme. I work as a part-time clinical teacher at Glasgow Dental Hospital, and when I told the fifth years that they were lucky enough to be attending a day of perio lectures, the response was less than overwhelming. Once they composed themselves, I promised them that they would come away today with a new passion for perio, so no pressure, Ian. Ian is a specialist periodontist from Liverpool. He serves on the British Society of Periodontology, is involved in postgraduate teaching, was involved in developing the S3 treatment guidelines and in formulating the SD-CEP guidelines on prevention and treatment of periodontal disease in primary care. He is also a wonderful speaker and communicator with a knack of making all those algorithms seem straightforward and presenting a pragmatic and sensible approach to perio. I won't go into Ian's full professional biography, as you can read it in our virtual programme, but he does have a life outside of dentistry, which involves spending time with his family, his dog Cooper, and time at his beloved Lake District. He is also a master swimmer. I had to look that up. He's a master swimmer, and although he's had a year out of competition, he hopes to compete again next year. So have a great day, everyone, and Ian, can I welcome you and invite you to deliver your first lecture. Thank you, Ian.
Thank you for that kind introduction, and thank you for inviting me to be here. There's Cooper. Oh. And for those of you thinking, he looks like a big lad, he can't possibly be a swimmer. That's me in lane 1, nearest, so I can get up and down the pool. Passionate about perio. I didn't pick that title. And for those of you who have come here today and you're thinking about this sort of passion, you've come to the wrong gig, because quite hard to think about passion when you're looking at those sorts of photos. The sort of passion that I'm going to hopefully try and instill in you today is the passion it takes to get you from here to here. And for me, you know, it's this sort of passion. It's sort of drive, it's desire to help people. I only wish my club had a little bit more of the Stevie G in them at the moment, because it's quite difficult being a Liverpool supporter. Patricia joked about, you know, I'm probably not joked about telling the dental students that it was a perio day. I bet you wish you'd come last year. Aesthetic dentistry, next year digital dentistry, and you've got the short straw, haven't you? And yet perio is the be-all and end-all of you know, modern restorative dentistry. You can't do the nice pretty stuff if you haven't got your fundamentals right. So whether you like it, love it, hate it, loathe it, whatever, you're stuck with it. We've got to do it because it's a really prevalent condition. It's massively overcomplicated at undergraduate level. I taught at undergraduate level at Liverpool University for many years. I was the perio lead there for 5 years. And we would teach you all about hyperactive macrophages and impaired neutrophil function and reduced chemotaxis. And then Barry the builder comes in on Monday and you're saying, oh yeah, Barry, your neutrophils are impaired and your chemotaxis doesn't function. And you've got all this clever stuff that you've passed exams in, but you can't actually get it across to patients. And so what I'm hoping to do today is join up some dots for everybody in the room, general dentists, hygienists, therapists, dental students, and hopefully give you some pragmatic approaches, because also at dental school, we work in a very an ivory towered environment. And you can spend hours doing tooth by tooth root planing and that quadrant this and hours of that. And then you get into the real world where you've got the SDR for a lot of you working in the NHS, and perio becomes almost, you feel, unmanageable. And one of the things I'm going to hopefully get across in the middle section today is that actually I think you can make an impact with the modern SDR. It's not perfect, it's not great, I think it's better than what you had before. And we'll try and have a look at just things you can consider going back to practice that you can do that might make things a bit more efficient compared to what you may have been taught at university. I'm going to try and make this very, very practical. A quick plug for the BSP, not to join it, because you're all going to go and join CGDent after today, an organisation I've been part of since the very start, its inception, and an organisation I truly believe in. I think we need our own college. We need that college to have Royal College status. We can only do that when we've got membership. So please do consider joining the college. The reason for mentioning the BSP is more that I need you to be driving your patients to this website. We have invested so much time and effort in this website, specifically the patient section. You know, there is so much noise and guff out there in the internet. It's like the Wild West. You know, coenzyme Q10 this and oil pulling that and I don't know, charcoal suppositories and shoving things in. But do you know what I mean? The patients are just confused. And yet this website is peer-reviewed, evidence-based, non-commercially biased. We've got leaflets on perio and lifestyle, perio and smoking, perio and pregnancy, perio and diabetes. There's a bucket load. There's about 8 of them. And that should be where your patients are shown to get their good quality information, because it's going to reinforce, hopefully, the high quality message that you're giving to your patients. So that's my only plug for the BSP. The outline for the day. Now, I appreciate heart sink moment when you see the word etiology on the lecture slide, but I'll justify that in a minute. We're going to try and get through some etiology and link it to S3 guidelines, and the SDR is going to run through the day. I'm not an NHS expert. Blimey, I had to spend time getting my head around your SDR. Wow. I'm based in England. I've just about understood the UDA system, and the SDR is quite complex. I have been an NHS GDP. I was an NHS GDP for about 8 to 9 years. I worked in the old system that you guys have been working in for the last God knows how many years. I have walked a mile in your shoes. I'm not that ivory-towered academic who's never done a day of NHS dentistry, and hopefully that will also come across. The middle section is all about the patient, and then also about what we can do for the patient. And then the end session, we're going to talk about when that doesn't work, what options have we got. It's a lot to get through. I'm going to crack on. So, etiology. We joked, you've all been taught, you've all passed exams in understanding these complex mechanisms that you then struggle to translate into the real world practice. And how can you treat a disease that you don't fully understand? You know, the whole plaque triggers inflammation, inflammation damages bone. Yeah, it's all very simplistic, but we could do with understanding it a little bit better than that, because it feeds into the treatment protocols we're going to talk about after the coffee break. So you're all sat here today, hopefully, in a health disease balance. Can I have a show of hands? You've all brushed your teeth this morning. No, I'm kidding. Some of you probably flossed in case we do plaque scores in the coffee break. We're not doing plaque scores. There's too many of you. All the hygienists will have flossed. It's just dentists that don't floss. Anyway, we're all hopefully in this health disease balance. We've got our bacteria on one side, and we've got our microbiome, as we all call it. It's very posh now. In Liverpool, we still call it plaque. We've got our oral microbiome on one side. We've got our host response on the other. And hopefully, we're all living in harmony with our oral microbiome. Our host response is made up of 2 basic components. I apologise now if we've got any immunologists in the room. This is very simplistic. But your host response is made up of 2 broad components: inflammation and then the immune response. Your immune response is that learned response. It's the thing that comes later, where your body develops antibodies, antigens to specific challenges. It's a learned, very nuanced response. Inflammation is the opposite. It is literally a crude, blunt weapon to deal with a challenge. And sat in this room now, we are all dealing with these challenges all the time. Ian Chappell talks about the concept of what's called immune surveillance. Your body is going around deciding which battles to pick. If you remember your inflammation system, the basic sort of initial response is the neutrophil. This is the stuff that you 4th and 5th years will be battling away at, passing exams in. But whenever I get a difficult concept, I always have to boil it down to explain it to a 12-year-old, and then I hopefully can then teach it. So many years ago when I was doing my perio training, I did boil this down to that sort of simplistic level. I sent it to my good friend Ian Chappell, and I said, Ian, is this roughly how this works? And once he'd got past the disdain of how simplistic I'd made it, he was like, yeah, sort of, but come on, you're not 12. I was like, no, that's exactly what I want. Then I know that I understand the subject. So the neutrophil is the first line of response. Your biofilm produces endotoxin, poison. The clue's in the name. That endotoxin binds to a host receptor cell, and that cell sends a signal. And that signal is basically going, hey, help, hey, help. The body goes, aye, aye, there's a problem. Let's send in the lads, and the lads being the neutrophils. So that's chemotaxis. That is chemical signalling, and the neutrophils are now going, we need to be over there because there's a problem. The neutrophils are drawn to the site of the problem. They leak out the blood vessels. That's diapedesis. Do you remember all these words? Yeah, learnt it, passed it, forgot it. Yeah. Diapedesis, that's why we get plasma leakage into the tissues. That's why we get edema. And the neutrophil goes to the site of the problem and it phagocytoses the bacteria, gobbles it up. And then it releases a load of potent killing mechanisms, elastase, collagenase, all these different things. And when it's done its job, it explodes. It's like a kamikaze cell, and it spews out all of that dead stuff into our tissue. And we have a process called active resolution, where our body mops up the byproducts of that inflammatory event. And when they're in balance, we all live happily ever after. And inflammation is a really good thing. The problem that we have in perio is that we have dysregulated inflammation. So we have a biofilm that is incredibly difficult for the body to manage because it's become established, and more of that in a few slides' time. And so as those neutrophils arrive and they start gobbling up those bacteria, they're having minimal impact, and that endotoxin production is still upregulated. So what does our body do? It sends more and more and more inflammation. And what happens? The phagocytosis happens, the neutrophil explodes, all of that dead stuff is poured into our tissue, but we can't mop it up as quickly as it's being produced. And now that collagenase and elastase is in your connective tissue, breaking down your collagen, your elastin, your connective tissue. And so inflammation, we're in a perio lecture, we always think of inflammation being bad. Inflammation is good. Dysregulated inflammation is bad, and that's what we're dealing with in perio. And this will all make more sense as we go through this first session. So, when I was taught perio back in 1857, we were all being taught, I'm a Leeds graduate, late 90s, but we were being taught it was all about the specific bacteria. We were sort of, there was the non-specific plaque hypothesis, remember that? The more bacteria you had, the more disease we'd see, and yet you will all see patients with appalling oral hygiene and no bone loss. About 10% of the population are resistant to perio. That's what we know. Really bad for business. We then, in the 90s, had Sokransky come along with all of his pyramids and the orange complex and the red complex. So I'm sure the dental students are thrilled to be trying to pronounce AA and P. gingivalis. And we change the spelling every few years just to keep you on your toes. But we were treating perio a bit like an infection at that point. We had loads of things like local delivery antibiotics, more of that later. And it was almost, when these perio pathogens are there, you are going to get perio disease. Now, we know it's not that simple. We see these perio pathogens in healthy patients, but what we do know is that there are certain bugs that when they get together, they are more likely to induce that inflammatory response in a susceptible host. It is not about an infection. There's no one bacteria that when present you'll have the disease, or one bacteria that when you take it away, the disease will resolve. It is not that simple. Perio is quite a complex condition. It's an inflammatory disease that's triggered by the bacteria, and probably more importantly, the groups of bacteria, the organised bacteria as they get together. Our nurses know about this stuff. We don't talk about bacteria or plaque anymore. We talk about biofilms. These three-dimensional polymicrobial sludges that when they get organised, they become greater than the sum of their parts. People sometimes say to me, do you ever get nervous coming to a lecture? I'll tell you what, last night when I arrived here to do a sound check and I came in that back door, I got nervous. And I have been lecturing for a long time. And you're like, wow, that screen's bigger than my house. But you're a friendly-looking bunch. I'm less nervous. I also know that you are more bacteria than you are human, because you are about 1.3 to 1 bacterial cells to human cells. So I just look at you as a room full of sludge, and I don't feel too intimidated. We know that bacteria live in biofilms. If you have a wet, hard, non-shedding surface, you will grow a biofilm. So a rock in a river, you run the finger on the inside of your tap, those of you who've done very well in your life, you might have a yacht. You know, you can run your finger under the waterline, you'll feel a biofilm. I have a canoe. But any hard, wet, non-shedding surface will grow a biofilm. We know that biofilms cause a huge amount of human disease, and we know that bacterial evolution is way ahead of our own evolution. You know, what doesn't kill them makes them stronger. We've got bacterial resistance. It's an increasing problem for future generations. And one of the concepts is that as the bacteria grow, these perionastes, your AA, your P. gingivalis, your Treponella dentata, all the big fancy names, you know, why is the body not dealing with those bacteria? Well, for the same reason that you are all sat here now, having brushed your teeth, hopefully without any gingival response to the plaque that you already have on your teeth. The hygienists are all there going, I haven't got plaque on my teeth. I never have plaque on my teeth. My mouth's always... 20 minutes after you brush your teeth, the pellicle forms, it starts to acquire that early colonisation. By this evening, we will all have significant plaque on our teeth, biofilm. Some of us will have the drinks reception, some of us might go on afterwards, and some of us might go to bed and be a bit squiffy and not brush our teeth tonight, and tomorrow morning we'll wake up and have that But we still won't have a gingival response to that significant bacterial volume. Why? Because there's loads of bugs there. The body is tolerating what's there because it can't go around fighting every battle. When you've got an immature biofilm, the endotoxin production is quite low, so the body decides that that is not a battle worth fighting. And one of the concepts is that it's the biofilm that allows these bacteria to evade that initial challenge, and then it gets too late. And so I was taught by a famous oral microbiologist, a guy called Philip Marsh. He spoke last week in Edinburgh at the BSP conference, and he said to us that plaque represents a classic example of both a biofilm and a microbial community, where it displays properties that are more than the sum of its constituent members. You look at the biofilm sort of assay and you think, that doesn't look too bad. Get them together and get them organised, and then all hell breaks loose. You will all have a friend who, when they phone, you know, the sort of friend that you shouldn't be allowed to sit next to at a party. Do you know that friend? When they ring you, you think, oh, this is going to be a good night. I might not come home till Monday. That sort of trouble friend. Yeah, great people to be around, but you can't do them more than once a year. And then you get other friends, and they ring you, say, do you want to come out tonight? You think, oh, great. I'll be in bed by 10 o'clock. It'll be a lovely evening. I'll be in bed by 10. So it's sort of that. When the wrong bugs meet the wrong bugs and they get organised, that's when all hell breaks loose. And that is one of the concepts that we're working with now. It's which bacteria meeting which bacteria in the susceptible host with modifying factors that we'll talk about in a minute that elicit that inflammatory response, then that dysregulated inflammation. I know at undergraduate level, microbiology is boring, yeah? And as you get beyond it, and as you get into your different specialties, and Patricia and I were talking about this last night, I actually quite like microbiology now. It's a bit weird. I quite like pathology as well. I find people who understand that stuff, I find them fascinating and I seek them out. I'm doing nothing to dispel the myths that periodontists are boring, am I? No. Okay. Anyway, trust me, undergraduates, you may not believe me, but trust me, the things you don't find interesting now, you will learn to love those in time. But we've got this concept now that the biofilm is this almost like a living, breathing organism. We know the bacteria communicate. They send out chemical signals. They call it chemical chitter-chatter. There's a more professional name, quorum sensing. The bacteria communicate and they know each other are there, and it allows them to become organised. Now, without getting into this too much detail, quorum sensing is really interesting. Go and Google it. There's some good TED Talks on it. One of the things that's being looked at, and it has been for the last 15 to 20 years, is using quorum sensing inhibition to block chemical chitter-chatter. If the bacteria don't know each other are there, they can't get organised, they maybe don't become as pathogenic. The University of Nottingham did a study quite a few years ago now that showed that 16 years before the study was done, a 3-day course of antibiotics would have a 97% clear rate for a urinary tract infection. When they were doing the study, 16 years on, that clear rate was 63%. So in 16 years, that's a huge amount of antimicrobial resistance. What do? We either double it up, we give an extra antibiotic, we give it for longer. What does that do? It just kicks the can down the road for the next generation and the next generation. And what the University of Nottingham did was they took that same 3-day course of antibiotics, they plugged in a quorum sensing inhibitor, and they got the clear rates back up to low 90%. That to me is cool in the gang stuff. That's like proper science. Watch this space. For some of you youngsters in your practicing lifetime, this hopefully will be a thing. So we know bacteria communicate and it allows them to get organised. We know that the bacteria trade, they swap byproducts, they become synergistic, they are supportive of each other. One bacteria's waste will become another bacteria's nutrient, and it becomes this living, breathing organism. We know there's the concept of construction, so we know that there's a protective element of the biofilm, and that's where that immune surveillance misses maybe that early periopathogen. And so, here we've got a slide that shows a biofilm, a lab-grown biofilm, admittedly, but all of the green cells are living bacteria. It's then being hit with cordyceil, chlorophyll, chloroform, cordyceocil, whatever your patients say up here. And all of the red cells are the dead cells. What does it tell you about the chemical control of established biofilm? It tells you it's hopeless. Chlorhexidine works well on a clean surface. It prevents plaque accumulation on a clean surface. What do the adverts tell your patients? Corsadil for patients whose gums bleed when they brush. No, brush more, do more, physical rather than chemical. I'm forever saying to patients, right, Mrs. Jones, blue one here, yellow one there, purple one here, and she goes, oh, it's all right, mate, I used that cordyceil. And your heart sinks and you want to give them a metaphorical Will Smith, don't you? You know we're not allowed to hit patients, don't you? If you're making notes, Ian said we don't hit patients. But you do just want to go, ah. And so for those of you who have not heard some of these analogies before, you need something quick that is the equivalent of a psh, stop being so silly. And it is, would you throw a bucket of water over your car? So when the patient says, oh, it's all right, mate, use that cordyceil, I go, do you? Would you throw a bucket of water over your car and expect it to be clean? No, I wouldn't. Why not? Well, there'd still be bits of mud on it. That's right. How would you get that mud off, Mrs. Jones? Well, I'd get a sponge and I'd give it a scrub. Mrs. Jones, would you read dinner plates under the tap and expect them to be clean? No, I wouldn't. Why not? Because there'd be bits of egg on them. That's right, Mrs. Jones. Even with the best fairy liquid, there'd be bits of egg, wouldn't there? How would you get the egg off? Well, I'd get a scrubbing brush and I'd give it a scrub. Mrs. Jones, you've done all your chores for the day. You've washed the car, you've done the dishes. You've gone for a walk. You've picked a rock up out of a river. What does it feel like? It feels slimy. That's right. Like the slime we were talking about on your teeth before about the bacteria. For 1,000 million years, water's been flowing over that rock, and that rock is still covered in slime. It's a bit like your mouthwash, Mrs. Jones. How would you get that rock clean? Well, I'd get a brush and I'd give it a scrub. Mrs. Jones, put the core still down, pick up that purple TP, and focus. You're laughing. You'll be using them on Monday. Yeah. Students, you'll be like that. Don't put these in exams. They're not going to get, do not. This is when you are talking as a human being and not as a robotic dentist to your patients. But there is nowhere to go with these analogies. Physical over chemical is what our patients have to understand. And then finally, we've got this concept of teamwork. As the biofilm grows, it becomes synergistic, it becomes supportive, it becomes protective. And so for all of the plaque scores, and can I just say, dental students, I hate plaque scores as well. Boring as hell, but a necessary evil. But it's less about the plaque volume and score, and it's about the biofilm disruption. It's the organised, stagnating biofilm that's the problem, because that's where the endotoxin production upregulates, and that's where the body goes, oh, yeah, and sends inflammation. Yes, we do want plaque scores low, because by doing that, we are disturbing the biofilm at the same time, and you can't have a high plaque score and be disturbing the biofilm. But when we're treating perio, and this is something I want you to remember for this afternoon, it is all about biofilm disturbance, because disturbing the biofilm downregulates inflammation, and I'll prove this to you later. Our patients have to be told that the biofilm is chemically resistant, but physically very vulnerable. We can break it up very simply with our equipment. Patients can break it up, but it's going to take a bit of effort. And I say to patients, look, it's a bit like losing weight. It's harder to lose weight than it is to maintain your weight. It's harder to get fit than it is to keep fit once you are at that level. Mrs. Jones, it's going to be harder to get you stable at the start. Once you're there, things will get a bit easier, but this is going to take some front-loaded effort on your behalf, Mrs. Jones. For all the essays that lots of you have passed and written, that sentence sums up disease etiology, our understanding. The most successful treatments need to attack the integrity of the biofilm, of the periodontal biofilm, and suppress the destructive host response. If you think of it as the bacteria are pulling the trigger, it's the host response to that bacterial challenge that does the damage. And our patients need to know about that that physical vulnerability that their biofilm has, they can make a huge impact. And we are going to talk about that because it's something I'm really passionate about after the coffee break. Not a big thing to come back, is it? But trust me, it'll be good. Trust me. You get that bit right, everything else becomes more efficient later on. You're claiming the same money for doing less treatment because the patients have done more. That's where that fits into your world. We'll talk about that later. So, I showed at the start a seesaw, and we've really only talked about one side of that seesaw. On the other side of the seesaw, we've got other things that affect the way the host responds, and you will know that as risk factors. And most of the risk factors haven't changed in the last 30, 40, 50 years. We know that we say genetic. There is no genetic component of perio. There isn't a perio gene. They looked at it when they did the Human Genome Project. They couldn't find it. When we talk about genetic, we are being loose with that word, non-scientific. We talk about family patterns of disease. In the same way, we see family patterns of cardiovascular disease, arthritis, diabetes, all these different conditions. But it's not truly genetic. I've seen twins where one has it and one doesn't have it. It's not that simple. We know that we've got the big ticket stuff, smoking, stress, medical conditions like diabetes. None of this stuff is new news to you. Nutrition, maybe. I think it was about 9 years ago, we had a conference, BSP conference over in Belfast. It was the first time where I saw a real focus on lifestyle and perio and a huge component on nutrition. And we'll talk about it in a couple of slides' time, but it may or may not be getting talked about as much as it should do at undergraduate level. And then obesity. That's probably something that wasn't on the radar years ago. We've got about 40 studies that correlate high BMI to increased severity of periodontal disease. Now, I can already hear what some of you are thinking, correlation. You know, in that obese group, you'll have poor nutrition, you'll have increased type 2 diabetes. You'll probably have low exercise, another anti-inflammatory thing that we can do. When we've extrapolated the data and when we've removed these confounding factors, it still appears that obesity is a risk factor for periodontal disease. It's to do with adipose tissue being a storage medium for cytokines, epidokines, part of the inflammatory cascade, and so it's part of the bigger picture. Now, I've yet to have the conversation, Mrs. Jones, I see you like chips. I've not had that conversation because what we don't have are the intervention studies. We don't have the studies that say if you lose weight that your perio will get better. However, you know, when patients say to me, is there anything else I can do? I'm trying everything. Then some of these sort of other things, these lifestyle things that might lead to other metabolic diseases are things we can talk about. If your patients focus on the one side of the seesaw, the oral hygiene, and if they control the big ticket items, which we know of as smoking and diabetes, and then you do reasonable treatment, most of the people, most of the time, are going to get better. And those that don't probably need somebody like me or your colleagues up here in specialist care. Perio is an incredibly simple disease to manage, but only when people do all the basic bits right. When we look at that list, it's a lifestyle disease. There is an element of inbuilt susceptibility. About 90% of the population have some level of perio susceptibility. 10% super susceptible, only 8 to 10% are resistant. The most of us have a level of susceptibility. And what we hope in this room, because some of us will be in this susceptible group, is that our lifestyle is such, oral hygiene, diabetes, non-smoking, is enough to keep us in that balance. And in a way, and this, I always feel mean when I say this, most people get the disease they deserve when it comes to perio. You know, if your patients did most of the things right most of the time, they wouldn't have half of the problems they've got. Caries, perio, they are preventable diseases. There are extremes. Those young patients with aggressive disease, clean mouth, that is a very different situation. But that is not walking into your clinic every other patient. Whereas what we used to call chronic periodontitis is, there is a huge amount of lifestyle in this. And so if you like your analogies, you can say to patients, look, your immune system's like a gun, and we're trying to prevent the gun going off, because if the gun goes off, damage takes place. Mrs. Jones, we've got two ways we can stop that damage occurring. We can reduce pressure on the trigger. You need to clean better. And actually, on the days when you're maybe not perfect, if there's less bullets in the gun, hopefully when the trigger's pulled, less damage will take place. The bullets being the risk factors. The aim of all treatment is to redress the balance. I mean, it's super simplistic, and it's easily said and more difficult to do. But most of the time, doing the basics well is what will make a difference to your patient. And that's a really important message to take away, because this is not about complex treatment today. To reinforce this little bit, a colleague, Professor Francis Hughes, who's based down at King's, he was part of an anthropological study. They got some Roman skeletons, legally, and he was asked to look at the dental disease within the Roman skulls, so caries, tooth loss, and he's a periodontist, the periodontal destruction. What he was able to do was age match the skull. He knew that this was a 30-year-old male called Barry from Basingstoke. He didn't know that. He just knew it was a 30 to 40-year-old male. He could look at the disease incidence in the skull and all the skulls he had. He could look at the disease incidence in 30 to 40-year-old males today. And what he showed was that in the Roman skulls, only about 5% of the skulls had bone loss, age matched, compared to about 30% in modern times. Now that's a bit of a juxtaposition, isn't it? Because in Roman times, there was no cortisol, there was no oral BIO, winking at you when you've done your 2 minutes, there was no TPs, and yet they had less disease. Lifestyle. What didn't they have? They didn't have sugar, they didn't have refined carbohydrate, they didn't have saturated fats. They didn't have the lazy lifestyle that a lot of people have. They had a hunter-gatherer lifestyle. If they couldn't catch it, kill it, dig it up, or pluck it off a tree, they didn't eat it, and they would have had a very physical life. Diabetes and obesity would have been very, very low. We probably have got bacterial virulence increased with bacterial evolution over the years. This is not that simple, but it does make the point. They would have had more bacteria on their teeth than we have today, and yet they had less disease, reinforcing the points that I'm trying to make. And these skulls had calculus on them. So, is it just me? I'm looking around the room, I'm thinking, dentist, hygienist, therapist. I can see who's who. Dentist thinking, ooh, please see and treat. Hygienist going, oh, just give me 20 minutes in a Cavatron, and that's like Christmas. We've sort of moved away from Homo sapien, and we've become a bit Homo Simpson. And it is a modern disease. And yes, we're laughing, and yes, it's important, and if you're laughing, you're learning, hopefully. But that cartoon is what we're up against. You know, when I say to patients, bacteria triggers inflammation, inflammation damages bone, they go, oh, right, bacteria, so I'm going to get some antibiotics then? No, you could always brush it off, couldn't you? Oh, that sounds quite difficult. I'll use that cord. Everyone wants quick fix, easy. You know, Mounjaro, the new weight loss, everything's about quick fix. Turkey teeth, I want it done yesterday. I want it done quicker. I don't want to wait. I don't want to do things properly. This is what we are battling against when we're battling perio. I mean, there are two main reasons I always think that we as a profession have sort of not dealt with perio well. One has been chronic underfunding. There's no two ways about it. And two, it's the lack of control that we have over this disease. As a profession, we are control freaks. We love our shiny polished margins and our apical constrictions and working lengths and all these, measure this and, ooh, look at me. And we get to perio and you can be the world's best scalar root planer and get a rubbish patient and you don't get very good outcomes. I'd rather have a great patient than an average clinician and we're going to get somewhere. And that lack of control makes perio not that palatable. But when we get it right, it's absolutely brilliant. If we just finish this bit talking about the big ticket stuff, not about how they work, but what we need to be telling our patients. We know that smoking is the single biggest modifiable risk factor in perio. I say that beyond oral hygiene because for me, bacteria, plaque, poor oral hygiene, that's an etiological factor. That's a trigger. That's the cause of the disease. So for me, smoking is the first single biggest modifiable risk factor. And we are supposed to, I don't know whether you know this, we're supposed to ask permission to talk to people about their smoking. This has come from the behavioural psychologists. So very simple, I get halfway through my consultation, I say, Mrs. Jones, I can't help but notice on your form you've put that you smoke. Is it okay if I just explain in 2 minutes how that is going to affect the way we treat this disease? And that's my ask permission. And when Mrs. Jones goes, go on then. I go, no, don't be like that. You can smoke all you want. My teeth won't fall out if you continue to smoke, but I need you to know a couple of basic things. Mrs. Jones, you are 3 to 7 times more likely to have this disease because you smoke. You are 3 times more likely to lose teeth compared to a non-smoker. And you are also less likely to respond favourably to my treatment. Mrs. Jones, if you and your twin sister walk into my surgery with the same disease, you smoke and she doesn't, and I treat you both the same way, she will get better outcomes than you because you smoke. Mrs. Jones, with that information, is there anything you might think about doing about your smoking? Our job in practice frontline is to ask, inform, and direct. And your medical legal job is done at that point. You are not trained to do smoking cessation. You're certainly not paid to do it. You ask on your medical history form, you have that brief intervention that takes no more than a minute. And if they show remote willing, you direct them somewhere. I don't know what systems you have up here, but in Liverpool, we have a great charity called the Roy Castle Fag Ends Association, and I direct my patients to there. And the patients are 4 times more likely to quit if they have proper support. That's our job. They have to know medico-legally that your treatment's going to be less successful. That is a really important thing to be getting in your clinical records. And then it brings us on to vaping. I'm assuming that vaping's just as big a problem up here as it is in Liverpool. Parts of Liverpool smell of sort of bubble gum, watermelon and apple, and then other parts marijuana, but that's probably most cities in the UK. Vaping's become a massive thing, hasn't it? And the BSP have put a statement out. The BSP have said, if your patient chooses to vape as part of their smoking cessation attempt, we should support them. That is not the BSP saying that vaping is good. We are saying that we believe vaping is safer than smoking, but also we are saying it's not innocent. And so for me, that is a patient who's engaging, they're showing willing. It is probably a good thing for their general systemic health as well. We can't get too focused on just our one little condition. And so that, you know, Mrs. Jones, that's great news that you're going to get off those dreaded cigarettes. That's really good. Once you've got on top of the vaping, you know, hopefully then you can start weaning yourself off that. That is probably safer, but we know it's not totally innocent in terms of your oral health. Is the message that we're giving to our patients. Going from smoking to vaping, we believe is a positive. The problem that we're seeing is my children's generation, 18 and 23, my 2 daughters, unusual names, but we like them. But my daughters have grown up right in the middle of this vaping generation. And I remember when, around the pandemic, when my youngest was 13, she told me that about a third of her year vaped at 13. In a middle-class school, middle-class area, you know, this is not some inner-city slum school type. This was, I was like, a third? Can't be a third, Jasmine. She was like, yeah, about a third. Because that generation think it's innocent. They think smoking's abhorrent, they can't bear it, but vaping's okay. It's this generation's version of Alka-Pops, isn't it, realistically? Now, we don't have loads of data, but there is quite a nice study, this study, that looks at 3 groups of patients, their oral flora. They look at smokers' oral flora, a non-smoker's oral flora, and a never-smoker new vapor oral flora. And the oral flora of that middle group, the never-smoker new vapor, is much more closely aligned with a smoker's flora than it is a non-smoker's flora, which is ultimately more anaerobic, more periopathogenic. And so whilst we're not seeing more periodontal disease yet is the big word there, this may become a problem in the future. So going from smoking to vaping, good. Going from non-smoking to vaping is bad. That is the message we need to get out to our patients. I think the one thing I've done with my children, this is not scientific, but when you're young, and we've got lots of young students in who just probably think they're bulletproof. They recover from hangovers enviably. They're up and fresh-faced the next morning. Your world is full of repair and turnover and health and, you know, great. When you get old like us, you know, your knees click and everything's a bit aching, your hangover's a bit like 3 days. And we're just not as bouncy and as springy. And when you're young, you think, oh, well, it'll happen to somebody else. It'll happen when I'm old and I don't care about it. So I've been showing my girls pictures of lost papilla, ANUG, because we're seeing way more AUG in vaping patients, and because all they care about is aesthetics. And I'm trying to scare the life out of them with aesthetics. They don't think bone loss will happen to them. And that is something I would encourage you to do with your younger patients. Show them the stuff that is going to push the button, because they don't think the other stuff's going to happen to them. Diabetes. Now, huge problem. We know that about 5% of the population are diabetic. We know that about the same amount are undiagnosed type 2 diabetic patients. Nothing has changed from your dental school days. We know we've got this bidirectional impact of the two diseases. It's currently the only disease that we have that has this two-way street. I think we're going to see another one. Talking to Shauna Culshaw, one of your own from Glasgow, only the other week, she's saying now that she thinks rheumatoid arthritis and perio are bidirectional, and she's got enough data to probably show that. So watch this space. It shouldn't be a surprise to us. But we know that when perio is out of control, diabetes is more difficult to manage. When diabetes is out of control, perio is more difficult to manage. Stabilise one, we know this bidirectional benefit. I don't think we do enough on this in the UK. I don't think we ask enough questions. When your patient comes in, new patient, and they've ticked no to diabetes, you go, oh, brilliant. And you get on with your appointment. Is that enough? I'm going to give you a scenario. This is a true story. So I had a new patient consultation. This is about 18 months ago. I work in a big practice, 4 floors. I'm on the first floor, and we have an upstairs waiting room and an upstairs reception desk. And I've got a 9 o'clock new patient consult. And Emma, who sits on the desk, sends me a message. Hi, Ian. Your 9 o'clock is eating jelly babies in reception. The cornerstone of every nutritious breakfast. Apparently the orange are one of your 5 a day. So he told me. Anyway, in walks this guy. He's 54. He's big. I mean, I'm tall. He's like 6'4", but he's big, like proper big. And he's ticked no to diabetes. And he's in my chair because he's got rampant, out of control, non-stabilising periodontal disease. And he's ticked no to diabetes. Is it enough to accept that tick? It's really not. So the question, risk factors for diabetes: family history, sedentary lifestyle, over 40, overweight, male, unstable periodontal disease, Asian males over the age of 40, 1 in 5 have type 2 diabetes. Look at your patients and risk I'm not saying send every perio patient to your GP. They will not thank you for that. But he clearly has multiple risk indicators. I said to him, I see you've ticked no to diabetes. When were you last checked? Oh, about 7 or 8 years ago. It was clear, so I'm fine. Because that's how it works, isn't it? I said, oh, you've got multiple risk indicators for diabetes. And before I could go into it, we were looking at each other and he went, it's not just that. I said, that's part of it. I said, but your age, your gum disease, that. I said, you are a high-risk patient. I need you to go and get checked. If you have unstable diabetes, it is pouring petrol on the flames of the fires that we are trying to put out. Between now and next time, Mr. Jones, please go to your GP and please go and get a basic blood glucose check. Really simple, brief intervention. No one's asking you to do anything more than that. The patient who says, yes, I'm diabetic, and you go, oh, type 1 or type 2? They go, oh, type 2. Are you stable? Yeah, I'm stable. And you go, brilliant. And then you carry on with your appointment. Ask some questions. Ask them, do they know their numbers? So the main number you want to know, and they should know this, is that you'll have heard of it, the HbA1c number. It is a measure of your glycated hemoglobin, how well you are processing sugar, and it measures about an 8-week period, because that's how frequently hemoglobin is replaced. And the numbers are normally given as a double-digit number. Under 40, non-diabetic; 40 to 49, pre-diabetic; over 50. 50 and over, you are diabetic. It's diagnostic. See that's off the UK Diabetes Council website. I said to a patient the other week, are you stable? He went, yeah. I said, oh, do you know your numbers? He went, yeah. I went, tell me then. And he went, 80. And I thought I had quite a good poker face, but I must have gone. Because he went, no, that's good for me. It used to be 120. And I go, okay, 120 is not great, and 80 is way better than 100. But that's not stable. And that is going to affect my ability to help you to control this disease. I need you to take that more seriously. Go and speak to your practice nurse. Go and get this looked at. You need to either do some more exercise, eat better. You need more medication. Something needs to change if we're going to be able to help you. So please, please, please just ask 1 or 2 more clever questions and then direct them somewhere else. And it's almost a compliance test. You are giving medical grade advice If they come back and they've not done it, you are building a picture of a non-compliant patient, someone who doesn't follow medical advice. People think about perio compliance as just oral hygiene. It's not. It's anything that you advise that they do that they fail to do. And that includes smoking cessation, diabetes checks, turning up for appointments on time, and obviously oral hygiene. We don't withhold treatment from smokers or diabetic patients. We don't. It's medically legally bad ground, even though we see it as a lack of compliance. If a patient's doing everything else right, medically legally we should still offer them treatment because they can benefit, they're going to just benefit less. Nutrition's really simple. Whatever your mum said is good for you, it's good for you. She knew what she was talking about. So we know that antioxidants from fruit and veg, we know that they mop up free radicals that cause what we call oxidative stress within cells. So they are anti-inflammatory. Omega-3 oils are also anti-inflammatory. They feed into active resolution, the mopping up of the byproducts of inflammation. The bad stuff, sorry about this, refined carbohydrates and saturated fats. So can of Coke and a bag of chips is a bit pro-inflammatory. We try and say to patients all things in moderation. As dentists, hygienists and therapists, we're probably chatting about basic diet stuff anyway from a caries point of view. Well, actually, there's probably some small perio impact. We've yet to have a study that shows direct correlation between diet change and periodontal impacts. However, when you get that patient who says, look, I'm trying everything, is there anything else I can do? Just make sure that their 5 a day is not cheese and onion, salt and vinegar, prawn cocktail, and make sure that they are getting a reasonably balanced diet. And then we get to stress. There are loads of studies. Lots of them were done over in Geneva, a guy called Gernot Wimmer. He did some great work that shows very clearly increased levels of chronic stress, prolonged stress, increased severity of periodontal disease. There are two broad mechanisms of this. One is a physiological mechanism that goes on within, where you get excess iron production that feeds bacterial virulence. But the bigger picture for me is the behavior change that goes with chronic stress. I mean things like bereavement, divorce, businesses going under, caring for a sick relative, stuff that's really wearing and chronic and feels unending. Those type of stresses are really difficult. And we often see people not eating properly, sleeping properly, doing the things that they're supposed to do, and we see their periodontal health decline. And I think all we can do with those patients where we identify that type of stress is just to keep their mind focused that when this stress passes, they still want their teeth to be there, hopefully beyond the stressful event that they're going through. And just that behavior modification bit, just focusing their mind on that bit. They cannot change the physiological element. All of these events feed into this cellular event called oxidative stress. You've got your neutrophil damage, that's the direct tissue damage, the enzyme stuff, but we also have these things feeding into stress elements within cells, where we get an imbalance between free radicals and antioxidants, and when we get that imbalance, damage is done via an inflammatory pathway. That hopefully is a modern contemporary understanding and hopefully simplistic understanding of how this disease works. And now we understand that, everything we talk about for the rest of the day should make sense. Because it seems like a bit of a big jump to go from talking about etiology into treatment guidelines. But I'm going to justify why I've done that. We've got this concept of the S3 treatment guidelines. Now, I had no idea what S3 meant. I thought it was some sort of S Club 7 reunion and some of them hadn't come back. S3 is the highest level of international guideline production that you can do. It's done in cardiology, endocrinology, it's oncology. They all do it. What S3 is, it's a level above a systematic review. It is where you ask the literature a question and you go and search the literature. That's a systematic review. But you bring that information back to an expert body and they add some weight or gravitas to how powerful the information that you've found is. Any of you who've done any postgrad or any of your undergrads who have been forced to read systematic reviews, I apologise. But you will know that you can read a systematic review and there might only be one paper that is included in that review and you've learned nothing more from that review than you wouldn't have learned from that paper. But then you do other systematic reviews and there's 50 papers that all tell you the same thing. Well, that systematic review is incredibly powerful because you now know that that thing you've looked at is either very, very good or very, very bad. I'll show you one later. And so that's where the academics come in. They look at the review, they look at the quality, the evidence, and then they grade the response. And you might think, so what? What S3 has done is it's basically told us in perio, that works, that doesn't. That works really, really well. That works really badly. That works quite well. It's done that, and that's a good thing. They looked at, it's not meant to be punitive, it's meant to be supportive. They looked at 4 phases of perio treatment. They looked at the behaviour change phase, they looked at the non-surgical therapy phase, they looked at surgery, and they looked at monitoring and maintenance. 63 questions were asked, systematic reviews, 63 reviews were done. We produced, I say we, the EFP, the European Federation of Periodontology, produced the S3 treatment guidelines. The BSP have really run with this, and I think it's a good thing that we've done it. I think it's a positive, and I'll justify why in a minute. But the concept is, and thank you to Ian Chappell for this slide, is that we've got this concept of a phased approach to care, a stepwise approach. Now, we have this in restorative dentistry. We have the restorative staircase. You don't go from an occlusal restoration to a full crown in one go. There are less invasive treatments you can do in between. And every time you go up the restorative staircase, it's a bit more destructive. The tooth will probably last a little bit, have a shorter lifespan. And the whole idea here is that we don't go straight from diagnosis to surgery. Let's see what we can achieve with the least amount of intervention. This is a really sensible way to do any healthcare impact. Think about it. If you're the patient, do you want the most aggressive treatments as the first line? If you've got an ingrowing toenail, and the doctor says, well, we're just going to chop your leg off just below the knee, 100% clear-up rate. And you go, feels a bit aggressive. Couldn't we start at the ankle? Maybe the toe. Could we clean under the toenail, perhaps? No, doesn't always work. Oh, right, best just chop my foot off there. Because that's what the S3 guidelines are trying to say. Get as much out of the least interventions, and then when you have to, build up to the most. And actually, from a cost-effectiveness point of view, the basic interventions are cheap and have big impacts on whole mouths, so oral hygiene. Non-surgical therapy is more expensive because now we are doing it, and we are more expensive than the patient brushing at home, but we have whole mouth impacts, so the cost benefit is still quite good. When people like me get involved at step 3s and whatever, we're now doing surgery on 1 or 2 teeth at very high cost, and the cost benefit is very, very different. The more we do at the start, the more impactful it is for the patient, and actually for you guys in a financially restricted environment, the less you're going to have to do for the same amount of limited resource. So for me, the S3 guidelines is really positive. The BSP love a flowchart. You've probably got them. If you haven't, email the society and try and get some of these out of my garage. You think I'm joking, my wife manages the BSP. We have a double garage at home, and I have to walk through it like this, like Pac-Man, because there's so much BSP rubbish in there. We ran out of these the other week, and we decided to order 3,000. One of us pressed an extra 0, wasn't me. I'm not saying who it was, but it wasn't me. And we got 30,000, which is the size of about half a mini in my garage. So please, email society, dear Paula, please. Ian said you'd send me some. Anyway, we've got a flowchart that holds your hand through the management of periodontal disease, and it talks about this stepwise approach. And for me, one of the best bits about this was the concept of the engaged and non-engaging patient. Because, correct me if I'm wrong, but for decades now, I've seen it. When I was a general dentist in practice, you'd think, oh, perio patient, right. And you just start doing your thing because you're a dentist and you've got to do stuff to get paid, and it's all about, and you didn't do any of the behaviour change stuff. The S3 guidelines and the concept of the engaging and non-engaging patients has put the patient back at the start of the journey, and it's made us realise or remember that they need to do more before our treatments can have an impact. What is the point of us doing our treatment in a non-engaging patient when we understand the etiology that we've just been talking about a minute ago? And so we have to be careful with this concept, because this could be abused. If you are a non-engaging clinician, Mrs. Jones comes in, she's got perio, and you go, your gums are bad, you need to brush more, see you next week. If that's your idea of engagement, and Mrs. Jones comes back and nothing's changed, and you go, oh, non-engaging, not having treatment. No, she's not non-engaging. You've not engaged her. There is an ethical quandary with this. When we talk about this, this is about you making an effort, the patient's not responding, and then we can start to think about pigeonholing those patients. At the end of the day, we've got a patient with a disease and we've got some solutions, but only if they buy in. We want these patients to have care. We're not trying to withhold treatment from a population. We just want to have the most impact. So the concept, as I'm sure you already know, and we'll reinforce this after coffee, is that you are a non-engaging patient if you can't get your plaque score below half of its original score. So patient walks in, swampy mouth, 100% plaque control or plaque uncontrol, and they can't get it below 50%. That's not a big ask, is it? For most people who walk in not at 100% plaque, well, we're trying to get them to a sort of reasonable target level of a plaque score of below 20% and a bleeding score below 30%. If they can't do that, that's still not a great mouth in terms of effort and hygiene. Well, that patient's a non-engaging patient. And then we have a third category, which is what the patients I call a CBA patient, the can't be arsed patient. The patient you say, you've got gum disease, you're losing bone, your teeth are getting a bit wobbly, they're going to fall out, you're going to need a denture, and they go, all right, can't be arsed. Yeah, you've got to use this brush here. No, can't be bothered, not for me. Can't wait to have a denture. My mum loved dentures. Right, that patient is a non-engaging patient. They equally don't then get all of the clinical intervention that you would give to a patient who goes, oh my God, I've got gum disease. What can I do to help? Tell me what I need to do. They're two totally different patients. Same disease, totally different outcomes, and we have to make sure we manage that outcome. The documentation of this needs to be very careful if you are going to withhold treatment from patients. My understanding is this is not quite written into your SDR, but we'll talk about where some of these things fit in as we go through. You are an engaging patient if you can shift the plaque score by over 50%. Now, again, don't get me wrong. If someone comes in at 100 and gets to 45, I'm going to open the doors as like starting treatment because I don't want to demoralise the effort they've made. They're still miles off where they need to be, and we're going to keep chipping away at that. For most patients, we're trying to get them below that 20% figure, and for me, that's still too high, and I'm trying to get that even lower still. But these are national level guidelines. And then we have patients who may never hit this level, and it's through no fault of their own. It's because maybe they have, I don't know, arthritic hands. I have a patient who literally brushes his teeth. His hands don't work. He brushes his teeth with a brush between two hands, and he cleans like this. And his oral hygiene is really good. And when people say, well, I can't brush properly, I just think of this guy with hands that his fingers don't bend, and he produces a really good standard of oral hygiene. And one of our hygienists tells a story, her cleanest patient is a blind patient. So when patients go, oh, I can't do it, oh, I can't see where that goes, Helen just goes, I've got a blind patient who cleans better than you. It's got nothing to do with what you can see. You just need to wise up and make more of an effort. But if a patient can't achieve these goals, you set them a personal target. It might be learning difficulties. It might be, educational problems. It could be any reason. You set them a target, they hit it, we open the floodgates to provide treatment. We want patients to have the care that they need. This is not supposed to be a barrier. Now, hopefully that makes sense, but it's also hopefully not new news. I've been teaching with a teaching company, Perio courses. Some of you are old enough to remember Phil Hour, who I know lectured on this stage, although it was much smaller when Phil was here. I was a delegate on Phil Hour's course back in 2002. I was an NHS GDP. I had essentially lost my way in practice. I qualified in 1998. I was a keen young dentist. I went on loads of courses, occlusion, endo, veneers, all like this, just stuff that was like sexy. And did I do perio? No, we had a hygienist who did that. I didn't really need to know about that. I was part of the exam S&P generation. And many dentists in the room will remember that. My notes would be exam S&P, whether it was an S&P or whether they had rampant perio, exam S&P. Do you remember it? URQ, UR6, MOD, AF, LA. And people would go, Ian, stop writing such comprehensive notes. You students are there like that, writing War and Peace. Can I have another piece of paper? And it's like, for one amalgam. I mean, there's a balance that we need to achieve. But in 2002, I actually felt quite vulnerable. I thought, you know what? I don't really understand perio. None of what I'm doing is working. I'm going to get sued here. I'm going to go on a course. And I went on Phil Hour and Graham Smart's perio course. It was a 4-day program at Aintree Hospital in Liverpool. And they put this slide up. And this was their teaching philosophy in 2002, and it had been their teaching philosophy way before that time. They'd been teaching this for over 30 years. And if you look at it, this is the Perio course's phased approach to care. Phase 1, risk factor management, oral hygiene instruction, and that patient is kept in a cyclical loop until their oral hygiene is optimised. Optimised was never defined. It was just Phil and Graham saying, I want the patients to be doing more. The patients then go into a non-surgical phase. We'll talk about non-surgical phases later. There's a reassessment phase. There's an advanced phase of maybe adjunctive therapies and surgery. And then there's a supportive care phase. Now, correct me if I'm wrong, that feels awfully like the S3 guidelines, the new way to treat perio. It's not new. It's what we've been doing for the last 25 years. There's very rarely anything new in perio. It's got a new set of pajamas on it. We've now got this sort of stepwise approach to care, but the basics that were always right are still right. What we've done is we put the patient back at the start of the journey, and that, to me, is a really important message that I need you to take away for the rest of the day. Perio is, we said it's a complex disease, but I also said it's a very simple disease to treat when everyone does all the basics right. When I used to teach at undergraduate level, the students would come to see me and they go, oh, Mr. Dunn, we've got patients in. Can you come and have a look? I go, yeah, tell me about the patient. Oh, he's 54. You're going to be excited, Mr. Dunn. He's a perio patient. Oh, brilliant. Great. I know a bit about that. I'd say, where are you up to with your treatment? And they'd go, going to do some scaling. I'm like, right, okay. But where are you? What are you? First phase of treatment? Are you in supportive? I'm going to do some scaling, Mr. Dunn. And it was like, can you stop asking me difficult questions? Because I just want to do some scaling. But we overcomplicated it at dental school. Your patient, Perio's got a 4-phased approach, dead simple. Your patients walk into your clinic, new patient, and you screen patients. And we'll talk about this very briefly. We're not going to get into that in any detail. But you screen every patient. When you identify certain, didn't think that was going to be an issue, you now have to do a more formalised assessment. And that assessment includes special tests that might include x-rays, pocket charts, vitality tests, depending on the case that's in front of you. And then you move into treatment, and then you move into monitoring and maintenance. And your patient will be somewhere in that process at any point in their journey. What I can't stress enough, and I think new graduates are very good at this, is that we don't go from assessment to treatment without a diagnosis. You should never treat anything that hasn't had a formal diagnosis. I see clinical records where people talk about BP4, red swollen gums, puffy gums, gums bleeding. I don't see the word periodontitis. And the lawyers will use that against you because you haven't diagnosed the disease. You've described the gingival quality, but you haven't made a diagnosis. The disease is periodontitis. One of the criticisms I have of the SDR is it seems to be based around BPE codes and not a diagnosis. And I'd like to think that we can influence that and maybe talk about that away from this meeting. Because the BPE is not diagnostic, is it? It is literally just didn't expect that. And that's what we do the BPE for. It's not to allow us to then formulate a treatment plan. It's a non-diagnostic tool. So, and undergraduates, if you get to a position where you don't understand what's going on and you're not sure, we have the option of a differential diagnosis. That's okay. You don't have to know everything all of the time, but you've at least got to have on paper what you think is happening so that your treatment then looks rational compared to the decisions you've made off your special tests. You are screening, as we know, for 3 states. Health, that unicorn patient, pristine gingival health, no bleeding, nothing. Not that common. Gingivitis, ridiculously common. Or periodontitis, pretty common. Yeah, depending on where you work and your socioeconomic background with your practice. This could be every patient that walks into your room. It could be every other patient. We believe on average, if we take a cohort of patients 18 to 80, about 50% of them will have periodontal disease, some level of bone loss. 83% of over 65-year-olds will have some radiographic bone loss. They are perio patients. The BPE is so simple, people massively overthink it. Every patient, every exam. What age do we start doing it? The minute you've got an adult developing dentition. My youngest patient currently is 15. There's no visible inflammation. She's medically fit and well. she's going to lose her lower second premolars by the time she's been referred to me. And there's nothing that you could see about her mouth that you think, well, it's occlusion or it's plaque control. She's got one of the most aggressive perios I've ever seen. And you look at her and she looks clinically healthy. I'll show you a similar case in a minute because she didn't consent for photos. It should be done by every diagnosing clinician. So the dentist or the diagnosing clinician. If you're a hygienist or therapist working in direct access that we've now had for 13 years, which I do believe is a good thing, you are then responsible for the screening and then the onward diagnosis and any referral that's outside of your scope, which is why it's there. But if you are working in a traditional environment, dentists, I would argue that you should be doing this because it is a pre-diagnostic screen. It triggers some special tests, and then the special tests, together with the information you've got, then lead to a diagnosis. And you are the diagnostician in that scenario. The BP is redundant once you've diagnosed perio because it's a screening tool. So once you've diagnosed it, why are you still doing it? You know, if you do it, that's fine. No one gets into trouble, but it's extra that you don't need to do. We monitor perio with pocket charts. We don't monitor it with a BPE, regardless of how much whether we like that or not. There were some big ticket things that came out when we revisited this. It says 2019. That's only because that was the year the classification came out and we had to mention the classification. This document is 10 years old. 2016 was the last time it was revised. And the BSP have said very clearly that we need x-rays for all BPs code 3 and 4s. So new patient walks into your practice, we need to take x-rays. We'll look at where that fits in the SDR as well. It doesn't tell us what we need to take, but we do need x-rays that show bone levels. If you have mild to moderate disease, BP code 3s and 4s, and your bite wings show bone levels, that is sufficient. Nobody is telling you that you need to do full mouth periapical series. But if you have those BPs, 3s and 4s, and you can't see bone levels, you can justify further x-rays because the lawyers will say you didn't know where the bone was on that tooth, you had no idea what was going on with that case, and therefore we've now got a weakness in our defence. I think ALARA has pushed us towards being scared to take a couple of additional x-rays. And I think in the UK, we actually under x-ray our new patients because we're worried, oh, I might get into trouble. Trust me, you get into trouble for not having enough x-rays to justify what you're looking at and what you're trying to treat. We've then got the boring stuff, pocket charts for all BPs code 4. When would you not do a pocket chart and a BP code 4? When you've got a reason that BP4 is not perio. So what? Vertical root fracture, endoperio lesion, some sort of weird impaction. You know, if you've got a BP code 4 and there's another reason, tell me in your notes, and then we'll understand in 5 or 10 years' time when your notes are being looked at why you didn't do the BP that was recommended. But most of the time, let's be honest, a BP code 4 is probably going to be perio, but we don't know because we can't diagnose off a BPE. I think useful things that came out, you will only have to record pockets 4 millimeters or greater. So we all hate doing pocket charts. That does allow you to be a little bit quicker. You probe every site, you only shout out the 4 millimeter pockets. Why? Because we know that pockets that are over 4 millimeters are less likely to be maintained by patients, and therefore they're the pockets that we care about and we worry about in terms of deterioration, or there are sites that need treatment. For the first time ever, the BSP said that we need to record bleeding on probing. If I could measure one thing in perio and only one parameter, it would be BOP and not pockets. I would rather have a 6 millimeter non-bleeding pocket than a 4 millimeter bleeding pocket because bleeding represents a risk for disease. It's showing inflammation at the site. This patient's got inflammatory level disease. And a 6 millimeter pocket that's not bleeding potentially may be stable, and we'll look at that statement later on. And so for me, BOP is a driver of what we do next, and the cases we monitor, we treat, we intervene. Obviously, the qualifying point with that is in a non-smoker. We don't monitor with BPEs, despite what some people do, and we don't use BPEs around implants because we will overreact. Implants might have a slightly deeper sulcus depth, so the implant is monitored rather than screened, if that makes sense. I'm reminding you why we do the BPE. You know, let's be dead honest. You don't need a BPE to know that 90% of the patients in your chair are perio patients. Often, as the patient's walking towards you from reception, you're thinking, 444 4434. I mean, I joke, but I don't joke because, you know, almost seems like a waste of time. You might as well think, let's just get some x-rays and go straight to pocket charts. Do you know what I mean? You don't need a BPE to go, oh, might this be perio? Let's check. Because that is, you know, pretty obvious. This girl, she's 21. She is Chinese. I'll explain the relevance of that in a minute. The only real alarm bell that I would say rings is the loss of the lower interdental papilla. Because we see recession, the recession on the laterals could be a dehiscence, couldn't it? Thinner phenotype, slight proclination. That might just be a localized dehiscence rather than perio. And she's 21, she's got a clean mouth, she's got no visible inflammation, and you think, oh, well, I'm running behind, I'm going to save myself 11 seconds and help myself catch up, get my butties quicker. No, this is why we do the BPE, because this patient is that patient. So, you know, the risk of getting sloppy with your BPE and not doing it in every patient at every exam, and even in the youngsters, is that you miss these patients, the less obvious ones, the ones that don't look like perio. That's what the BPE's been designed for, not for the obvious patients. It's a quick screening tool for you to not miss stuff. That's what the BPE is. And I think people overthink it and overcomplicate it, and then people also then don't do it. And medico-legally, trust me, these are the ones that pay out big, really big. The biggest case I've seen that I've been involved, not involved with, but I was treating the patient, she won over £400,000. It was a perio-ortho case. No one had done any screening. No one had done any monitoring. The orthodontist got in trouble. The general dentist got into trouble. £400,000. Trust me, you would not swap that money for her mouth. When the BPE was republished in 2016, the BSP got a little bit of criticism. People said, why can't you be a bit clearer with your, you know, this code means this and that code means that? You don't want that in a guideline. You don't want something that's prescriptive, because the minute you don't do it, you're now negligent. And then the lawyers have got it's a clear, did you do it? No, right, you go to jail. Do not pass go, do not collect £200. And so it's deliberate. The wording is deliberate. We want wiggle room. We want clinical interpretation. You are autonomous clinicians that have to be allowed to make decisions on the here and now. And so the BPE document talks about this. The clinician needs to use their skill, knowledge and judgment when interpreting BPE scores, taking into account factors that are unique to each patient. The most important line. Deviation from these guidelines may be appropriate in individual cases, for example, where there is a lack of patient engagement. So we can deviate from the guidelines. BPE code 4, do this, do that, do this, do this. You know, if we've got a reason to. But then if you're going to deviate from guidelines, I need to see that in your notes. 6-point pocket chart, delayed due to poor plaque control, delayed due to gross calculus deposits, delayed due to gingival inflammation. Tell me that you know that you were going to do it. I'm just not doing it now, and I'm going to defer it. That's a perfectly medico-legally acceptable thing to do. Now, in a way, looking at your SDR, this is quite nice, because we've got this, this sort of oral health examination and diagnosis bit. It's the only bit where I could find the word diagnosis, that title. I'd like to see that word a bit more when we start talking about treatment, but we'll come back to that. Nowhere in there does it say at that first point that you've got to do all that big data capture. It talks about, you know, looking at plaque control, looking at all the soft tissue, all the things that we do as part of an exam. But actually, it's quite nice that this is not asking you to do any more detailed capture. So you, at this point, will have done your BPE, you'll be making this claim. You'll also hopefully be taking your x-rays to be able to confirm your diagnosis. And you will have your provisional diagnosis, a working diagnosis of periodontal disease that can move the patient into a pathway. You have deferred your pocket chart to a later date, and you've justified why you've deferred that pocket chart. If we just quickly talk about radiography, I've said already, we need x-rays that show bone levels. And people sometimes say to me, what's the point in taking x-rays of a BP3 here? It's not going to change what I'm going to do next. Well, if you believe that, justify that in your clinical records. I can't imagine a scenario where you've got a BP code 4 anywhere and you don't take an x-ray that shows bone levels, because you've got no idea what's going on. And people say, well, it won't change what you're going to do. I'm going to just do oral hygiene instruction. I'm going to do some debridement. Yeah, but What if it's an endoperio lesion? What if it's a vertical root fracture? What if there's a vertical bone defect and you're thinking, oh, maybe this patient's got aggressive disease rather than chronic disease? What if the bone loss is to the apex and you don't know that and you've told the patient everything's going to be fine, Mrs. Jones? The x-rays really inform your moving forwards. And actually, the most motivating part of my appointments, I find, is me with the patient showing them where the bone should be, where it is, and how little is left on some of these teeth. That, for me, is the real sort of moment where the patient goes, right, oh God, I get it. The x-ray for me is a huge part of the disease education rather than just my diagnostic bit. In terms of frequency, there is no preset time when we then re-x-ray patients from a perio perspective. Unlike caries, where we actually do screening x-rays for caries, 1 year, 2 years, 3 years, whatever it may be, depending on the risk profile, in perio, the disease is too slow, it's too subtle, and it's too vulnerable to a poor x-ray. The minute you angulate the x-ray one way or another, your root length changes, your bone levels look different. You can change the prognosis for a tooth by taking a rubbish x-ray. You know, I joke, you want to see some of the stuff we get on referral. And so it's too subtle to monitor a perio patient. We monitor with pocket charts whether we like it or not. And so there is no preset time, 2 years, 5 years, 10 years. Your x-ray needs to inform your clinical decision. So I could have a patient who comes in, new patient consult, we take their x-rays, we diagnose their disease, we put them through treatment, we get them to stability. And I'm seeing them once a year for their annual reviews. And if those pockets are shallow, not bleeding, I have no need to take an x-ray. If that patient walks in and I've got a couple of deep bleeding sites, that site is going to be re-x-rayed because that is going to inform how I'm going to manage the case. I've got a problem that needs a diagnosis, that needs a treatment plan. And the only other time would be maybe if I'm making restorative decisions a year, 2 years after the baseline, and I'm thinking, right, now we're stable, we're thinking about maybe doing some ortho or crowns or whatever, I might re-x-ray the patient then. But it's not for periodontal parameters in stable patients. And hopefully that makes sense because it fits nicely with a LARA. I think just going back to this, and it goes back to the sort of the SDR bit, you've got to have that formalised diagnosis before you move to treatments. I cannot stress that enough. One of the things we're not going to get into today is staging and grading and how to make a diagnosis. We are thankfully now working with a generation of undergraduates who are coming through who don't even know it's a new classification. For them, it's the classification. A bit like for us, there's mobile phones and there's phones, isn't there? Yeah, and like my kids don't know what a phone is. They just, everything's mobile phone. Yeah, and our new graduates, that they don't know the old localized, juvenile, rapidly progressive, remember all that stuff? You had a birthday and you changed your diagnosis. Then we moved on to chronic and aggressive, a system that I quite liked. And now we've got staging and grading. It's old news. It's not a new system. No, in our lot, we'll probably change it in the next 2 or 3 years and we'll have another new system. So we're not going to get into that. But please, please, please be working to a formalized diagnosis because without it, you are medically legally vulnerable and you don't know what you're doing and what you're treating without it. I'm going to just very quickly start this bit, and then we'll go for coffee. We're going to take questions at the end, just before lunch, unless there's a burning question that someone's got from this morning. I don't mind taking a couple of questions, but there's probably not a lot of questions to come up from this section, but we'll see. I've said to you that we've got the patients at the start of the journey back again, and it's less about us and it's more about them. Now, the reason why I think that's such a good thing is that, well, one, without it, our treatment doesn't work unless the patient's changing their behaviour. Two, the more the patient does, the less we do. And, you know, for you guys in a practice environment, if you've got a financially restricted cap, if you can do less time in the chair for the same payment, ethically, that's got to be a good thing, hasn't it? That's got to be an efficient way for you to manage perio. And what I see with a lot of practices is that this sort of step one, this oral hygiene phase, is not as thoroughly done as it could be. And if you focused a bit more on this bit, when you get to your bit, you'll have a lot less to do and you're going to get paid the same. And it's all and it's going to work, and then it's going to last, and then you can do your fancy posh composite bonding and Invisalign and whatever other things you get up to. But it's going to work and it's going to be more efficient. And you know, I know you'd all love to change the remuneration and be paid hundreds of pounds for this, and that's not going to happen. We know we've got a restricted budget, and so the funds that you've got to try and find the most efficient way to manage perio. And the first part of that is doing a proper step one. Because step one is as powerful as step two, your treatment.
Yeah.
Would you say 10,000?
Don't know where that sound's come from. I love that. So, step one of care probably fits into your 2A. Your patient's been diagnosed, and I've talked to a few different practitioners in the last week or so who have sort of got their head around this system. 2A is sort of what I understand that people wanted to be their step one. It's not so much about loads of intervention, but it is a bit of an oral hygiene phase, patient's education. It's not a huge amount of money, but equally this could be delivered by anyone in your team who's got the appropriate qualifications. So even an oral health educator can do probably 90% of this, apart from the what you and I would call a gross scale or the super gingival PMPR. I know some practitioners I've spoken to who are bypassing this and going straight to a 2C, and they're getting on with their treatment because they want to get on with stuff. And again, one of the things that I would hope to see from the SDR and the people behind it is that we will get some clarity documents. So in England, we have obviously the wonderful UDA system, that perfect system. Let's not go there. But the one thing we have got is a document called the Avoidance of Doubt document. The BSP work very closely with the Department of Health, and they produced literally a hand-holding document on how you can claim, what you can claim, and it was just to give clarity. And it's not perfect, but actually there is a system, there's a pathway. And then no one's going to get into trouble for over-claiming. And equally, those very ethical people who worry, oh, if I claim that, I might get into trouble, but then you underclaim and you shoot yourself in the foot, that's where we need clarity. And that's what I would really like to see from the SDR people and people behind it. And I'm sure the BSP would help with that if we can do. Because a clarity document would be good. And the more I've read your document, the more I believe it lends itself to a very simple a sort of flowchart approach to how and what you can claim. So we'll see if that can come off the back of this. I'm not going to get into rules. That's not my job. I'm going to just very quickly talk about this, and then we'll talk about how we get this into patients. So I said to you a minute ago that an oral hygiene phase is as powerful as a treatment phase. That's a really big statement. So you can do 3 hours of root planing, or a patient can clean better at home, and you're going to achieve roughly the same. Big statement. So, is there anyone in the room who disagrees with this relatively modern, contemporary, 10-year-old-ish statement? The most important factor in the prevention and treatment of periodontal disease is the individual standard of daily self-performed oral hygiene. That's a no-brainer, isn't it? We're all on the same page. If we go back 100 years to the Dental Cosmos, this is the American Dental Journal. I'd have kept that title. Dental Cosmos is much more attractive. Stillman, who many of you will have heard of, Stillman was a very eminent writer of his time. Stillman's clefts, some of you will have heard of Stillman's clefts. Stillman said, the patient must be taught in detail the duty that devolves upon him to maintain a hygienic mouth. Patients who exhibit a sustained indifference in this matter are of no interest to my practice, and I politely dismiss them. S3 guidelines. It is, though. Stillman is acknowledging that I can help you, but only if you help yourself first. And if you don't, I'm not interested. That is S3 guidelines. And in the last 100 years, it became all about, somewhere we got lost. Stillman knew it, and we got lost because it became all about us. We became the best scalers and root planes. We were like scraping all that stuff out. It's all about me. Look how good I am as a clinician. You know, some of you who qualified before me will have done very surgically aggressive treatments as undergraduates. Big gingivectomies, undergraduates doing perio surgery. Imagine that, undergraduates, wherever you are. They're all thinking, give us a go. But, you know, it was very aggressive, all about me treatment. Then the 90s came and it became all about antibiotics and bits of cow's toenail with chlorhexidine shoved into pockets and gels and lotions and potion. And we had that chemical phase. And each phase that we've gone through forgot about the patient. And the patient bit is as powerful as your bit. Prius did a study. He took a group of patients, 44 patients, who've all got severe disease, and he splits them into 2 groups. He has a control group who get no intervention whatsoever, and he has a test group who get a 3-month phase of oral hygiene instruction, detailed, multiple appointments, and everything you can imagine that periodontists measure, Prius measured. Pocket depth, bleeding on probing, clinical attachment level, all of this stuff. And at 3 months, he closes the study. Don't worry what the table says, it's a Friday, we're not here to look at tables. What the study told us was that the effects of the oral hygiene phase in the test group, you'd expect a significant reduction in plaque because they've had tailored, individualised oral hygiene. So that's a no-brainer. Their BOP average reduction was 30%. Now, imagine that. Your patient comes in with, like, I don't know, a 40% BOP score, and they get it down below 10% with home care. Well, we know that when they get below 10%, especially if their pockets shrink with it, that now we can start talking about stability. And they're doing this at home, in the bathroom with a brush that costs a couple of quid, and not as part of your treatment intervention. Their pocket depth reduction on average was about 1.6 millimetres. You haven't even touched them yet, and they are reducing their BOP by 30%, and they're reducing their pockets by 1.5 millimetres, even a little bit more. Now, you might be thinking, that's not that impressive. There's a study by a chap called Cobb. Cobb looked at what happens before and after old school scaling and root planing. I mean like proper, the proper's 3 hours. We know that the average pocket depth change for 3 hours of root planing in a deep pocket is about 2.1 millimetres. And these guys are doing it at home in the bathroom with a brush that costs a few quid. This is the point I'm trying to get at. If you want to be efficient, focus your time on this, and then when you get to your 2Cs, you'll have a lot less to do. I'm going to show you. In fact, I'm going to show you now. This patient, she's 63. She's nervous. She hasn't been to the dentist in about 15 years, and she goes to her general practice, who immediately refer her in to specialist care, partly because she's difficult to manage, her phobia and everything else. Now, I know in dental school, back in my day, I'd have been thinking, get in. That's a juicy perio case. I'd have been numbing them up. I'd be rolling my sleeves up. We'd be getting in there. There'd be bits of gingiva hanging off because it's all friable and delicate. My nurse would look like a scene from Pulp Fiction. There'd be blood everywhere. And it would just be a bloodbath. And the patient would leave. They'd probably be in agony when the numbness wore off. You'd be thinking, oh, that was brilliant. As you're wiping the blood off your face. And 3 months later, the patient got better, and you're thinking, oh, I'm brilliant. Look at me, I'm great. Well, Phil and Graham, the guys who taught me back in 2002 when I was that lost NHS GDP, their attitude was, then get the patient doing more. So imagine this patient comes in to you in your NHS practice. You know, you've got a lot of work to do for not a lot of money as part of your SDR. But we said to this patient, look, you do more. And then and for her, the motivation was, the more you do, the less we do. And she's like, well, I hate dentists. Hate hygienists even more, but I hate dentists. And so we said, great, we're trying to do as little as possible. You go away and work harder. We showed her how to clean better. And admittedly, S3 guidelines, if I go back a slide, S3 guidelines would say a gross PMPR, a supragingival blast to facilitate easier plaque control. Totally accept that, no problem. And actually, because my approach might feel a bit ivory towered, and I do get that, for you guys, if you can have that appointment where you do that really front-loaded oral hygiene, but then you can do that gross scale, at least the patient feels like they've had something done. The Phil and Graham approach, and my approach for the last 15 years or more, 20 years, was that the minute I touch the patient, they're going to attribute the gains that they see to my intervention. And I want to promote the patient belief that they have some power in this situation. It's called an internal or external locus of control. It's a behavioural psychology theory. So I want her to know that even before I touch her, she can make a difference. So she goes away with all sorts of brushes and gadgets and gizmos, and we ask her to come back at 6 weeks for an oral hygiene review. Looks pretty spicy, doesn't it? Looks pretty serious. Some of you might think, oh, there's an oral med condition going on here. She was medically fit and well. We just felt it was a plaque-induced hyperplasia superimposed on top of a periodontitis. At 6 weeks, she comes back looking like this. Now, that's pretty cool in the gang stuff, isn't it? Because she's achieved that at home in the bathroom. Now, if you'd have achieved that with that bloodbath appointment, you'd be thinking, blimey, I am practically Ian Chappell. I probably should be the professor of something somewhere because I'm amazing. And yet, it's all about the patient. What have we talked about this morning? We've talked about the patient disturbing biofilm. And as she's reduced both their plaque volume but also disturbed that biofilm, she's having a down-regulation of her inflammatory response. This is incredibly powerful. Students, how often does it happen to you on the clinic? You get your tutor over and they go, missed a bit. And then they walk off. And then you go, so what do you do then? Pick up your scaler and then you've no idea what you're scaling because you couldn't find it, but someone found it. And then you get them back over and then they go, much better. And then they leave. Students, are you nodding? I'm just checking. Yeah, okay. Because we've taught you that calculus is the be-all and end-all, haven't we? And we've taught you that when I was at Leeds in the late 90s, Margaret Keller, wonderful lady, Mr. Dunn, that is not glassy smooth. That is not glassy smooth. I can feel, it feels like a cobbled street. I want it as smooth as a billiard ball. That's what I'm after. And I would root playing the living daylights out of my patients because that was the way we were being taught. It had to have that glassy smooth surface. What does this tell you about that? It tells you that calculus is not the be-all and end-all. It's the stagnating biofilm that triggers that upregulates the endotoxin production, that triggers the inflammation, that then does the damage. And the minute you disturb the biofilm, you downregulate endotoxin production, the body then responds with switching off the inflammation. This now allows us to do a lot less aggressive treatment, and that's where we're going to go after the break. We're going to develop this a little bit more in a minute. In fact, I'm going to actually have the break here. I think it's a nice sort of thought point for you to leave with at this point going into your coffee break. And also, that you just think, I could do some biscuits or something, you know. We have got probably 2 or 3 minutes if you want to do a question. I don't mind. Has anyone got a burning question that's come up so far? I mean, so far it's been a bit, not much to ask, but anyone? If not, there is a stampede to the coffee. Please go and visit the trade. These events can't happen without the trade.
And please if we can all be back in here for 20 past. And Ian, there's a few of us sitting down there with red faces, guilty as charged regarding the calculus and the students.
We've all done it. We've all done it.
Right, so 20 past, everyone. Thank you.
all going? Good morning. How are we all doing? Come on, hurry up, take your seats. Shift. Right, guys, those of you that know me know that I'm quite involved with VT in Scotland, so it's an honour to be asked to come up here and to present the prize for the VT case presentations. As you'll all know, the culmination of the VT year is when the VDPs all come and present a case of their completed clinical work over the course of the year. What happens is that the trainers and the advisor from each scheme pick the best presentation from each scheme. These are then passed to Mr. Robbie Thompson, Director of CGDent Scotland, and Billy Cameron, wherever Billy is, who's the Assistant Dean for VT, and they pick the overall winner. So, I just want to say that these guys take this stuff seriously. There's a lot of work that goes into it all. So to be chosen as the scheme best really is an achievement. So I hope you're going to show these guys the respect that they've earned. Okay. So, scheme winners, we have Rory Burns. Andrew L. Milligie. Georgie French. Patricia Fu. Niamh McInnes. Hannah Milner. The audience there. Christy Fee. Sorry, these guys should have stood right behind me when I'm trying to present. I'm not looking at you guys. So our top three. In third place, we have Anna-Marie Strowich. Congratulations, well done. Get a photo. In second place, we have Vivian McCange. Photo.
Oh, sorry.
So that means that our first place winner is Karen McLeod. Excellent. Okay. So thanks very much for everyone for coming up today. We've got prizes for the first three places as well, which I'll give you in a wee second. And I'd like to welcome back to the stage our speaker for the morning, Mr. Ian Dunn. Yep.
At least you'll not know how scary it is to be up here looking at that lot. Congratulations to the winners. Not really thought about what I'm going to say next about that, but one thing, there's a lot of negativity in our profession, don't you think? A lot of moaning, a lot of dentistry's rubbish, everything's garbage. All I'll say to the youngsters is you get out of this profession what you put into it, and the more you commit, the more you do, the more you strive to be the type of dentist you want to be, hygienist, therapist, and push yourself, the better your career is. You can sit and moan, or you can go and get the career you want, because you literally get to pick with this job. It's one of the beauties. You can work 2 days, 5 days, 10 days. You can choose which diplomas, MScs you do. You know, design your own careers and don't listen to the moaning, because it's a great career. I'll get off my soapbox now and start talking about something I do know something about. So we're back to gums, and we're back to our friend here who achieved quite remarkable things in a 6-week period at home in the bathroom with a toothbrush and some incidental aids. And we said to her, look at what you've achieved. I've not even touched you yet, and you're already making an impact on this disease. How do we do that? We use photography. I appreciate in busy NHS practice, you may not have fancy cameras and all the time in the world. There'll be very few patients who haven't got a camera phone in their pocket. And even if you say to the patient, have you got a camera phone? Right, don't delete that photo. I'll see you in a couple of weeks. Have a look at that. Have a look at the difference you've made. Yes, you'd rather have it part of your clinical records, but equally, anything you can do that motivates a patient, and photography, really, that tells a huge story, doesn't it, to the patient that they have achieved this, not me. We said to her, well done, you're engaged, go to reception, book in for your treatment. We are now going to help you get the bits that you can't get. And she said, I think I can do more. And she basically was saying, I really don't want that treatment with that big, sharp, sticky thing that you've got. And so we said, well, off you go, have another few weeks. And she goes away, she has another 6 weeks. Because let's face it, this is a slow disease, isn't it? Unless you're dealing with those young patients with aggressive disease, this is a slow condition. A few weeks will make no difference to her treatment outcomes. So there is no problem giving her that little bit of extra time. And people are so quick to review these oral hygiene phases. And actually, the longer they're in this hygiene phase, the bigger the impact, the less you're going to have to do. And, where are we? Here. What's that big lump of black stuff there? Subgingival calculus, isn't it? The stuff that on clinics we were telling you, you've missed a bit, and you can't treat disease unless you've got rid of all the calculus. These pockets are healing in spite of that calculus. They're not responding because of it. And it's going to develop where we're going to go next with our treatment discussion, because some of the dogma that's around some of the more traditional perio treatments really needs to be put to bed. Because this is starting to reinforce the point I've made this morning about actually what causes the disease, and it's not the calculus. One of the hardest things that we have in perio is getting patients to change their behaviour. I mean, that's just in life, isn't it? We all do things that we shouldn't do, that we do because we like doing them. Eating too many chips, having two glasses of wine too many, not going to the gym as often as we should. We know what we should be doing, and we don't always do it, and it takes discipline, and that's the hardest part of this journey. Now, I don't want to stand here as a specialist periodontist talking to a room full of general practitioners, hygienists, therapists and students and say, I can motivate every single patient, because that would be disingenuous. I know that my patients are a self-selecting group who choose to seek out my care, and they're paying for that, and they're choosing to travel. That straight away gets rid of a lot of those CBA patients that you see, the can't be arsed patients. Yeah. And so the tips that we're going to go through now are really aimed at those patients who do want to try and save their teeth and motivating them to do more. You will have patients who do not care enough about their teeth to do half of the things they need to do, and those patients are non-engaging patients who go into palliative care. But the patients I see come from practices like yours. So it's sort of not pigeonholing all patients as, well, no one ever does anything, no one ever tries. When you get that little nugget of a patient who wants to save their teeth, this is where this advice can be useful. The most important thing I need, if I'm trying to get a patient to do more, is I need an emotional tie-in. What do I mean by that? I need something that they care about enough that I can use with them, against them, for them, to get them to raise their bar. So one of the most important questions I ask at my consultations, tell me why you're here, what are your hopes and fears about your teeth, where is it you want to be in 5 years' time? And then I can't stress this enough, especially to the undergraduates, if you ask a question, shut up and listen to the answer, because we're too busy talking sometimes to not listen. And so you ask those questions. What are your hopes and fears? What do you care about? Where do you want to be in 5 years' time? Because what I need to hear is, well, my son's getting married next year, and I want Invisalign for my son's wedding, and I've been told I can't have it because I've got unstable gum problems. Great. I've got you. Brilliant. I've got you. I've got something I can use. I want veneers. I want composite bonding, but I've been told I can't have composite bonding until I have my gum health. So great, brilliant. I wake up in the morning and I've got blood on my pillow and it's really disconcerting and I've got a new boyfriend and I don't want blood on my pillow. Great. I've got something to use that you care about. My mum went to a nursing home and she's got a denture and they kept losing their dentures and I don't want to be that person. I want to go to the nursing home with my teeth. Brilliant, I've got you. Because everything I now deliver is going to be about that and not about what I want. And the behavioural psychology on this is really quite strong. Information that's perceived to be relevant to the patient is received better than generically given, or information they feel is generic. Every single one of your patients will go to your appointment, and some of them will then leave that appointment and go to the pub. Given that they're in Scotland, probably a lot of them. I got to Edinburgh last week, true story, and we got there a bit early, and I had to go somewhere in a taxi, and the guy said, "Oh, what are you doing in Edinburgh?" I said, "Oh, I'm here on business, I'm lecturing at a conference." And he said, "When are you lecturing?" I said, "Not until tomorrow." He said, "Oh, am I dropping you at the pub then?" Could do, I've got a few things to do though. But I just thought, when in Scotland. I had a similar experience in Belfast, and if you come to Liverpool, it'll be no different, trust me. We're peas in a pod. Anyway, some of your patients are going to go to the pub. They'll get chatting, and they'll say, "What have you done today?" "Oh, I've been to see the dentist." "Oh, yeah, I went to the dentist. Which one do you go to?" "Oh, I'll go to John McGovern down the road." "Oh, right, what did he say?" "He said I need to brush more, I should floss, and I should not smoke." And they go, "Oh, yeah, he said that to me as well." "And do you want a cigarette?" "Yeah, let's go have a cigarette." And because it's generic, all your patients expect to hear, "Don't eat sweets, brush and floss." That's what they expect to hear. When you deliver that same information, Mrs. Jones, you were telling me that you want Invisalign for your son's wedding. That's why you've got to do all this difficult stuff, because without that, because I've explained the disease here, you understand how it works. Without that, you're not going to get what you want. So the sooner you start that, the better. Information that's given that's perceived to be relevant to the patient's values is received more favourably. The next part of the list comes from a behavioural psychology lecture, my first ever BSP conference in around about 2007, I think it was. And we listened to a lady called Lynn Myers. And a lot of these things I was already doing, but one or two of the things changed the way I practiced. And I've kept these things going. But the first thing is explain the disease in detail. Now, I'm conscious that you will be thinking, well, I haven't got a lot of time. I'm a busy GDP. The concept of the stepped approach and the concept of maybe that 2A appointment, or if you go straight to your 2Cs, they are asking you to do some at least patient education. Why will your patient change their behaviour just because you tell them to change their behaviour? Those of you who've got kids, I have an 18-year-old and a 23-year-old, but my 23-year-old lives in London. The 18-year-old still lives at home, sadly. And she is one of these like Instagram princesses. She goes out of the house looking $1 million, never goes anywhere without looking perfect. Her bedroom, well, she hasn't got a wardrobe, she has a floor drobe. It's a dump. And I would go into her room and I'd go, rah, 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 and I'd walk out and I'd get halfway down the stairs and I'd hear her just go, and nothing would ever change because she had no reason to change her behaviour. Because me shouting wasn't really the thing, which is like you shouting at your patients. Jasmine then passes her driving test. And now I can just walk in and go, "You can't have the car until..." And I walk out. And now she's got a reason to change their behaviour. Right, before you do, don't take patients' car keys off them if they don't brush their teeth. That's not something you can do. However, it makes the valid point, you have to have a reason to change behaviour, whatever that is. And so the patients have to understand the disease. I'm going to show you how I do that. There are loads of ways to do it, but I'll show you why I think my way is good, and you can decide for yourself. Lynn Myers said to us, she worked with non-compliant type 2 diabetic patients. And so she was working with a lifestyle-based disease. A lot of type 2 diabetes is lifestyle-led. And she said, is there anything you can do in your world that shows the patient the power of their own efforts? And I've just shown you a case that very clearly proves that if the patient does more, they will see clinical improvement. And it's giving that patient that that internal locus of control. I was chatting to someone in the coffee break, and they said, "Oh, that bit could do with being explained." In behavioural psychology, if you have an external locus of control, you don't believe that you can help the situation you're in. and you go to somebody and you go, fix me. And it's all about you fixing them. An internal locus of control is where you believe you can make a difference to this situation. It's not just health, it's other things. But in healthcare, we want an internal locus of control, a patient who believes, I need to do something and I can actually make a difference and they're going to help me because they're lovely, but I can make a difference. And that's what I showed in that previous case. So Lynn said, can you show them? Yes, we can. She then said, you need to make concrete plans. Now, this bit, I thought I was doing really well. I would sit with patients for multiple lengths of time, shove this here, there, shove that one there, blue one, purple one, grey one. See you in a couple of weeks. Lynn Myers told me that is unplanned behaviour change. You've provided oral hygiene instruction, but you've not planned when that behavioural event change is going to take place. And so that changed the way I practiced. And honestly, this takes no more than, it's less than a minute. After you've delivered your oral hygiene instruction, if you've got your emotional tie-in, you say to the patient, blue one there, yellow one here, when are you going to do this? And the patient goes, I don't know. I'll probably do it in the night time. I'm not sure. I'll do it. I go, no. Let's just have a minute. This is the most important part. This interdental stuff is the most important part of what you can control. And that's what's going to help you get those veneers for your son's wedding next year. The sooner you do this, the sooner you're going to get those veneers. When are you going to do this thing? And we physically plan with the patients. And I know it's a very, very touchy-feely thing, but it doesn't take long. I say, look, what about doing it first thing in the morning when you do your normal toothbrushing? Oh, well, I've got 6 kids and I've got 3 dogs and a cat. And that. I said, look, right, that's probably not the time then, is it? What about when you, I don't know, pick the kids up from school and you've fed them and you have a bit of quiet? Could you go to the bathroom then and make... Yeah, probably could do that. And we physically plan that behaviour change. I'm not going to stand there and tell you that all the patients come back and go, I'm doing it just when we agreed in, you're great. That's not what happens. What tends to happen is that some of them do it when we planned. Others will come back and they'll say, oh, do you know what? I'd come in from bathing, like walking the dog and I thought I'd do it then, but I'm covered in and I didn't want to. What I've found is, and I've already made them think that they've got a plan where this can fit. And they actually come back to me, the majority of them, with their own plan. You are trying to fast track them finding the thing that works for them in their world. And it's not going to be the same for every patient. And then you want to try and link it to something. You want a habit forming situation. It takes on average 66 days of doing something every day. Tim Newton from King's told us this only last week at the BSP conference. On average, 66 days to form a habit. And so don't expect patients to be perfect first time. This is a marathon, not a sprint. You are constantly chipping away at that patient's effort that they're making. 66 days, the standard deviation is 28 days and 297 days. It's quite wide. So it's anything from a month to nearly a year. However, on average, it's a couple of months. But it's making the point, one OHI intervention is not going to change that patient's behaviour. They've got to do something repetitive. And you almost want that Pavlov's dogs type scenario. Do you remember that Pavlov's dogs experiment? They'd ring the bell and they'd feed the dogs. And then they could get to the point where they could ring the bell, not bring food, and the dogs would salivate, a physiological response to the bell ringing because they associated the bell with the food. You almost need that. Phil Auer used to have all his patients listening to The Archers, the radio programme. I'm far too young to listen to The Archers, so I don't do that. But find something that makes it more habitual. So when that event happens, people go, I need to go and do my brushes. And then anything you say to the patient, you've got to back it up with written. Some of you, I can see some of you, you're writing notes, and some of you are just listening, and because some of you are auditory learners, some of you are visual learners, some will be kinesthetic learners. I need to physically do something before I can understand it. And you don't know who Mrs. Jones is sat in your chair, and you deliver all this information, and half the time they're not listening. So I back everything up I say with written information. And again, I don't expect to read it because most people don't read half of the stuff I give them. But at the same time, medico-legally, I've now got my clinical notes and some written information that says I gave you a lot of information. You can never tell me I didn't know anything about this gum disease business. If you haven't got good quality leaflets, I said to you before, the BSP have them. On the Perio Courses website, there is a back office that you can register to get access to. And my patients' information leaflets are there for you to go and download and steal. dental students, you can go back and tell your tutors, I was so inspired by Ian that I did this little thing over the weekend. They'll never know it was mine. So just there's a little tip for you. Back it up with written information. And then last thing, I don't know what it's like at Glasgow, but at Liverpool University, we used to have the dispensary in the middle of the clinic, and there was a box called the oral hygiene instruction box, but it was well known as the blue box of shame, because you'd see the students go to the dispensary and they'd say, can I have the oral hygiene box? And then it was like a death march back to the, this is 20 minutes of my life I'm not getting back. And then you'd have the student with a model going, you've got to shove the thing in there. And the blue one goes like that. And the patients are going, what, you, oh, that's my boss going, oh, shut up, just get... And there was a massive disconnect between the patient and the student because it was all done on models. And patients have to know what right feels like. Think about that statement. How do they know what it's... When you say to patients, do you use little brushes? Yeah, I do. I use pink. And I look in their mouth and I think, did you mean purple? And then they usually go, no, pink. And it's covered in dust and it's bent. And they go, look. And because what do they think those brushes are? They think they're pushing food out. They think they're doner kebab dislodgers, don't they? What are they? They're biofilm disturbance weapons is what they are. And it needs to be the biggest brush that fits the space snugly. And they need to know what right feels like. And we often think it's a bit beneath us. Oh, I'm a dentist, I'm really important. I'll let someone else do that. That dissolves the message. We need to, at least, dentists, do some oral hygiene instruction. Even if you're going to pass this work on to your colleagues, your hygienists, your therapists, your oral health educators, give it some importance because it's the most important part of the journey. So we will literally sit with the patient with a mirror. Mrs. Jones, can you see that purple brush? Oh, that's big. Yes, it is, Mrs. Jones. Right, watch where it goes. Oh, I didn't think that. No, you didn't, did you, Mrs. Jones? And I say, right, can you see where it goes? Yes, I can. Right, give us the mirror back. Close your eyes. Can you feel how tight that feels? Can you feel I'm pushing that brush just up towards your gum before I do the in and outy bits? Mrs. Jones, if it doesn't feel like that tonight, you're not doing it properly. That's how it's supposed to feel. Make sure anything they're rubbish at, you do to them so that they can feel what right feels like. It's really important because what you're trying to avoid is this.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes, Anna, and you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
Don't answer that question.
No. Why don't you show me how your inhaler works?
So, did anyone ever watch House? What a brilliant programme that was. He was wonderful in that. Second only to his Blackadder character, but he was bloody brilliant at House. She'd had a medical diagnosis, we're joking, but she had a medical diagnosis. She'd been given a medical intervention. I don't know whether you know the story behind this scene. She wasn't getting better. She'd seen every doctor in the hospital, and it took House to say, show me how your inhaler works. How many of your patients have got all the gear and no idea? Yeah? They've got the Oral-B IO 10,000 links to their phone. It washes the dishes. It heats the car. It's amazing. And they've got TPs and they've got water flossers. And then they walk in, they've got crap oral hygiene. And you're thinking, ugh, whose job is it to tell them how to use those bits of kit? Ours. And when you do this, everything will start to click and everything will start to get better. Try it. Just try some of these things. Go back to work on Monday and just tweak little things, and hopefully those little things will snowball into bigger things. How do we explain the disease to patients? My colleague Phil, the guy who sort of inspired me back in 2002, he would do the arm and the sleeve thing. He would say to patients that their hand was the tooth, and he would show their jumper as the gum, and he would have a pen, and he would talk about the pen going into a pocket. He'd squeeze the cuff of their shirt so it was tight, and he'd say in health the pen can't get in, and then as it got inflamed the pen would go deeper, and then he would talk about recession, and he'd peel their shirt back, and he'd talk about drug-induced gingival overgrowth. He'd grab their arm and he'd do mobility. He'd put his arm next to their arm and he'd do incidental cleaning. he was trying to explain the disease to patients. Now, we thought about this for many years. We worked together for about 13 years eventually as teaching colleagues. And here we said his was better. I think mine's better because I don't like at a new patient's appointment suddenly like manipulating people's arms. You'll end up with queues of weirdos outside your practice front door. You also medically legally can't show that you've done it. And so what we do is we draw a picture. But before we draw the picture, we have to explain the disease to the patient, how this disease works. One of the things that you've got to remember, and as some of you may have seen it, there's a video called The Sound of Periodontitis that the BSP made many, many years ago. Hopefully the dental students will have seen it. If they haven't, you need to make sure they get to watch that video because they should. It's patients talking about how they felt about their perio. And in that video, there's a patient called Angela. And Angela is a mid to late 60s Chinese lady who is asked initially about how she felt about her diagnosis. And she talks about things that you would not think about. She talks about the shame of her diagnosis. She talks about she couldn't tell her friends about her diagnosis. She could talk about the cancer diagnosis she'd had to her friends, but not her perio diagnosis because she was embarrassed because it was associated with her being unclean. She talked about her ugly side and revealing her ugly side, which was this perio problem. And when you listen to Angela talk, it's incredibly emotive. Now, again, you will have patients who are CBA patients. They're not interested, don't care that they've got perio. Others, and I need you to remember this, when you say to them they've got gum disease, perio, for some people it's actually like devastating, this diagnosis. It's also a situation where, Mrs. Jones, you've got gum disease. Mrs. Jones then thinks that I think that she's dirty. That's the immediate reaction. Now, most of the time, she is, and that is what I'm thinking, because that's why she's in this mess. But, and, you know, we're joking and we're laughing, but, you know, it's not all about that, is it? Because we have some clean patients who have quite significant disease. But more importantly, what comes next is behaviour change, and you've just put a barrier up. Patients sat there going, they think I'm dirty. Oh, I don't think I like that person. No one's ever mentioned gum disease before. Oh, I'm not sure about this. That's a barrier. This is how you get past the barrier. So I will sit the patient up and I'll say, Mrs. Jones, I can see that you've got some gum disease. Do you know anyone who's got, do you know anyone else with gum disease? Or tell me what you know about gum disease. And again, if you ask a question, shut up and listen to the answer. This is where you get, oh, the baby took all my calcium. I lost a baby for I lost a tooth for every baby that I had. Gum disease runs in our family, it's genetic. I get all this stuff. And at that point, you now know what bubbles and myths you have to dispel. I say, Mrs. Jones, it doesn't quite work like that. Let me explain. Mrs. Jones, there's about 10% of the population who are resistant to this disease. The rest of us have some level of susceptibility. Mrs. Jones, you're in that group. You're in the group where bacteria builds up on your teeth, it triggers inflammation, and inflammation is what damages your bone. Mrs. Jones, it's a bit like arthritis. Do you know anyone with arthritis? Oh yeah, Ethel's got arthritis. She's got damage in her joints. Right, Ethel has got arthritis, inflammation coming from within that damages her joints. You have got inflammation that's coming from within that's damaging the bone around your teeth. And we know what triggers that inflammation. It's the bacteria that builds up on your teeth. Mrs. Jones, I can see that you're looking a bit... It's a bit like I'm criticising your cleaning. I've looked in your mouth, Mrs. Jones, and your cleaning's about average. It's about a 7 out of 10. I'm thinking 3. I'm saying 7. If it's really bad, I'll say 6. Mrs. Jones, if everyone walked into my practice with 7 out of 10 cleaning, I'd be out of a job. This is me building rapport now. My poor nurse has to listen to this garbage every day, multiple times. She's just sat behind me just shaking her head. Anyway, Mrs. Jones, I've looked in your mouth. Your cleaning's about a 7 out of 10, thinking 3. If everyone cleaned at 7 out of 10, Mrs. Jones, I'd be out of a job. The problem is, Mrs. Jones, your trigger point for triggering inflammation is much more sensitive than other people, and your 7 out of 10 is not enough to get you the right side of your trigger. Is it okay, Mrs. Jones, if we have a little look at what you're doing and see how we can get you from a 7, 3, to a 10, 6.5 will do, so that we can help you switch off your inflammation. Can you hear the language? The language is so important. It's a bit like NLP, neuro-linguistic programming. You are almost brainwashing the patient. There is what we call a transfer of ownership. This is your disease. These are your problems. I'm going to show you how you can help yourself. And when you're doing that, I'm going to help you. That's the message I'm trying to give the patient. What we've told her is she's not cleaning well enough. What she hears is, I'm no worse than anybody else. I am a bit special. My trigger is quite sensitive. It's not all my fault. I need to do more. And this lovely young gentleman, this lovely young gentleman is going to show me how I'm going to get there. And it, honestly, even with the most hyacinth bouquet type characters that you will come across, this gets you past that stigma of, it's not all your fault. And then once we've done that, then we go into the explaining the disease in detail. And this is the fill arm and the sleeve thing. I draw a picture. The beauty of the picture is it can get scanned into my clinical records. And no one can ever say, Ian never told me how gum disease works. So I say, look, Mrs. Jones, I've just been explaining bacteria triggers inflammation, inflammation damages bone, and we've got to get you the right side of your trigger. Let me explain a bit more. Mrs. Jones, your teeth have roots, and over the top of the root is the crown, the bit you smile and chew with. Mrs. Jones, your gums are supposed to be up here. And when the gum gets to the tooth, it tucks down onto the root and it forms a little seal to stop the bacteria getting into your body. Mrs. Jones, we call that a pocket. And this is where the patients go, oh, I know, I've got 9s. And I go, yeah, I know, that's why you're here. You'll see in a minute, Mrs. Jones, it's nothing to be proud of. Mrs. Jones, a normal pocket should be about 2 or 3 millimetres, and you've got 9s. We'll talk about that in a minute. Mrs. Jones, I've just been telling you, bacteria build, underneath the gum, we've got bone. The teeth and the bone are not fused together. They're held together by a ligament. Think of it a bit like a shock absorber, Mrs. Jones. So I've now explained basic dental anatomy. Mrs. Jones, I was explaining a minute ago, bacteria builds up here. It meets your sensitive trigger point and your body triggers inflammation in the gum tissue. That inflammation is what damages the bone. Mrs. Jones, I've looked at your x-rays and I can see that you've got some bone loss. And I'll often say to patients, do you know you said to me your teeth feel a bit loose? Well, it's because your teeth are not held like that, they're held like this. And we do this visualization for the patient because it's all about that kinesthetic, visual, auditory type learner. Mrs. Jones, think of the bone and the gum like a tent pole and a tent. When the bone shrinks, the gum often wants to shrink with it. Mrs. Jones, I've looked in your mouth and we can see that your teeth have got a bit longer, you've got some of the roots exposed. The problem is, Mrs. Jones, the bone's gone faster than the gum and you've got these bigger, deeper pockets. These are those 9s that you were so proud of a minute ago. Can you see a problem with that 9mm pocket? And you hope that they say, well, how on earth am I going to clean down there? And if she doesn't say that, you go, how on earth are you going to clean down there? Mrs. Jones, don't worry, you don't have to clean down there. I'm going to teach you to be an Olympic gold medal winning toothbrusher up there. And once you're doing your bit, I will then go in there and get the bits that you can't get. And between us, me and you are going to get you the right side of your trigger point, and we're going to switch off the inflammation, and we're all going to live happily ever after. How does that sound? By this point, they are gagging to get on with it. They're raring to go. It's like, come on. And they said, when can we start? Mrs. Jones, tonight in the bathroom with your purple TP. Thanks for coming. See you later. Because perio is one in the bathroom. We've had that conversation already. Mrs. Jones, when we switch off your inflammation, anything that's inflamed is going to contract, like a spot on your nose or a bruise on your arm. Inflammation heals through contraction. Mrs. Jones, when we do your treatment, your gums are going to shrink. So if we just step out of character for a minute, we know from the studies that 70% of pocket healing is recession. 70. Every time you've got a pocket over 6mm, the majority of your healing is recession. 30% is clinical attachment level gain, where you get a long junction epithelium. So we know that patients who have perio treatment are going to get recession. So, consent for it. This is consent. Because dentists in the room, if you are doing a filling and it's a bit deep and you think, oh, I might expose here, you don't keep that to yourself, do you? You sort of say, look, Mrs. Jones, the filling's quite deep. We'll try not to hit the nerve, but it might, you might need root canal treatment. You preempt what you know might come next. Do it with perio because you know they're going to get recession. And then the patients will say, oh, I don't want recession because that's going to look rubbish. And the crowns and that. And then, are you ready for another cheesy analogy? I bet you're going to, in work on Monday, your nurses will wonder where you've been. So when the patient says, oh, I don't want my gums to shrink, that's going to look rubbish. You then have to put your sad Sam eyes on and you go, Mrs. Jones, I'm really sorry, but you have to have a longer tooth or a tooth no longer. You're all groaning. You'll be using it on Monday. Don't be I bet you, Monday, you'll all be rocking the river, longer tooth. None of these are mine. I've stolen them off loads of people. But they make a point. Mrs. Jones, we cannot treat perio without recession. This is a consequence of the disease. The gum and the bone's like a tent and a tent pole. Your tent pole is gone. The inflammation is keeping the gum high. And as we control that inflammation, it's going to shrink. And if we don't control that inflammation, that tent pole's going to keep going until your tooth falls out. You get to choose which one you want to have, but you cannot have perfection. Mrs. Jones, it's not all bad news. I said the gum's going to shrink this way. It's also going to shrink that way. And after treatment, Mrs. Jones, you will have more stuff holding your teeth in place. By stuff, we know that we're talking about clinical attachment level gain. How many times have you heard patients say to you after perio treatment, my teeth feel stronger? And they say, this is a bit weird, but my teeth feel stronger. But it's not weird, Mrs. Jones. You've got more stuff holding your teeth in. And actually, the quality of that tissue, the tone of it is really healthy, as opposed to that boggy swamp that the teeth used to be sat in. It's not surprising that these teeth are healthy. That, and we've joked and we've had a bit of banter, that takes me less than 3 minutes. 2.5 minutes I can get through that. And I've explained health, I've explained disease, I've consented for recession. That can be scanned into my notes. No one can ever tell me that I didn't tell them that they'd had perio problems. Some of you might have the, I think it's the Haleon now, flip chart. Now, and you might think you're wonderful with the flip chart. Do you know what I mean? Where you have the cross-section through a tooth and the periodontium, and it's got health and then gingivitis, and you'll be there going, that's health, gingivitis, mild perio, moderate, that's you. Got it? Great. So I used to do that. True story, this. So I used to do that up until about maybe 10 years ago. And I thought I was brilliant. I thought I was properly behavioural changing the patients. And then I did a consult, and the patient at the end of the consult says to me, that's been great. I'm up for this. Where do I get those brushes from? Brilliant. By the way, I think I know your mother-in-law. I said, oh, great. How do you know Geraldine? Oh, we used to work together. I said, oh, brilliant. Yeah, I love my mother-in-law. She's a great lady. Wonderful. That's great. I'll tell her you said hi. About a month later, my mother-in-law's around at our house, and she said, oh, I believe you had Mrs. Jones in the other week. I said, oh, yeah. She said she knew you. She said you seem lovely. And I said, oh, that's good. She said she had no idea what you were talking about with that flip chart, but she trusts you, and she's booked in for treatment, so she can't wait to get started. I was devastated. I'd got a compliment that I was lovely, but what I thought was a wonderful, 20 minutes, she had no clue what was going on. And I challenge you to go back to practice, get one of those flip charts, and just have a look at it. And without your dental head on, how on earth do you know what all those bits are? And that's the beauty of this. It's the telling the story that, the minute you see a patient have some vacancy, you can go, you didn't understand that bit, did you? You tell the story as you draw in the picture, and just try something. There's online stuff, there's loads of things out there. We are just trying to get patients to understand the disease, because now she understands why she has to change her behaviour. I forgot I'd left this one in, but it's a good one. Because someone said, oh, I like your analogy. So I never get to use this. As a general rule, my patients are quite compliant because they come from practices like you. You've had a good go at them. I'm then seeing them, and I'm trying to just raise the bar and do things a bit differently. Hygienists will probably, and therapists will probably appreciate this probably more than dentists, but when the hygienists or therapists are trying to do this step 1, step 2 thing, and you're saying to the patient, look, you go and do some more cleaning, and then we'll start our treatment. And the patient says, oh, just shut up and clean my teeth, will you? I promise I'll do them brushes. That familiar, hygienist therapists? I can see a few people nodding. Just shut up and clean my teeth, will you? I'm not here for a lecture. And you go, no, that would be stupid. Let me explain why it would be stupid. I want you to imagine you've come in from work and you've run yourself a bath. And you've gone downstairs to get yourself a drink, to go and have a nice, long, relaxing soak in the bath. But you've gone onto social media and you've got distracted. You're arguing with someone you've never met before on social media. And now water starts dripping through your ceiling and you think, oh, yeah, I've left the taps on. You run upstairs and the water's pouring over the top of your bath. By this point, they're looking at it like you're a moron. Anyway, keep going. So you say to the patient, what would you do? What's the first thing you do when you run into that bathroom? And you hope the patient says, well, obviously, I'd turn the taps off. And I go, yeah, that's right. Would you start mopping the floor up before you've turned the taps off? And the patient goes, no, because that would be stupid. The water would be pouring it. That would be stupid. I go, that would be stupid. I'm not going to start mopping the floor up down there until you've turned the taps off up there, because that would be stupid. So if you could go and focus on that cleaning, and I'll see you in a couple of weeks and we'll see how you get on. I don't get to use it as much as I'd like. When you use it, it's the smuggest feeling on the planet because they have nowhere to go with that analogy. So you are welcome if you get to use it. Congratulations, I hope you enjoy it. It then brings us about, we're finishing this bit with patient care and we'll get into what we physically do to patients. We've already talked about it. It's all about the physical and not about the chemical. That tray, Phil gave me that picture from years ago. He said to his patients, bring in all your oral hygiene aids. That whole tray, apart from the silver mirror and probe, was what the patient brought in. So the green mirror and probe was the patient's. And look at the chemical reliance that patient's got on their home care. They've been bombarded by social media, advertising, marketing, and it's all about the chemicals, all the gear and no idea. Poor Pauline was Phil's nurse. She was delighted when he retired. Every time they had an FTA, he was like, let's get some new photos, Pauline. They have to do physical. And I'm not going to here to go through evidence on this stuff because it's the biggest brush that fits the space possible. If a perio-susceptible patient can't fit a brush in a gap, they should floss it. That's dead simple. The evidence for floss is not great, but cleaning between your teeth, if you're perio-susceptible, is a non-negotiable event. 40 to 60% of the circumference of the tooth is interproximal. How can you treat a disease if you're only cleaning half of the circumference of the tooth? Non-negotiable. People ask me about water picks. They are a second best. There's no two ways about it. The evidence base is very clear. If a patient won't incidentally brush and they will use a water pick, that's great, but they have to accept the compromise they are making, and I cannot guarantee them any outcomes with that. It's a second best. In terms of secret weapons, this again, I have now used for probably 20 years. And I think more and more people are taught this now because more and more people have listened to people like me and Phil over the years. But the concept of getting the patient to physically clean into the pocket. Now, I get some of you will be thinking, I would just be happy if my patients knew which end was the handle and which end was the fuzzy end. And if they just brushed twice a week, I'd be delighted. So this is not for the CBA patient. When I have a patient who I've put them through step 1 of care and probably step 2 of care as well, if I've got any residual pockets to that point, I've got a lot of my shrinkage, I've got a lot of my junctional epithelial attachment, my clinical attachment gain. If I've got deep residual bleeding pockets, I'm now asking my patients to clean vertically into that pocket. We teach them this CTS Super Slim, not sponsored. I've seen the Wisdom Super Slim brush is very good. I'm sure there's others on the market, but CTS was the one that we have in the practice. And we teach this splay, push, wiggle. And you might be thinking that's bonkers. Why? Well, what are they doing? I said to you, stagnation points with biofilm are the problem because the biofilm gets organised, it triggers the inflammatory response. They are physically disturbing the biofilm within the pocket. They are biofilm disturbing the same way you do when you do your non-surgical therapy. And whilst we haven't got loads of evidence for it, I'll show you a little bit of evidence. Clinically, this has done me out of more surgery than any other thing I teach patients to do. And you'll be thinking, my patient won't do that. And if they won't, well, they won't get the healing. If they do, they might avoid people like me. And you can threaten them with people like me. Mrs. Jones, you've got a deep residual pocket. We've got 3 choices. We can just carry on doing what we're doing, but it's going to stay deep and it's deep and bleeding, and that probably means progression and probably tooth loss. You can shove this brush where the sun doesn't shine and up in that pocket, and hopefully you can get that pocket a bit more stable. Or there's this Scouse bloke in Liverpool who's got a big knife and charges a lot of money and he'll cut your gums. And the patients will often go, where do I shove that brush again? Yeah, you can use the threat of surgery or the threat of tooth loss to try and stimulate that motivation to the patient. Again, not everyone can do it, but those who can maintain pockets that are deeper than we'd often expect for many, many years. Evidence. Because I'm supposed to be evidence-based. There is limited evidence for this stuff. But I was taught this by Phil and Graham. Phil and Graham were taught it by Bernie Keyser back in the day. And these guys were absolute pioneers of minimally invasive periodontics. When this paper came out in 2013, it validated everything they'd ever taught. Now, it's a low-power study. So we've got, it's a very catchy title, Subgingival Root Brushing in Deep Human Periodontal Pockets. It's an American study by a group called Page and Rams, and they used this monster. I would advocate something a bit smaller. But they took 11 patients with severe disease. They've all got pockets that are 6 millimeters or greater, and they are untreated. And they do what we know as a split mouth study. They say, right, one half of the mouth gets clean normally, the other half we want you to do deep subgingival human root brushing. They follow them for only 2 weeks. And this really reinforces the point that I was making to you at the start of this session. They followed them for 2 weeks. They had a couple of appointments where they did oral hygiene instruction. And again, you might think, well, I can't do that. Anything you can do at this phase is better than nothing. They then brought the patients back, still had no treatment at all. And the control sites, nothing had changed. Why would it? Nothing would change. They hadn't done anything differently. At the test sites, bleeding on probing was eliminated. Now, we know from studies by people like Lang and Paulson that if you've got a BOP-free site in a non-smoker, it's a 98.5% predictive measure for stability. So no bleeding is really good. They switched off inflammation in these deep pockets without any treatment from you guys. They shrunk the pockets on average by 1.8 millimeters. Now, I've told you already, the average pocket depth change when you do an intervention is 2.1 millimeters. Makes you look a bit rubbish, doesn't it? Because they're achieving similar at home with a brush. And so other things happened. Periopathogen count went down. It would do because the environment's going from an anaerobic to an aerobic environment. You'd expect that pathogen shift. For me, you know, the 2 clinical parameters that we look at in perio, the main ones, pocketing and bleeding, they are basically treating moderate to severe disease at home in the bathroom with a brush. If you want to do less treatment for your limited budget, get the patient doing more. I can't keep saying that enough times today. And the authors of this study commented, they said they didn't expect this was a precursor study to something else they were going to do. And they didn't expect to see the outcomes that they saw. And they talked about the Cobb paper, that their evidence was showing similar magnitudes of gains to the non-surgical literature. We have to remember what our goal of therapy is. When you treat a perio patient, we are trying to achieve what we call a closed pocket. It's a defined situation where you've gone from a deep bleeding pocket to a shallow non-bleeding pocket. And shallow, 4 millimeters or less with no bleeding on probing. That is the definition of a closed pocket. It's important to remember that when the BSP did the classification document, if you read it, probably not, but if you read it, in the small print, they did say, it is important to note that higher probing depths of 5 or 6 millimeters in the absence of bleeding on probing may not represent active disease. That is a really important statement because there was a time when everything about perio was driven by depth of pockets, the decision making. The minute you had a pocket that was over 4 millimeters, when you'd done a couple of rounds of non-surgical, you were picking up the scalpel and chopping bits of people apart. Made you feel very clever, very important, but it wasn't very much fun for the patient. And as our data has got better, and figures like, if you've got BOP-free site in a non-smoking patient, you've got a 98.5% chance that that site is stable, we have a slightly higher tolerance on when we intervene. We know from the studies that pockets over 4 millimeters are more difficult for the patients to maintain inflammation-free. That's where that 4 millimeter pocket comes from. And so most people cannot maintain 5 and 6 millimeter pockets, and those patients may need more treatment, whether that be non-surgical, adjunctive care, or surgical care. But those patients who can, maybe we've reached the end point for those patients, and maybe they can go into supportive care. And some of us were chatting in the break. One of the hardest bits about perio is the life sentence nature of perio. You know, caries is a one-trick pony. You come in, you do a bit of prevention, but you treat the hole and you fix it. And for a good while, even with crappy diets, that's going to be okay. It's fixed. And perio is this chronic disease. It's the only real one that we deal with in general practice. And the system's never really understood that. The remuneration system's never really understood it. Your patients are going to go in and out of stability and in and out of treatments, in and out of maintenance. And if you are a proactive practice, and if you are properly monitoring your patients, and in our practice we do a lot of this, I will get to the point where I've got a couple of 5s, maybe a 6. If they're not bleeding, we'll often put those, and we've exhausted what we can achieve non-surgically, I'll often put those patients into supportive care, and as long as nothing's changing and we are monitoring accurately and carefully, all good. The minute things start to change, well, now I've got to intervene. That's why I'm monitoring. And now I've got to be a bit more aggressive with my treatment. Maybe if the patient's going to have ortho or restorative, I won't want to sit on a 6mm pocket. But if it's not that patient, if it's just a patient who just wants to save their teeth, the tolerance levels of what we decide very much is based on some of this data. And it means we can be less aggressive with some of our patients. To finish this little bit about oral hygiene, this is a massive anecdote, so please don't think this is evidence-based, but I'm going to back this up with evidence later on. I used to teach with, I apologise for the BDA slide, I've snuck it in the coffee break. I used to teach with, on the FGDP restorative diploma, the FGDP being sort of the precursor to what is now CGDent. And I firmly believe having our own college is so important. We were a subsidiary of a Royal College of Surgeons, and it wasn't a good place for us to be. And the FGDP was brilliant, but where we are is better. I used to teach on the restorative diploma with a guy called Nick Lewis. Some of you will know or knew his dad, Kevin Lewis, who used to be head of dental protection, wonderful human being. Nick's a restorative consultant, was at the Eastman. He's now somewhere on the South Coast. He does a lot of head and neck cancer rehab, but he works in private practice. And I always thought that when I was teaching perio, Nick was like half asleep or catching up on his paperwork, but clearly he listened to what I was saying to the delegates. And so Nick got this patient on referral, relatively young, late 20s, early 30s. That's horrendous. That's quite shocking. And Nick quite rightly said, we're going to do some non-surgical therapy. You're going to clean more. I'm going to do some treatments. You might need surgery. This might need like a regenerative type approach. Perfectly reasonable thing to say. He teaches the patients at the consultation how to do all the brushes and all the single tufted and sends the patients away. And the patient doesn't come back for nearly 9 months. This is the beginning of Feb. They come back at the end of September. And they walk in and say, hi, Nick, I'm ever so sorry. Life's been busy. Things have happened. I've not been back. I've not seen my own dentist. I've not been to the hygienist. I have been using that brush, though. And actually, feels a lot better, actually. I've not really seen any bleeding for a while. But anyway, I'm sorry, and I'm here now. Can we get on with the treatment? Nick re-examines the patient, and the 9mm pocket is now a 4mm pocket, and they've had no treatment. And Nick is so questioning his treatment planning that he justifies an X-ray, rightly or wrongly. And he takes an X-ray. I mean, all you can say is that there's been bone infill on that X-ray. Now, what I'm going to show you later is the evidence base behind this for non-surgical therapy, because we are now believing that vertical defects should be treated non-surgically first and wait a year before we entertain doing anything fancy, clever, or surgical. This is a huge anecdote, but what has that patient done? That patient has been biofilm disturbing, there's been no professional intervention, and they've created an environment that has allowed the body to repair and heal, because the body wants to heal, and that patient's actually got some sort of regenerative impact from that. It should hopefully reinforce the etiology part of the day, that it's not about the calculus, it's all about the biofilm, and biofilm disturbance is the be-all and end-all. It's almost like I know what I'm doing. Your patients walk into your practice with these deep, boggy, swampy pockets. They have to take responsibility for this, or there's bits they can access and there's some bits that they can't and that we do. But they have to take responsibility for their bit before we take responsibility for our bit. When you are assessing patients in step 1 of care, it's all about the marginal bleeding, bleeding superficially. That's the last, gives us an idea of the last week's worth of their oral hygiene. Once you're into treatment phases, we're measuring bleeding on probing to the base of the pocket and seeing what bleeds. There is no difference between delayed bleeding or immediate bleeding. If you've got a 9mm pocket and a 5mm pocket, well, the 9's going to be delayed because it's got further to travel. There is no difference between delayed or immediate. That's an old concept. But your patients are walking in with these deep pockets. And I've shown you already, hopefully, that when they take responsibility for their bit, they can achieve that. If they don't take responsibility, or even if they do and there's still residual disease, that's where we now come in with our treatments, which is where we're going next. If our non-surgical treatments don't work, I can then come in with a knife and I can achieve the same. But what are we trying to achieve in perio? We're trying to achieve that. We're trying to achieve an environment where the patients on a day-to-day basis can keep on top of their trigger point and maintain their own periodontal health, that external locus of control. That is what we're trying to achieve. Not a patient who's self-reliant, not reliant on you to fix their problems all the time. Which takes us into treatment. I'd love to say that all patients can fix themselves. I'm a firm believer that most mild to moderate disease could be fixed at home. I truly do believe that. But, you know, the calculus, there's lots of reasons why we remove calculus. We'll explore that in a second. You'll be pleased to know there's still some treatment to be done, because perio treatment's good fun, isn't it? It's just me, isn't it? It is just me. It's all right, that's fine, I understand. You're going to learn to love this, I promise. So we're sort of thinking now about step 2 of care. So we've gone through a step 1. We've got the oral hygiene better. We've modified risk factors in this utopic, you know, sort of everything's perfect, everyone does as they're told type world, which I know is not real. Now we've decided the patient's doing enough that we can think about doing some treatment. And we've got these mucky, contaminated root surfaces that are covered in cementum, they're covered in calculus, and they're covered in biofilm. You will always get biofilm on a hard, wet, non-shedding surface. There's no better place to grow bacteria than a deep, dark, swampy, damp mouth pocket. It's a perfect environment. And what I'm hoping is that we have already today made the point that the biofilm is the cornerstone. You know, it's the most important part. But then it takes us to calculus. I reckon I could raffle that patient off. I reckon we could have like a bidding war. Come on, who'll buy this off me for 10 quid? 20 quid, do it here, 20, do it here, 50. Hygienists are going, give it to me, give it to me. Wouldn't you just love 30 minutes in a cavitron with that? I mean, just. I always like to think this patient flosses. They don't floss. The teeth are so loose, the calculus never formed a splint. However, I've started to develop this point already. There is an obsession with calculus and this total calculus removal. I see it on some of the forums on social media that I spend far too much time on. You know, dentists bringing in their hygienists and wiping the floor with them. You've left a big lump of calculus there. Right, let me tell you, you never ever remove all the calculus. It never, we don't have it. Even surgically, we never remove all the calculus. Just that needs to go, by the way. We're not leaving that behind. But when I went to Phil's course in 2002, it lit a little fire underneath me. I had just started working in the dental hospital. I was working in basically like the sort of the casualty department, the A&E department, and I was just trying to be keen, young, keen dentist, and Phil had lit this fire under me. I was doing NHS perio in my practice. I was seeing good results. I was thinking, God, this stuff works. Like, it actually really does work. I then got a job in the perio department. Someone came down from upstairs and they said, we've heard you're keen and, you know, do you want to come and work in perio? And I thought, no, perio? Is there nothing sexy like endo or crowns, or can I not work in the pros department? They were like, no, it's perio or nothing. And so I got a job in the perio department and I thought, it's a stepping stone. I'm going to be in there for like 10 minutes. They'll realise I'm a lovely guy and they'll want me somewhere else. And that was my thought process. And I went onto the clinic in 2003 and I was supervising undergraduates. And at this point, I was thinking, I feel a bit weird. I quite like this. I'm getting good results in practice. I'm enjoying being around periodontists. That was a strange feeling. I thought, oh, not sure whether I like this conversion that's taking place. So much so, I went to Europerio, the Perio Olympics in Madrid in 2006. That was quite a big epiphany. NHS general practitioner, I'm suddenly going to an international perio meeting because I'd been teaching perio undergraduates on the clinic. And I thought, I need to know more. And I'd suddenly got this little fire underneath me and I wanted to know. And I messaged Phil and Graham and said, I'm going to Europerio. What should I go and listen to? They said, go and listen to this guy, Mombelli. He thinks like us. And Andrea Mombelli is a very famous researcher, very well known, very well respected. And I went to his lecture and he opened it with that. He said, if you think, and there's a room, I mean, you think this is big. There was about 6,000 people in this room. And he stood there and he went, if you think calculus is important, you need to leave the room now. In 2006, this was heresy. This is going against everything we'd ever taught, everything we'd ever been taught. And the whole room, you had 6,000 people all tutting at once. Like, I'm not going to like this. You could see people like shifting uncomfortably in their seats. And he went on to qualify it with, he said, I'm more interested in the living bacteria than the dead ones. It's the living bacteria that produce the endotoxin that trigger the inflammatory response. Now, he actually went on to say, maybe calculus is defensive. Maybe it's wrapping up the pathogenic bacteria and neutralising them. He was being very tongue-in-cheek. Please don't believe that that is what we believe about calculus. But he was making the point very clearly that calculus on its own does not cause disease. And we have got study after study after study that shows we never remove all of the calculus. And yet at dental school, how do we measure your ability to treat perio? You've missed a bit. You know, we have to measure something. So please, students, don't go back and like shout at your tutors, although you're all going to look at each other different on Monday, aren't you? No, we have to measure something. There are some surrogate measures we have to do at undergraduate level. And one of them is that you don't leave boulders of calculus on the root surface. You'll see cases of mine in a minute. We'd love to measure your patient's response in 3 months, but that's not going to be very good, and it's just not possible. It makes that undergraduate management very difficult, and we use calculus as this surrogate measure of how good your treatment was, but it's probably a false measure. More experienced people in the room. How many times have you been in practice and you've thought, I was flipping brilliant then? You do a non-surgical intervention, you think, honestly, I was practically Ian Chappell. I was so good, I can't wait to see that patient in 3 months. You're there at home at night, you're thinking, honestly, brilliant. I can't believe how good I was. Ever have those days? I don't have them very often, but sometimes, you just think everything went right. And then 3 months later, the patient comes back for the review, and they look like this. And you think, I'm such a bad dentist. I'm a rubbish hygienist. I am awful. I should go to the GDC. I might report myself. Look at all that. And you forget how wonderful you thought you were. And that patient has healed in spite of those deposits. Now, let's just be very, very clear. I am not here to say, leave all the calculus, just wiggle your ultrasonics around, shove brushes. That's not the message. We want to have as decontaminated a root surface as possible. But one of the things that this concept does is allow us to think about more efficient treatment strategies, because our clinical endpoint of that glassy smooth surface that's unachievable within the payment system that you've got, and is probably over-treatment, this thought process allows us to think differently about more effective, more efficient treatment strategies. That's why this is important. We should think about calculus as a byproduct of the disease. It's not the cause of the disease. The disease comes before the calculus. We know that we get healing in the presence of calculus. We've even got studies that show healing over calculus. That, again, is not what we're trying to achieve, but it happens. Calculus is not the be-all and end-all. Some of you will recognise a name on here. This is an American textbook, but some of you will recognise Philip Preshaw because he was dean at Dundee until about a few months ago. And Philip Preshaw, Professor Preshaw, is an eminent researcher in the field of periodontal disease. He's a world leader. I mean, Ian Chappell is like the UK poster boy for perio, but Philip Preshaw is academically at very much the same level, same kudos, and is well respected. So when Philip wrote the first chapter for this American textbook, and when Philip Preshaw, a UK homegrown professor of perio, dean at Dundee until recently, when he says calculus does not cause disease, you've probably got to think about it. It's not just some Scouse bloke at the front, doing his little performing monkey bit. There's some serious people making this point. He does say it can be plaque retentive, and that's one of the reasons we remove calculus. Clearly, that's got to go, hasn't it? Why do we remove calculus? 3 reasons. 1, it's a 3-dimensional obstacle, even if it's only a bit of calculus on the root surface. If the patient is subgingivally cleaning, or if you're subgingivally cleaning, the biofilm down there will not get disturbed. We try and remove as much calculus as possible. That's the first reason. It's a physical barrier to effective biofilm control. Second reason, it looks rubbish. That's a reason why we remove calculus. Third reason, far too much fun to leave it there. What if it falls off between appointments and you don't get the joy of knocking it off? You've got to remove calculus. Students, you must love still knocking lumps of calculus off. Please tell me that you've not lost that love just yet. As it rattles down the aspirator, you think, get in. It's just me, isn't it? And I'm going to have therapy after today, don't worry. So, I'm going to show you cases later. We do not deliberately leave calculus. That is not the message. I have said that the perio course's philosophy was that we don't immediately remove it, whereas S3 would say get rid of the supergingival stuff, and I get why. But in the ivory tower that I probably work in specialist practice, I get away with that withholding, getting the patients to do more, and I bring in my deposit removal as the patient engages. And you'll see later on healing, we are getting root surfaces clean. But we'll talk about how. Cementum. Now, the younger cohort in the room, the FDs, the students, you will be getting told we don't do root planing anymore. Fair statement? I would hope all universities are saying we don't do root planing. And the concept of root planing was the cementum was infected or it was necrotic. So many of us, me included, Margaret Keller would say to me, glassy smooth, Mr. Dunn, I want to hear it squeak as you go up the root surface. It was about removing that necrotic or infected layer of cementum. Students, FDs, those who've been taught recently that we don't do root planing, where you're taught to scrape sharp things up soft things. Metal curettes up soft root surfaces, but you don't do root planing. Okay? Hold that thought. Cementum. Let's just have this conversation. There is still one UK dental school who is still teaching the removal of cementum. I don't know how they're getting away with it. The evidence for cementum removal is really poor. And a guy called Ian Daly said many, many years ago, in the 80s, there was a small movement, people like Bernie Kieser, who went on to teach Phil and Graham and all those guys. There was a small movement about we are over-treating patients. But it was a small movement that never really got a grip. And Ian said that over the years, the rationales for root planing have been based on observation, not scientific investigation. So what he's saying is, we root plane, patients got better, therefore, root planing is what gets people better. But it is that, we used the analogy before of the ingrown toenail and the below-knee amputation. No one ever said, is that too much treatment? Or is that the least we can do to get there? Or can we do less and achieve the same? And that was the 80s this was being asked. The studies were not done till the early 2000s. I'm going to show you the studies, and this actually translates now to you in practice. The 80s produced loads of studies. The top study, without going into any detail, basically says cementum holes are this big, endotoxin molecules are that big. It's not impregnated, it's not infected. Endotoxin is superficially located on the surface of the cementum. Study after study, lots of these are UK-based, but then loads more that came from Scandinavia, Jan Lindy, Sture Niemer, the Gothenburg group, the godfathers of modern periodontics, all producing similar studies. I'm going to talk to you about one study. So, a guy called Jim Moore, in conjunction with the late, great Bernie Kieser. This guy was a South African periodontist based in London. Quite a cantankerous, sort of grumpy, loved to argue with people. I'll give you an example. So Phil used to work with Bernie in the West End of London. And Phil would be in his little surgery doing something nice and delicate, some suturing or whatever, and the door would slam in Bernie's room, and a patient would be in the corridor. I've never been so insulted in all my life. And then Phil would just hear Bernie go, come back next week, I'll try harder. Because he just didn't pull punches with anybody. And he constantly pushed against the profession where there was the 80s and 90s, very surgically driven specialty. And Bernie was saying, we are over-treating these patients. So he does a study. He takes periodontally hopeless teeth, he extracts them, and he does 3 things to them. He washes them for 1 minute with sterile water. He collects everything that comes off. He polishes them with a sterile brush, and he collects everything that comes off. He then burrs through the surface of the tooth to the depth of 2 millimeters to replicate 100% cementum removal, and he collects everything that comes off. And now, in each fraction, he can measure how much endotoxin came off in each layer. Endotoxin being the thing that triggers the host inflammatory response. What he showed was that rinsing gets rid of 40%, 39.52% of the endotoxin. Polishing gets rid of 59.73% of the endotoxin. It doesn't take Rachel Riley or Carol Vorderman to tell you there's not a lot left on the root surface to be planed off with our over-aggressive treatments. And Bernie came to the conclusion that we don't need to be as aggressive with the root surface. And the Scandinavians were coming to the same conclusion. The devastating bit is that with all this evidence that was building, it never got a grip. We could have been at the forefront of minimally invasive dentistry. You look at most dentistry now, especially people like your Tif Qureshi's and that align, bleach and bond, that minimally invasive stuff. In the 90s, we were exposed to the American sort of protocol, blushing pulps, prepping teeth, the elective devitalization, the maximally invasive dentistry. And we've moved towards minimally invasive dentistry in every aspect. My endodontist talks about ninja access cavities, these little tiny access cavities, minimal preparation of the root canals, enough to get it clean but without stripping the internal strength. Minimally invasive has been the way we've got. Medicine has gone minimally invasive. We could have been there in the 80s, and it has taken decades to catch up, and I'm still not convinced that everyone thinks this way. Graham, smart, Phil's teaching partner, who sadly passed away very young, he did a PhD under the tutelage of Bernie to follow this Bernie's work up. And he was the guy that coined the phrase debridement, where he was describing a technically simpler subgingival instrumentation that might be as effective as root planing. He talked about debridement being the new name for this concept, conservative instrumentation, overlapping strokes, light pressure, reduced time. That sounds good to you guys in NHS practice. Reduced time, yeah. One of the reasons that we don't often run hands-on courses for non-surgical is they would only last about 20 minutes because that's debridement. You know, I am doing 99% of my treatments exclusively with ultrasonics. And for decades, people would criticise me and Phil and other people. Oh, they're the guys who've dumbed down perio. They've made it too simplistic. You know, you've got to have mini Gracies, you've got to have all these Montana Jack, you've got to have all these different things. And Phil was teaching me, and I'm teaching now, an almost exclusively ultrasonic approach. And I'll show you why in a minute. The one thing you've got to be with ultrasonics is thorough. This is not a, you know, what have I got in next? Perio. All right, I'll just take my brain out and I'll just give it a rest. I'll just wiggle this around in the pocket for it. It's not that. You need, if you want to get the same results as me, I don't do anything special, but I am in the moment. I am thinking about where the tip is. I'm thinking about the anatomy of teeth. I'm thinking about root grooves, classically under-instrumented sites. The way, if any of you are endodontists, who wants to be down canals all day? Anyway, no, if anyone's into their endo, the people who are really good at endo are better than the average general dentist because they understand internal anatomy. They know where the extra canals are going to be. They think about the things in a different way. Perio's no different. You think about the external anatomy of the teeth. You're thinking about upper right fours will have a mesial groove or a furcation. Canines often have a groove on the root. Teeth are not these cylindrical flat surfaces. So it's an in the moment, in contact with every millimetre of the root surface type approach. I do some up and downy, I do some backwards and forwardsy, I do a bit more up and downy. That is debridement. It's a less aggressive treatment approach. One thing I will say, if you are going to do ultrasonic only treatment, you've got to be changing your tips, because I go into some practices, because we do practice visits, and you go into some practices and their ultrasonic tip should look like that, and it looks like that. And then they want people go, oh, I don't get the results you get, and I can't get calculus off with my ultrasonic, because it's not doing anything. Only 3 millimetres of the tip is active, so only 3 millimetres of the tip is doing this, and the minute you lose a millimetre, a third of the efficacy of that instrument's gone. Dentists, when you're prepping a tooth, you don't think, oh, this burr's only 3 months old, I can't possibly get rid of it, I'm going to grind away for the next hour and a half. You think, right, this is blunt, I'm going to get a fresh burr, now I can get through my crown prep. Endodontic files, single use, because they're fresh, they don't break. You know, I'm not saying they're single use, but you've got to be checking your tips, because you're not getting the results because your instruments are rubbish. When you get a new tip, it's like a hot knife through butter, or a hot tip through calculus. The other thing, let's have a think about, yeah, we've got time to do this. I'll ask for a show of hands just to make sure you're awake. Who's got a Cavitron? Okay, about 20%. Who's got a piezo? Who doesn't know what they've got? Well, only about half of you put your hands up, so the rest of you don't know what you've got. Right, we're laughing, it's not good enough. Because if I asked you what your favourite burr was, you'd know, oh, it's a 340 diamond, it's a 340 course, it's a, what's your favourite file system? Oh, I like Pro Taper because I love the you'll have a reason. And then I say to you, what scale have you got? I've got a white one. What's it look like? It's white, it's got a silver little thing on it, it just makes a noise, sprays water, white one. Right, we need to know, because the way you use them is different, and this will translate into what I'm going to talk about in a second. Your Cavitrons, so black handle with a big, long magnetoconstrictive that goes into the black handle. Cavitron, they have an elliptical action. So when you are cleaning the root surface, you are trying to clean with the side of the instrument. We know we don't clean with the tip of the instrument. You're not engraving, John was here. You're trying to debride the root surface. And as you increase the amplitude of the power, you just get a bigger run-up to wallop that calculus. The beauty of a Cavitron is it's idiot-proof, and you are constantly sweeping the tooth in the right plane. Piezo, white handle, little silver tip. Now you all know what you've got. So Action, NSK, EMS, Satellec, all of them. They're dental. Most of the others, piezo, they are linear. And you might be thinking, so what? Well, one's like a car wash sort of approach. The other's like a windscreen wiper. And if you with a piezo are not moving that instrument in the right plane, you are going to go from here to there. And you might think, so what? Well, that is not the way the instrument's supposed to work. That is when the patient goes, oh, God. And that is also ineffective. And patients say to me, you're not coming near me with that thing. I hate that thing. And I said, just give me a chance. You should almost be silent scaling when you use an ultrasonic, Cavitron or piezo. The minute you hear it screaming, you've got it in the wrong plane and it's no longer working at its optimum level. And all of these little things are really important, these subtle things that you will think about for your other parts of dentistry, but you don't necessarily think about for perio. So, good tips, decent length, not worn, knowing what your instrument's doing, all of these things are important. Power setting. Bernie's study told us 60% washes off, 40% polishes off. Why do we have our Cavitrons set to stun so that when you press go, it goes wallop, wallop, or bang, bang, and the patient goes, oh, yeah. Because that's what we do. I go into practice, you press go, and it's just set to the maximum setting. Polishing and rinsing gets rid of 40%. My piezo is set to 40% of the power. And then if I hit something that's difficult, I can boost it. But I start off with it nice and low, and I am biofilm disturbing. It's still very effective at removing calculus, but I've got a lower power setting. Water flow. You go to some practices, you press go on the pedal, you can put fires out in Australia. That's not what's meant to happen. You're supposed to be able to hold your instrument up. There should be a mist coming off the end of your tip. At the most, there should be a little droplet. That's as much water as you need. And you're thinking, so what, why? Well, a couple of benefits. Patient comfort. If you've got it coming off the tip like a fireman's hose and it's cold, well, you're going to get sensitivity. If you have it coming off the tip and it's a mist, then it's cooling a hot tip. It's coming off as a mist. It'll be body temperature. You get less sensitivity. And I'll talk to you in a minute. I use less local. Acoustic microstreaming. That mist is bubbles. And you might be thinking, so what? The bubbles are full of energy. And as those bubbles go beyond the tip of the instrument, they hit the biofilm, they impart energy, they burst the biofilm. Damien Walmsley, Birmingham University, been shown very clearly in multiple studies. Acoustic microstreaming is quite powerful. And you might be thinking, it can't make that much of a difference. I don't think it does make that much of a difference to the clinical outcome, but it is more comfortable. And then if you pick up the Sir David Brailsford approach, you all know who he is. He was the head of UK cycling. There was the year that we won all of the gold medals at the Olympics. Do you remember this? It was about a decade ago. And Sir David Brailsford was interviewed and they said to him, why is your team cleared up this year? And he said, marginal gains. And the reporter went, what? Marginal what? And he said, we looked at every aspect of our athlete's life. We looked at nutrition. We looked at their training. We looked at their recovery. We looked at sleep. They optimized like 8 points in the athlete's life. And they made each one 1% better. And those marginal gains added up to being 5% better than their competitors. They won all the medals. So when we're doing perio, I have a Sir David Brailsford approach. It's marginal gains. For the sake of just setting your instruments up right, you will get better outcomes. All for the sake of just giving this a little bit more thought. That's all I'm asking. It's not time consuming. It's not difficult. It's avoiding that fireman's hose approach. Moving forward, you can tell it's a bit of a soapbox thing for me. I'm quite passionate about this stuff, but it's important. We've got to move away from root planing. And I do believe that universities are teaching we don't root plane anymore. But the idea that we can scrape sharp things up soft things, and this is a tooth that's been root planed. This patient was referred to me, non-resolving pocket on the distal aspect of that lower right 5. quite a remarkable distal inlay cantilever, non-evidence-based, but lasted 35 years, out-survived the tooth. Non-evidence-based students don't do inlay distal cantilever bridges. However, we had to extract this tooth because it had become endoperio, and it was just cost benefit of trying to save it was not happening. When I extracted it, look at the level of iatrogenic damage that's been caused on that root surface. Did it cause the endoperio lesion? I don't know. But perio is a life sentence, and treating it with the most aggressive approach is only going to end up with problems. You cannot be that aggressive for the patient's life. We want to be debriding. And the definition of that is the removal of plaque and or calculus with the non-intentional removal of tooth tissue. So in a way, and I'm being slightly pedantic at this point, you can do non-surgical therapy with hand instruments. And if you are a black belt second dan ninja hand scaler and you get great results, keep going. Yeah, because it's all about the quality of the treatment. That's the important bit. And if you're rubbish with an ultrasonic and you're better, well, do what works in your hands. However, the days of that I used to do in the 1990s with Margaret Keller, that glassy smooth surface, that's got to be gone. If you're using a hand instrument, you are going into a deposit, getting beyond the deposit, underneath it, clicking it off, putting that down and back in with your ultrasonic. It's a less aggressive approach. Ultrasonics we use from the top down, hand instruments bottom up. And it's like saying to your kids, here kids, go and polish the banister. Okay, Dad, just take the dust off, son. Don't do anything. Okay, Dad. You've got to use the right equipment for the right job. And debridement is something I believe is realistically an ultrasonic only driven treatment. Do I have hand instruments? Yes, I do. I have a tray that has my mirror, my UNC 15 probe, an ultrasonic handpiece, and I have 4 mini Gracies and a mini Syntet. And if I hit a boulder of something that I can't remove and I just, and I think, right, I want to try and get it, rather than change my tip or risk breaking my tip, I'll put that down, I'll go and get a hand instrument, and then I'll put it back down and I'm back in with my ultrasonics. So I'm not saying I never use a hand instrument. I almost never use a hand instrument.
5, 4, 3, 2, 1, go.
You all know what's coming next? Great film.
You're only supposed to blow the bloody doors off.
So remember that when you go back to dental school. Anyway, real world implications of what was a bit of an academic discussion. And I'm going to take this through to lunch, and then we can do a few questions if needs be. This has impacts on your choice of instrument, whether you need local or not, and quadrants and full mouth. We'll get through this quite quick. Choice of instruments is dead simple because I've made my point. We've known for 20 years, this is a European workshop systematic review that looked at the efficacy of hand and ultrasonic instrumentation. They had 13 papers included in their systematic review, and the review conclusion was there was no difference between the efficacy of subgingival debridement, whether we use ultrasonics or sonics. Remember those old air scalers? Awful. Anyway, or hand instrumentation in the treatment of chronic periodontitis. No difference. We've known that for 20 years. There is no difference. What if I said to you, because when an academic says no difference, they mean there's no clinical difference. There's pocket depth reduction, clinical attachment level gain, bleeding on pro. That's what they mean. There's no difference. What if I said to you one's quicker? Is it better? It's not clinically better, but it's better for you guys because you're not getting paid loads to do quadrant scaling and root planing. And this study said that subgingival debridement may be completed in less time using ultrasonics rather than hand. And this is what Phil was teaching me back in 2002, and this is what I took back to practice. If we fast forward this now to the most up-to-date data, this is the S3 guideline that asks the question. It's my favourite S3 guideline. I don't know what yours is, but this is mine. I know. But the reason it's my favourite is because, honestly, we were really quite heavily criticised behind our backs and sometimes publicly. Phil and Ian are the guys who've dumbed down perio. They've made it too simplistic. It's not that simple. It's way more complex. And in a way, it was a bit like, you can't hope to achieve anything in practice. Just give everything to us specialists because we're magic. It's sort of the attitude that I felt that was coming out. And yet I'd seen this approach work in my NHS practice back in the day. The S3 guidelines asked a more important question, because what I hear is a blended approach is best. And a blended approach is where people will say, you do your gross deposit removal with an ultrasonic, and then you go in with a hand instrument because that gives you more tactile sensation. That's where you do the clever stuff. So they ask the question, are hand or ultrasonics better, or is a combined approach the best? That's the question. And the answer is very clear. We recommend that subgingival instrumentation is completed or performed with powered or hand instruments, either alone or in combination, because it makes no clinical difference. Yeah. Now, dentists. Do you remember 2020, pandemic? And we went back to work, non-AGP, and I had to go back, and I had perio patients to treat, and I've spent my life ultrasonically debriding. I was going home every night, and I was like trying to eat my tea, and my hand was in spasm, because hand instrumentation is flipping difficult, isn't it? Really difficult. I was going home, it was like couldn't hold a fork, I was having to eat left-handed. I was saying to my nurse, can we not just do AGP? Because it's tough, isn't it? And ultrasonics, they're simpler, but they still need that level of thought that I was talking about a minute ago. You've still got to be in the moment, thinking about what you're doing with a mindset of what am I trying to achieve. But there is no clinical difference. And actually, really importantly, it got the highest grade of recommendation, a grade A, and the whole room of academics agreed with that statement. Nobody can tell you that blended approach is the best. That's an opinion. It's a what's in your hands that works that makes a difference. Rubbish treatment, whether it be hand, ultrasonic or combined, is still rubbish treatment. Good treatment can be done with any of those approaches. Philip Preshaw. Read that. And I want you to read it both as if you're a clinician and as a patient. Just have a minute reading that. Ask yourself, which bit don't you want? Ultrasonic instruments are indicated to debride the root surface. It's a gentler, less destructive form of treatment that achieves the same clinical outcome without causing tissue damage. It's also more time efficient. Which bit don't you want of that for you as a clinician in practice, or for your patients, or for your mum? You know, when patients, when they do ultrasonics, it's quicker, it's less destructive, it just gives this, no, I want it to hurt. I want it to take longer, hurt me. Right, call the police, yeah? Because no one ever wants painful, more destructive, damaging, longer treatment at the dentist. Nobody on this planet. Philip Preshaw, I've explained who he is, important chap. It has a knock-on to local. Now, this is a personal philosophy. I use very little local in practice. If you do a proper step one, and I mean, like we've shown you, a proper step one, and you massively reduce the inflammation, treatment automatically is more comfortable. If I'm then not shoving clumsy, big, sharp instruments into inflamed pockets, and I'm doing debridement with my 40% power, my mist coming off the tip, I do 80% of my treatments without local. The minute a patient goes, ooh, when I'm treating them, and I go, ooh, like, the worst thing you can do is go, ooh, we're all finished, because you know you're not done, you've undertreated the patient. So the minute the patient goes, ooh, I go, oh, I'm going to have to numb you up now. So it's not that I don't use local, but if a patient can cope with the treatments I want to do to the standard I want to do it to, and I can do it without local, that's fine. Students, you probably need local because you won't have the skill set yet to be doing comfortable treatment. But over time, as you develop your clinical touch, you will find that you can do this treatment, a lot of it without local, because of this concept. And if these teeth haven't been root planed, they've got cementum on them, you don't get the sensitivity, patients cope remarkably with this treatment. The biggest problem that you have is the problem that we've had in the Northwest as well. You referring to the hospital, if you haven't done treatments under local, it gets bounced out back to you, doesn't it? Now, I can't change that, and that's the same all dental schools around the country. That is old school dogma, because there is not one study that shows treatment under local is better than treatment without local. What we see in hospital is undertreated patients in secondary and tertiary care. Local is for pain relief. It doesn't glue the pockets back to the teeth. If the patient can cope with the treatment you want to do, knock yourself out. And then last thing on this, and then we'll translate this into a study, and then we'll probably do some questions. Full mouth versus quadrants. There was an era, probably about 15 years ago, where there was a move towards full mouth treatments. And a guy called Mark Quirian said that full mouth treatments were better. He would say things like, would you clean your kitchen floor 1/4 at a time? You wouldn't, because you'd walk the dirty bits through the clean bits. It doesn't make sense to do quadrants. That was Mark Quirian's sort of sales pitch. When you look at the S3 guidelines, there are no clinical differences between quadrants, full mouth or half mouth. No clinical difference at all. So essentially, you get to pick what you do. Hand, ultrasonic combined, single visit, quadrants, whatever, you get to pick. And actually, this fits with the SDR. Because what I saw in the SDR is that you've got this concept of a 2C, if I get the numbers wrong, forgive me, but I think a 2C and a 2E, which is a quadrant charge for additional quadrants. Now, it's not a big charge, but one of the concepts we have in the English Avoidance of Doubt document is that you can do a Band 2 UDA claim for your Step 1, OHI gross scale. You can then do a Band 2 claim for your first round of non-surgical therapy, another Band 2 claim 3 months later. And so there's this concept of a phased approach. And one of the things it says in that document, not in the first proper non-surgical, but in the second proper non-surgical bit, it says this will probably be more thorough and take longer because in the first phase of treatment, you had other things to deal with, caries, extractions, whatever, stabilisation. And this is where maybe your SDR can help and maybe there could be a flow. If a patient walks into your practice with multiple quadrant disease, multiple diseases, you could be doing your 2C and your 2Es as you're doing quadrant dentistry. And your perio will be okay, but it may not be as thorough because you were doing other stuff. But once you've got through that stabilisation and you've now got a review and you've got residual pockets, now you can do a, 2C, 2D, whatever you want to call it. And maybe now that is where you do full mouth rather than quadrants. It sort of does lend itself for you to have the flexibility to do whichever one you want based on the patient that's in front of you. If you can do an FMUD, you can just claim a 2C. If you want to do quadrants while you're doing other stuff, you can claim a 2C and 2Es, if I remember my SDR properly. It gives you some flexibility. It's not perfect, you're not going to get rich off it, but at the same time, you're providing good quality, hopefully, patient care. Let's finish with this bit, and then I'll do some questions, because you're all probably starving. I haven't had breakfast yet. I said to you, no one had done the studies that looked at the most versus the least treatment. 2005 was the first study. Jan Venstrom did a study, 42 patients, all with severe chronic periodontitis, split into two groups. One group gets, the control group, 4 hours of root planing. We'll call those the unfortunates. The test group get no more than 1 hour of FMUD, full mouth ultrasonic debridement. At 3 months, they review the patients. They measure the pockets. Any pocket that was 5 millimeters or greater gets re-FMUD'd or re-root planed. And they closed the study after 6 months. There was no clinical difference between the two groups. Where there was a difference, they'd had 5.5 hours on average. They'd had less than 2 hours. I know what you're thinking, I can't do 2 hours. It's a proof of principle point. It's a proof of principle study. What they also showed was that at 3 months, about 65% of pockets had closed. Lesson number one, Mrs. Jones, you've got severe disease. We are not fixing this in one go. This is going to be an ongoing treatment. This is going to be a phased approach. You're going to pay now. We'll review it. There'll almost certainly be another thing to pay. You are in this for the long haul. It's probably going to take a year to get you stable. Because at the 6-month period, about 85% of pockets were closed. There's still need for these patients to be treated. You cannot fix perio, severe perio, in one round of treatment. Really important point. So, Philip Preshaw, I'm going to give him the penultimate word, then I'll have one word from a guy called Lars Laurel, then I'll take questions. Philip Preshaw, root planing cannot be justified as a treat concept. To put it more simply, it's not possible to remove all the calculus. We do not want to remove the cementum. Root planing doesn't have a place in modern periodontal therapy. Philip Preshaw, ex-dean of Dundee, professor of perio, big statement. This guy's called Lars Laurel. He used to work in Gothenburg with Sture Niemann and Jan Lindy, the godfathers of modern periodontics. We invited him to come and speak at a BSP meeting about 10 years ago. And we wrote to him, we said, "Dear Lars, please come and speak at this meeting in Birmingham." And he wrote back, "Dear BSP, I am delighted to be invited. You do know that Jan Lindy's still alive though, don't you?" Because Jan Lindy's like the poster boy. Think of Jan Lindy and Sture Niemann like Ant and Dec. He's Stephen Mulhern. That's sort of the relationship. It's quite embarrassing to call Lars Laurel Stephen Mulhern. Anyway, so we said to him, "No, Lars, we've heard Jan Lindy loads of times. We'd like to listen to you." He said, "Oh, it's brilliant. I'll definitely be there. But I am very old. You might want a spare speaker in case I die." God's honest truth, that was... Anyway, we said, that's fine. And we did have a spare speaker. And he arrived, and he was a picture of health, and he was wonderful. He did a history of non-surgical therapy, and it was brilliant. All, quoting the studies and all the things they'd done in Sweden through the 80s, 90s, and brought up to date. And a question came at the end of the lecture. Is there still a place then for hand instrumentation in non-surgical therapy? And there was a pause, and we all waited, and we're all there. And he went, no. Now, I think that's probably a little bit too far. But at the same time, it's making a very, very nice point that everyone is now thinking about being less aggressive. And there is this dogma out there of this, we've got to be, and then it becomes mindless, thoughtless treatment. I used to see students, I was saying this to Patricia, they'd call me over to look at their case. You know, I'm going to get the patient, I'm going to do some scaling. You'd check the pockets, there was nothing in it. There was a deep pocket, it was bleeding, but it was clear, there was nothing on the root surface, and they were going to scale that patient for an hour and then get me to come and measure it. It's thoughtless dentistry. We've got to be a bit more mindful with that approach. I'll just show you that we can remove calculus, and then we'll take questions. What this case shows you, look at all the healing. Look at how clean the roots are, ultrasonic only. This is not me saying I'm leaving loads of calculus. Watch your upper laterals, because again, referrals, when do you refer? If things are getting better, personally, I keep going non-surgically. I only think about invasive stuff if I plateau and the patient's still got disease. Watch your laterals, upper laterals. A year, still got some healing. 18 months, still healing. You know, perio does not heal overnight. It's a bit of a marathon, not a sprint. And expect your moderate to severe cases to be with you for anything up to a year. And breathe. Do we have any questions off the back of anything we've talked about that session? Be as controversial as you like, because I've not pulled my punches. But anything? You're all just starving, aren't you? Please do. Got one from the front. There's one there as well, yeah.
Right, okay.
Have we got a roving mic? Because there's a question. I'll be able to hear. Go on.
Regarding calculus, is there more liability of the biofilm attaching to calculus than there is to the tooth surface, or does it not make any difference at all? You know, I'm thinking, is there another reason to remove calculus?
It's a three-dimensional roughened surface, so I think the three-dimensional nature of it makes it more difficult. It's obviously easier to clean a smooth surface than a lumpy, bumpy surface, but the actual adherence, I don't think there's any major difference at all, not that I've seen, so no. But look at that case. I'm not here advocating leaving calculus. The different mindset is that if I'm not thinking, oh, I've got to get that last bit and spend 40 minutes on that one bit, if I don't have that mentality, I just think, I want to clean the pocket, get as much as I can, I want to move on, I'm going to review the patient, I'm going to see the healing. If it's not resolved, I can go back in and do more. It's just a different mindset. I was trying to treat everything in one go to please Margaret Kellett, and actually, even if I did please Margaret Kellett, that Venstrom study tells me I still wouldn't have fixed all the problems in that one go. It's just a different mindset. So you had a question, somebody. Yes, please.
I was just going to ask, you said after healing you get a lot of gingival recession. So I was just wondering, can you tell with a patient, you know, if they've got a thick or a thin kind of gingival biotype, will there be a difference in recession, and can you predictably say how much recession?
No. Okay. So the question, it's a very good question. The question was, can you look at a patient's gingival phenotype, thick and thin, and work out how much recession? Is there a way of quantifying it or not? I mean, the thinnest of phenotypes don't actually get pockets, do they? They get that loss of attachment. They very rarely get pockets. The medium to thicker phenotypes are the ones that get pockets. And the thicker the phenotype, the more self-supporting that tissue is when the tent pole's taken away. And so they're the ones that I only ever really end up doing surgery in relative medium to thick phenotypes. In terms of quantifying it, you can't quantify it based on phenotype. The thicker the tissue, probably the less recession you're going to get. But that's not a good thing, because the less recession you get, the less pocket reduction you get, the more likely you are to be more invasive with your treatment in more severe pockets. But there isn't a figure. It's that longer tooth or a tooth no longer, and they either get that recession and healing or they lose the tooth over time. Yeah, but what I do like about that question is phenotype. We don't talk about phenotype enough. It should be talked about orthodontically, restoratively, perio-wise, we should, phenotype, maybe we'll put it in for this afternoon. Phenotype should influence the way we think about our treatments, and we don't. We treat everyone the same, and we shouldn't. And I will stick something in for this afternoon. Now you've said that, thank you. Any others? Oh, there is one. Yeah, please.
Thanks for your talk. I just wanted to ask you, you mentioned earlier about the Chinese lady, I think it was Angela, who had severe disease, and you sort of said, I'll come back to
Oh, I did, didn't I? It was the young girl, the Chinese girl. So it was the 21-year-old. The reason I mentioned her ethnicity was just when we used to have chronic and aggressive periodontitis that apparently no longer exists. Yeah, right. But when we did have that concept of chronic and aggressive, there was a predisposition, a racial predilection towards Asian, Afro-Caribbean, Chinese patients. So as high as 5% of that patient ethnic group would get aggressive perio. The Caucasian population, about 0.1%. So that was the reason for mentioning their ethnicity. Just there is depending on your patient demographic, you might see a bit more of that aggressive disease. I mean, I would hope, it is still very rare as a condition. I would hope that most of you don't see aggressive periodontitis because it's devastating. They're the patients that are my bread and butter, and it's like every day of every week I'm treating those patients. So, but that was the reason, the ethnicity links, yeah. Any others? Oh.
EMS machine in practice, it's very on the up in practices now. What do you think of that?
Right, time for lunch. No. So the question was about the EMS machine. And so, right, EMS is a piezo ultrasonic scaler. But what you're probably asking about is air polishing. And if we just forget EMS for a minute, other companies make air polishing devices. I just want to be very clear. I'm not here to do anyone in or promote anyone, or we need to be very sensible at this. So the EMS piezo is very good. It's actually the one I've got in practice, but I also have the Acteon Neutron. I have both. In terms of air polishing, the other bit, the glycine powder or the erythritol powders. So if you remember the old polishing, you used to have the bicarbonate stuff that was like high pressure, super gingival stain removal, like heavy tar from smoking, but that could lacerate soft tissue. The air polishing that we're talking about now is microscopic powders under low pressure that can be used supra and subgingivally to disturb biofilm. They have been validated for the maintenance of healthy periodontal patients, the maintenance of implants, the early management of peri-implant mucositis, and there's a couple of studies that say maybe in early peri-implantitis you might be able to have an impact there. Where it's not validated is for the active phase of treatment. And if you start using air polishing subgingivally in inflamed pockets, there's no resistance to the air penetration, and you'll be at risk of emphysema, surgical emphysema, which is a non-important event. It's just embarrassing. And most of those companies will say that you shouldn't be going anywhere near the subgingival with those products, that air pressure in that very, like in this lady, it would be quite risky to be using air polishing at the start of her journey. Not terrible, but just risky. And that's not EMS, that's all of the systems. I think the one thing I would say with EMS is just their marketing's been so aggressive that they've almost made themselves out to be better than everybody else. S3 guidelines doesn't validate that. S3 guidelines doesn't talk about air polishing for treatments of perio. And so, at the end of the day, air polishing is what we used to do with a brush and a rubber cup or a bit of prophy paste. It's a biofilm remover. I think we need to be a bit careful that we believe that some of these things are like mythical treatments, that they're a tool in a box, is what they are. They're nothing magical. It's a great piece of kit, but so's Acteon, so's NSK's, so's everybody else's. Thank you. That comes up all the time. And I always have to tread on eggshells.
Okay, thanks. You're aptly entitled passionate about perio. I think we can see your passion shining through. Thank you very much. That was excellent. Thank you. So if we can all move to lunch now, most people will be in the Clyde suite, but students and the vocational trainees who know that they're going upstairs, please make your way up there as well. And we'll be back here to start at 2:20. Thanks very much.
Afternoon, everyone. Good afternoon. Just before we start the afternoon session with Ian, I just want to take a moment to say a big thank you to 4 of our MFDS study group tutors. 2 of them are here, Claire Fleming, Martin McKinstry, whom we heard from earlier. Unfortunately, Paul Friel is watching from home today, and Kathleen Berry is at a bar somewhere. So a huge thanks to them all. They've decided to resign. I think we just wore them out, is the truth. It only took 10 years, but we got there. It was either that or it was the recent mock MFDS exam day, and right next to us there was a seminar for turkey teeth. And I can tell you, the organiser was our new best friend when he found out we were all dentists. 2 days later, we've got 4 resignations. Now, I'm not saying the 2 are linked, but what are the chances? But a huge thanks to Paul, our right-hand man, and his team for their tireless efforts over the years, for helping really engender that collegiate spirit that we've got today with the students, the VDPs, their trainers, and the whole profession and dental team here. So, on behalf of CGDent Scotland, could I ask Claire and Martin to come forward, please, just to receive a small token to say a big thanks and a show of our appreciation, please. Thank you. Thank you. Thanks, Martin. You're going to get a quick video.
Thank you.
Patricia De Vries assures me that they're not Jet 2 vouchers with the discount code Turkey Teeth. Anyway, for the first lecture of this afternoon and his last lecture of today, for one last time, Dr. Ian Dunn.
Okay, what could possibly go wrong? 2-course meal, wine, comfortable seats, an afternoon in the lecture theatre, and Perio. What could possibly go wrong? Please do you make a favour, if they start snoring, just do that, because just my self-esteem can't take it. Okay, so you'll remember, possibly, hopefully, that we finished talking about this case and that long-term healing. I want to talk through a few things this afternoon, relatively quick, short things, but, you know, just to show you some cases and then also what we can do when things maybe don't work. You know, these are cases that have all been managed with the approach that we've been talking about. This sort of step 1, get the patient cleaning better, non-surgical intervention, predominantly using ultrasonic sort of FMUD type approaches. Cases that look quite severe and quite serious, and most of the time, perio is really simple. And then great long-term stability. Some of these cases, you know, you look at them at the start and you think, oh, I might refer that. This is the same case. There's a funny story to this case. So this was presented at BSP Cardiff, so in front of a BSP audience on the main stage, and you can see this sort of bold as a calculus. It's the sort of case, he's like, oh, get in, loads of deposits. That's going to be great fun. Easy wins, basically. And what you're looking at is the long-term healing response at 2 years. And then I think, if I remember rightly, I've got 4-year data on this case showing really nice healing, bone improvements. We've got that lamina dura reappearing on the mesial aspect of the lower right 6. And I can tell you that all of the pockets are shallow and there's no bleeding on probing. So all pockets are 4 millimetres. We've got closed pockets. And we're at BSP conference and we get to the end of the lecture and a hand goes up. And this guy goes, hi, thanks for your lecture. I'm 3rd year specialist trainee from the Eastman. And people are like, get on with it. It's not, we don't read your CV out. And he was like, could you go back a few slides? So we go back a few, and he goes, I can't help but notice on the mesial of that 6, there's some calculus. And we went, yeah, good spot. You can tell you're a 3rd year specialist trainee. He said, thanks for acknowledging the calculus. They said, so are you going to raise a flap now and get rid of that calculus? And we said, all the pockets are shallow and there's no bleeding on probing. And he went, yeah, heard that. But are you going to get rid of that calculus? Are you going to lift the flap? And we said, all the pockets are shallow and there's no... And this poor lad, who at the end of 3 years of specialist training, who had pretty much been taught calculus is the be-all and end-all, could not get his head around the fact that we were saying it's a stable site. We treat patients, not x-rays, don't we? And if that pocket was 7 millimetres and still bleeding, I'd pick a scalpel up all day long and we'd be doing something about that deposit and we'd be shrinking the pocket. But remember the goals that you're trying to achieve with treatment. This closed pocket, this shallow pocket with no bleeding is our end point, and however you get there almost doesn't matter. And keeping in with this patient sent in to me, "Dear Ian, this patient's got a localised vertical defect. We believe that you periodontists have magic pixie dust that you can sprinkle into pockets and it grows all the bone back," because we do have that, by the way. And so, "Dear Ian, can you please do some of your magic surgical stuff?" Well, I can't, because look how inflamed that tissue is. For anyone who places implants, anyone who does any sort of delicate type surgical stuff, trying to do surgery in inflamed tissue is a nightmare. The tissue is friable, it wants to tear and rip. It's like trying to suture wet toilet paper together. It's a nightmare. So we are always going to do a non-surgical phase in these cases. So we did non-surgical therapy. You can see we got inflammation resolution in the lower picture. Really annoyingly, the pocket healed and I couldn't do any surgery. I was quite frustrated because I love doing surgery. It makes me feel important. And I keep the patient close and I think, right, I'm going to keep them close because it may not be fully stable. There's a big infrabony defect there. And then we got to the point where the patient saw me for their 1-year review before I'm content to release them back to the wild. And I said, "Oh, look, I just want to be comfortable that when I refer you back, that we are referring you back in a stable situation. The pockets are shallow, there's no bleeding." And I justified another x-ray. That's quite cool, isn't it? Non-surgical therapy. There's no one in this room that in theory couldn't have achieved that outcome, because all I did was non-surgical therapy with an ultrasonic. Really high quality, really thoughtful, thinking about the anatomy of those lower incisors and the hourglass shape and that groove and all those things, but it was non-surgical therapy. And what we've effectively got there is what looks like periodontal regeneration. Is it regeneration? Well, we can debate that, but it doesn't matter. It looks way better than it did before, and the pocket is shallow and there's no bleeding. And we are seeing this all of the time. How many people would put the forceps on that tooth? Excuse me. This patient is not that old, and it's their upper front tooth. And the patient is asking us, "I will do anything to try and save this tooth." This tooth is vital because, again, think about it, students, you would be thinking, is this an endoperio lesion? If it is, it's going to change how you're going to manage the case. But we vitality test this tooth. It's a single-rooted tooth. It's vital. We can be confident that tooth is still endodontically not involved. And yes, I cannot say to this patient, everything's going to be fine, we're all going to live happily ever after. But with a patient who's up for it, I can say to the patient, "Mrs. Jones, your tooth has got nearly 100% bone support on one side. If we do nothing, you're going to lose it. If we do something, we might be able to recover it. We might be able to prolong the life of this tooth. What would you like me to do? There are no promises." And if the patient says, "Stuff it, take it out, I'll have a denture, I'm not bothered, I'll have a screw in," then that discussion can be had. But if the patient says, "I really, really want you to try and save my tooth," what have you got to lose by trying a non-surgical intervention? Because perio is all about treat it, review it, make a decision. Treat it, review it, make a decision. And that's the make a decision bit is often what we don't do, and then we end up with supervised neglect. And as long as I do an intervention and review it, and if I see improvement, well, I can do some more intervention. And then if I see some more improvement, I can sort of keep going. And if I don't, I can take the tooth out. But we kept going because the patient was up for it. They had 10 and 11 millimetre pockets on that central incisor. And yet, 3 years down the line, that tooth is not only there, it's actually orthodontically repositioned itself, just naturally. The inflammation's gone, the diastema is closed. Who'd take that tooth out now? Hopefully nobody. Being a bit Donald Trump, we need to make teeth great again because too many people are taking too many teeth out thinking that implants are the be-all and end-all. And we know that implants in perio patients don't do as well as implants in non-perio patients. At the BSP meeting last week, I heard at least 3 different clinicians, the most famous of them all, a guy called Klaus Lang. Implants are a replacement for missing teeth, not a replacement for teeth that have options. And so we need to have that mindset because implants don't always work in these patients. Now, you might think, "Oh, this is all well and good, Ian. These are nice little cases, nice anecdotes, but there's no evidence." Well, actually, there is. A friend of mine, a guy called Luigi Nibali, is the head of the periodontal department down at King's. It's a huge department made up of 13 different departments. It's the whole of oral biology that he's in charge of, and his specialty is perio. And Luigi's pet subject is the non-surgical regeneration of these vertical bone defects. And he's been publishing on this now for over 5 years. We're about 7 to 8 years down the line with these papers. And he's got about 9 papers now on this topic. So if you want to go and Google and by all means go and have a look at them. He's not the only person to have published on this, but he is showing predictable, regular, average gains of 3.6 mils, which in terms of pocket depth reduction, that's almost heading towards double what we would expect with normal treatments. He's showing radiographic bone fill of about 2.5 mils on average. And this is now changing, this has changed the way we think about periodontal regeneration. There was a time where we would be thinking as a specialty, we don't want that height collapse because we want to be able to regenerate, not to shrink. And so we were being taught only as early as 5 years ago, do a non-surgical therapy, get the inflammation down, get in quick and do your regenerative approach. And the most famous periodontist in the regenerative sort of sphere, a guy called Pier Paolo Cortellini, he wrote a paper last year with Luigi that says there's now a paradigm shift in the way we think about vertical bone defect management. And we're thinking about non-surgical therapy, following these patients for anything up to a year before we even entertain picking up the scalpel and doing a surgical approach. And again, doesn't this just fit with everything we've talked about? Why do the most treatment when you can do the least treatment? And the benefit of this approach, this minimally invasive approach, is it's achievable in your practice because there's nothing here that I've done that you couldn't do at home. Whereas the minute we start to get into surgery, like I said before, it gets very expensive. We start adding in biomaterials. Very limited numbers of people can do that type of work. And it means that it becomes a very niche subject or treatment option for patients. Whereas now we should be looking at these things thinking, maybe, just maybe, we can have a go at this. We're not sure where the limitations are, but this patient is 43. And she had what I would call generalized aggressive periodontitis. And I appreciate aggressive periodontitis young patients, and some of you in the room thinking 44 is not very young. It is. It's very young. Isn't it, Robbie? Very young. Anyway, the point of aggressive periodontitis for me was always about the disproportionate nature of the disease. That clean mouth, low risk factor, very fast, very rapid bone loss, and then the concept of vertical bone defects. So we treated this patient non-surgically, and we also used adjunctive systemic antibiotics. I'm going to talk about that in a minute. And we followed this patient, and we made no promises. She's got best part of what? 80, 90% bone loss on the mesial aspect of those lower centrals. We've got one bit of hope that we actually have a vertical component because we've got that interdental spike. And when we see this patient at 18 months down the line, again, hopefully nobody would be thinking about taking those teeth out. I can't predict this, but equally, if we don't give teeth a chance and we take them out, well, you know, you're always going to be right about prognosis. If when the tooth is in the forceps, you say to the patient, see, told you, hopeless. You are always going to be right at that point. Treat it and see what happens. Doesn't feel very clever, but as long as you're making review decisions and you're not doing supervised neglect, treat it and see what happens is a very sensible way to go. This patient, 23, she gets referred to me by her orthodontist. She rocks up at an ortho practice, and the orthodontist goes, oh my God, 23 years old. That is devastating. Some of you in this room will be 23, and that is devastating disease in anyone's book. We put this girl through non-surgical therapy with systemic antibiotics because she's got classic aggressive periodontitis, old school aggressive disease. And we stabilised her relatively quickly. Shallow pockets, 4s, 2s, 3s, 4s, couple of 5s, very little bleeding, and we kept her in supportive care for a year. She then gets pregnant, and we don't see her for a year. And she comes back and she said, oh, I'm so sorry, I've had a baby and life's been busy and I've not seen anyone. I'm worried that it's all your good work will be ruined. We examine her and her pockets are still shallow because even though she's not been with us, we taught her the importance of home care. She's self-maintained. And I said, look, all your pockets are shallow. There's no bleeding. You're okay. And she said, well, actually, I hate the way my teeth look. Am I okay to have orthodontics? Now, if there's any orthodontists in the room, I'm sure you'd all be thinking, because this is a hairy appointment if we're thinking about orthodontics. They're going to move fast, maybe too fast, maybe so fast that they end up in the bucket. But I said, look, let's have a look, because their teeth are firm and their teeth are ugly. You can imagine don't look great. And we do a lot of perio-ortho in the practice. I said, look, let's get some up-to-date x-rays and let's see what's going on. Have a look at her canines, especially the upper left canine. That looks as though it's been regenerated. That looks as though, those of you who do implants will know what bios and GBR bone looks like. And you'll be thinking, Ian, you've done surgery. Trust me, we have done no surgery in that case. And yes, she's still a very high-risk orthodontic patient. But actually, we're prepared to give it a go because her alternative is that she's got to take the teeth out and do something crazy. And she is a super high susceptible patient. All I want you to think about when you go back to practice is that, do we give this a chance? Do we treat it and see what happens? Because you can always take the tooth out if it doesn't respond at a later date. Why do we feel a need to believe we know what's going to happen to that patient when we meet them for the first time? We've got no idea about their compliance. We've no idea about their biological response. We literally don't know the patient, and yet we think in our infinite wisdom, because we've got a BDS, that we know what's going to happen. And actually, the more we give teeth a chance, the more teeth surprise me. I was chatting to a few of you in the break. We've all got cases where we've said to patients 20 years ago, that's not going to last. And 20 years on, that patient comes in and goes, still there, lad. Don't know what you're talking about. We've all got those patients. What do we do when we get to that point, though? Because what I've shown now is sort of things working. And I'd love to say that we just do non-surgical therapy and everything's perfect and we all live happily ever after and my practice is periodontal utopia and there's no pockets and no bleeding. If you believe that, I've got some magic beans I can sell you. We still have other things that we have to consider. And so what I want to do is rattle through, and I do mean rattle through, the logic behind decision-making on this. Yes, and it will be rattled. So when I look at a site that's not responding, a site or a patient, I'm thinking, is it the patient's fault? It's always the patient's fault. It's not my fault. I'm perfect. Best thing about being a periodontist, it's never my fault. They just didn't clean well enough. Endodontist, it's your fault. You didn't do the root canal properly. Perio, good place to be. But you think of patient factors, you think of clinician factors, two big bits. In terms of patient factors, we've talked about these already. You've got, are we looking at missed risk factors? Are we looking at an undiagnosed diabetic patient? Is it the smoking that's stopping the healing, in which case there are very few onward options? I've talked about anatomy, and we'll sort of touch on that again in a second. And then we know that compliance is the biggest thing that holds us back in terms of non-surgical outcomes. I'm not going to go through the risk factor stuff again, but you've got to ask yourself, am I missing something? Is the smoking, is the vaping, is the diabetes control? Is there something about the patient's life that's getting in the way of that patient healing? Anatomy, we've talked about this. We've talked about grooves on teeth. All of you, hygienists and therapists, get your dentist to save some extracted teeth over the next 5 days. And in your lunch break, maybe after lunch when you've had your dinner, but go in and have a look at the teeth and have a look at the anatomy of the teeth because you don't get to see that as hygienists and therapists. Dentists, when you take a tooth out, just have a minute while they're biting on the cotton wool, just looking at the tooth and remembering that these teeth are not these perfect spheres or perfect flat surfaces. They've got grooves, they've got nooks, they've got crannies, they've got all sorts of areas that we under-instrument. You've then got things like furcations, notoriously difficult to treat. But then I also think I much prefer an open furcation to a closed furcation. How often have you seen like lower pockets, buccal of lower sevens, where you have relatively shallow pockets and you fall into the mid-buccal of a lower seven? And you think, why is that there? And it's almost certainly that patient's had maybe mild 10% loss of attachment. But once that 10% loss of attachment gets to that closed furcation, that bone in there doesn't stand a chance. It's tiny, it's got very limited blood supply, and they then behave like vertical root fractures. So anatomy plays a big part. Phenotype, the question that was asked this morning. Thicker phenotypes are more likely to self-support and maintain pocket depth. And then you've got things like vertical bone defects that we've seen can respond to non-surgical but might need a surgical approach. Compliance, just a quick thank you to, I couldn't be part of this video, but Tom Cruise stood in for me in this video. This is meant to be me talking to a patient, but Tom did this for me. So just see if you understand this bit.
God, help me! Help me, Rod. Help me! Help you. Help me help you. Help me help you.
Callum Youngson, Professor Youngson, who was my line manager at Liverpool Dental School, great Scottish gentleman. Here he said to me, don't care about their teeth more than they do. Now, I sort of get that. I think it's our job to care about their teeth more than they do. And that's often me talking to patients, and that's often the reaction I get, that... You know, but compliance is everything, and we've covered that bit. When it gets to clinician factors, we've got poor treatment. And all I can say is that probably 80 to 90% of the cases that are sent in to me in practice are managed non-surgically. And so in theory, that means that they could have been managed in a general practice setting. Admittedly, time, money, equipment, all of that stuff gets in the way sometimes, and you are doing the very best that you can. And hopefully your referral colleagues are very supportive of that approach. And that is really important if there are any referral practices in here. But it is uncommon that I can't improve on the situation that's been referred into me. Whether that's just raising the bar with the patient doing more, whether it's me improving on the non-surgical outcomes. Practices get offended when we repeat non-surgical therapy. I'm not going to do it unless I believe I can make a difference. Then we've got things like diagnosis issues. I'll show you what I mean by that in a minute. And we have to sometimes accept that we've exhausted non-surgical options. Poor treatment, we've talked about all day. Anatomy, time constraints that you have within the NHS service. Equipment, we've talked about equipment, worn instruments, old kit. You know, you can't do good quality dentistry with battered old instruments. And then, you know, are you going back and checking the root surfaces? Are you, although I said calculus is not the be all and end all, I'm still checking to feel that I've not left boulders behind. Are you producing high standard, high quality treatment? The diagnosis issues that are commonly referred as perio that aren't perio are things like vertical root fractures, endoperio lesions, things that present, so occlusion. The patients had loose teeth. They were sent to me as a periodontist with shallow pockets and no bleeding, but grade 2 mobility in the first and second premolar. What I hope you can all see on that last x-ray is we've got widening of the periodontal ligament space, we've got that funneling effect. That patient has got some sort of occlusal parafunctional habit, and that the mobility is an adaptive process. They've got best part of what? 90% bone support and grade 2 mobility. Everything's diagnosis, diagnosis, diagnosis. There are many things that present like perio that aren't perio. And you know, right diagnosis, right treatment, wrong diagnosis, wrong treatment, no diagnosis, who knows what you're doing. I said I'm rattling through this bit. Maybe you've exhausted what can be achieved. So then it takes us into what can we do differently? What options are out there for our patients? Let's just restrict this part of the discussion to the engaged patient, because I have no options for your patient who doesn't do the homework. So I don't have a magic bullet. We don't think about anything, antibiotics or local deliveries. If the patient's cleaning is poor, they've hit the end of their road. So all of the things we're going to talk about now in the last 30 minutes of this afternoon is the concept of how we can manage an engaged but non-responding patient. I can think about repeating the non-surgical therapy. I'm going to come back to that. I can think about adjuncts, and you can think about adjuncts. We'll talk about that in a minute. Surgery. I think everyone thinks that periodontists are like Zorro, with cutting patients open all the time. I do about 10 to 15% of our cases are managed surgically, and I'm treating a cohort of the worst patients. So surgery is these days a last resort for our perio patients. Extraction is an option for a periodontally compromised tooth, as is palliative care. If you get to a point where the patient plateaus, there's still some deep residual pockets, they can't afford, can't access, or don't want any advanced treatment, as long as everyone's on the same page, it is okay to say to that patient, look, we've run as far as we can, you don't want any more intervention, let's just try and look after this best we can, but you need to know that that tooth is probably going to deteriorate, and as long as we're on the same page, and that's all well documented, that is a perfectly acceptable situation. And then you've got specialist care. And I appreciate in Glasgow and in other parts of Scotland, specialists, periodontists are a rare breed. We are, you know, rocking horse doo-doo, if you want to call it that. There's not many of us. And as soon as you go away from any major centre, you are really going to be struggling. But we'll talk about that in a second. In fact, let me just play you this.
But it's frightening to think that with modern medicine and all the technique available to them, they can't really help you. I should think of the old days, you know. You were better off. Because nowadays they're all specialists. Everyone's becoming better and better, and less and less. And eventually someone's going to be superb at nothing.
Those of you who do specialise, even if it's sort of non-specialist specialised, you restrict your practice. The minute something comes in that's outside your comfort zone, you realise how inadequate you are and how much you've forgotten. My endodontics is terrible. I have those patients who follow me around the Northwest for 20 years and they need an endo, and they're literally begging me for me to do the endo because, oh, you're the only one I trust, I want you to do it. And I'm saying, you trust me, you do not want me to do your endo. I paid for my wife to have her endo done by a colleague because I'm so bad at endo. As a specialist, you pigeonhole that, you sort of go down those rabbit holes of your specialty. I think I said before, you have to remember what failure looks like as well. Because I see on social media, I've done a round of treatment and I'm rubbish. I don't know what I've done wrong. The patient's not responded. And one of the first questions I ask is, what do you mean by not responded? And often the person will come back and say, well, they've still got some deep pockets and bleeding. And I say, yeah, but where were they before? And they'll go, well, they were 9s. And I say, where are they now? And they go, well, they're 6s, but they're still deep and bleeding. We talked about the Venstrom study before, and Venstrom told us 65% of pockets roughly close on the first round of treatment, up to 85 by the second round of treatment. We know the average pocket depth change in the first round of treatment is about 2.1. In the second phase of treatment, it's about 1.2. So if you're getting anything better than this, you are doing better than average. And so don't beat yourself up if a 9 goes to a 6. You've achieved better than average treatment outcomes for your patient. But just accept you're not quite at the end of the journey with that patient. This is an onward process. And I've said it already, a lot of my patients are with me for a year before I even think about anything like surgery or think about discharging the patients. That's sort of the timeline I'm thinking of for moderate to severe disease. We've then got things like adjuncts. So we've covered hair already, I went to my 10-year reunion last year. Kidding. It was a long time ago. I was just at the start of a perio journey, and all my colleagues in my year were going, perio, I've heard you're doing perio. And then as the night wore on, they'd come over to me and they'd go, sorry about taking the mickey before. Can we have a chat about perio? What do you stick in pockets? What's the magic stuff? What's the best thing? And I was like, an ultrasonic. Because they all wanted to know how to magically close pockets up, like we have some sort of glue that shrinks the pockets. We have local delivery antiseptics, perio-chip close site, we have local delivery antibiotics, and we have systemic antibiotics. And I think we should just talk about this reasonably briefly. The S3 guidelines have looked at this. And the S3 guidelines have said about local delivery antiseptics, so perio-chip close site, chlorhexidine-based products, that we may consider them. But if you look at the grade of recommendation, it got an O, which is an open recommendation. A is this is a really good thing to do, or it's a really bad thing to do. B is this is a good thing to do, or it's not a good thing to do. O is meh. It's neither good, it's neither bad, it's not really good, it's not really bad, meh. It might do something, it probably won't, it's a meh, right? So all of these things like perio-chip close site, average pocket depth change of about 0.5 millimetre when you use them. Woo, 0.5 millimetre. I mean, you can't even measure 0.5 millimetre. The same goes for local delivery antibiotics. So Elizol, dentamycin, we had Arestin, we had Atrodox, a lot of them have gone now. They've gone because they're not that great. And again, it has an open recommendation. If I show you some data on this very quickly, it's very late in the day to be doing studies, but this was the biggest systematic review on local delivery antimicrobials, both antibiotics and antiseptics, prior to the S3 guidelines. This is one of those powerful systematic reviews because they've got 56 papers that are all the highest level of evidence, randomized controlled, placebo-controlled trials. That's the highest level of clinical trial you can get. And what they showed was that when you use one of these adjuncts, an adjunct is, alongside your treatment, the average pocket depth change is a whopping 0.4 millimetres, and the clinical attachment gain is a whopping 0.3 millimetres. The single tufted brush was achieving about 1.8 millimetres, and you're not exposing the patient to antibiotics. You're not abusing antibiotic sort of resistance protocols. These things are not that impressive. The tetracyclines were marginally better than the chlorhexidines and the metronidazoles, locally delivered, but this is not that impressive. If you have a non-responding pocket and you said to the patient, look, we've hit the end of the road, it's plateaued, it's not getting any better, it's either go to a specialist or we try one of these, I would not criticise that at all, because these are averages, and averages are just that. Some people will have done worse than this. I'm not sure how, but some of them would, and some will have done better. And some of you in this room, me included, have used local delivery antibiotics, and we've had great results. It's like, that one time at band camp, I went from a 9 to a 3, and it's like, and you remember the good times, but you don't remember that time that the 9 went to a 9. You don't remember them, do you? Because you think, oh, God, park that one. And that's our sort of internal bias. The studies tell us the average pocket depth change are around about 0.5 mil on top of the gains that we would have got anyway. But if you have a pocket that isn't responding and you want to try it, by all means do it. Where I have an issue is when I see patients who come to me and they say, oh yeah, I've had 37 periochips, I've had 18 rounds of dentamycin. Doing the same thing and expecting a different outcome is the definition of madness or stupidity, whichever one you want to pick. And at that point, I think you're abusing the patient's goodwill, you're abusing antibiotics that we shouldn't be abusing, and that is not the way we should be practicing. So under-promise, hopefully over-deliver, but just know that these things aren't great. It takes us in fact, let's go past this. There are loads of new products coming on the market, and all I'm going to say about them is they're untested, untried, and I have tried them, and they're generally not very good. I'm not going to get into names or products. If you want to come and talk to me about those products, by all means do, because there's 2 or 3 companies pushing different things. None of them antimicrobial, none of them antibiotic. They're all what they call wound modification products based on things like hyaluronic acid, vitamin C, or some of the amelogenin type things. They are really unimpressive based on what I've seen so far. So we can put that to bed. Systemic antibiotics. I've said 2 or 3 times this afternoon that we had young patients with what we would have called aggressive disease, and I said that we did non-surgical therapy with systemic antibiotics. That is an almost non-controversial statement. I think most of us in perioland use systemic antibiotics for aggressive disease. The S3 guideline says that we should not routinely use systemic antibiotics. I totally agree with that statement. And it says that we may consider it in young patients with grade C periodontitis, C being fast progressing, what we would have called aggressive disease. What is worth also saying is that the BSP have been very clear on this. We believe that this shouldn't really be prescribed in general practice unless you're a tier 2, which is a dentist with special interest, or a tier 3 specialist practitioner. The only issue I have with that, ever so slight issue, and I'm, Mr. BSP, I'm all part of that, and I do stand by this. It's all well and good if you work somewhere like Glasgow, where you might have 2 or 3 private periodontists, you've got access to an NHS hospital. You can argue whether the care there for perio is good or not, I don't know, but Liverpool and Manchester, very mixed what you can get on the NHS. One of the issues I have with this is that if the BSP is saying, look, you must never, ever, ever give these things to these patients, then what if these patients can't, won't, don't access specialist care? Do we not give them the treatment they need? If you have a young patient, that clean mouth, that rapid progression, and you should strongly encourage those patients to seek specialist care because they will always do better in specialist care. If they don't, I personally think that you should consider doing this as an option, but you're going to document why you are breaking the guideline. You're going to show that you have strenuously tried to get that patient into specialist care, but ultimately, if you don't do this treatment, they may not get better. You're going to watch their teeth fail, all because of a BSP guideline. Do you remember what guidelines are? They're just that. They're not law, they're guidelines. It brings about the question, what do we deliver? In our practice, it's every single patient where we diagnose aggressive disease, I am giving it in the first phase of therapy. There is some evidence, so if we look at the BSP Good Practitioner Guide, that says do a round of treatment, and then if there's still residual disease in these young patients with aggressive disease, then do the antibiotics and another round of cleaning. There is a little bit of evidence that says if you give them right at the start, the patients do a little bit better. Gareth Griffiths, Sheffield University, Professor Griffiths, he had a randomised controlled trial, 2 groups of patients with aggressive periodontitis. This group get amoxicillin and metronidazole plus their debridement. They get a placebo plus their debridement. And at 3 months, they have done better than them, obviously. They've still got some disease, they've still got loads of disease. So then he does a second phase of the study. He swaps them over, they now get the antibiotics and the cleaning, they now get the placebo. The patients have had the same treatment, just in a slightly different order. And what Gather showed is that those that had them in the first phase did better than those who had them in the second phase. And so that is one of my protocols. When I diagnose aggressive disease, I treat them aggressively. I still put them through step 1, but I shorten all my protocols down. I'm going to bring them back early within a couple of weeks. They are generally already a clean patient. If I can get to the base of every pocket and I can be confident the root surfaces are clean, and in aggressive disease, they are often very clean. There's often very low levels of calculus. They will leave that appointment with their systemic antibiotics. What do we give? You've heard me mention amoxicillin, metronidazole. That's the most common, the most widely known, most widely researched. So 500 amoxis, 400 metros, one tablet 3 times a day for a week. There is evidence that shorter protocols work, and there's really good evidence for azithromycin. So I now don't give amoxi-met. I give 500 milligrams of azithromycin, 1 tablet a day for 3 days. They get 3 tablets. This should not be on your radar with any sort of regularity. If you get an aggressive periodontitis patient, get them out your practice. That is the gold standard message. But if you get that youngster who won't travel and won't be referred, at least think about it. I then said about palliative care or extraction. If you're going to put a patient into palliative care, all I will say is, I'm always having the conversation, when this tooth eventually fails, Mrs. Jones, what are you going to do next? Because if we're going to watch a tooth fail slowly over 2 years, 5 years, and they're going to lose all that bone, and the patient says to me, actually, I'd quite like an implant, I shouldn't sit on that tooth and watch it fail. But if the patient says, oh no, I don't want those screws, can't afford them, I'll have a denture, it's at the back, I don't need to replace it, well, I'm much happier to sit on that and watch that fail because there's no consequence to what comes next for that patient. And so what we don't want is to be losing ground and making the treatments more difficult. So I think if you're going into palliative care, at least have that onward crystal ball gazing conversation. The S3 guidelines looked at what should you do if you don't have access to the expertise of specialist referral, and it says to you, you should provide high quality step 1 and step 2 of care. In your case, this will be 2 C's, 2 D's, and God knows what else, because I've lost track of the numbers and the letters. But you know, doing something is better than doing nothing. If we finish this last bit, and we've got about 20 minutes, talking about the good stuff, surgery. Surgery has its place. I think a lot of people think that we don't do a lot of surgery as periodontists. We do a lot less than we were doing as a specialty probably 15 to 20 years ago. I split surgery into 3 sort of options. We've got access surgery, literally open it so I can see what I'm doing and deal with whatever I've missed before. We've got then resective surgery, where we might remove tissue, apically reposition flaps, resective flaps, root amputations. You might think they're a bit weird. I'll show you in a minute. Good evidence base for them. And then you've got sexy perio, regenerative perio. We're growing back the gum and the bone that's been lost. It's sort of the holy grail of periodontal disease management. So if we have a rattle through this, Bernie Kieser said the existence of a pocket on its own does not justify surgical intervention, nor can there be any depth of pocketing that automatically necessitates surgery. He's making the point it's less about the pocket depth and more about the inflammatory status. You might not have heard of Bernie before today, but you should all have heard of Jan Linde. You've all read a paper by Jan Linde, whether you like it or not. Jan Linde said he's the godfather of modern European perio. There's no established correlation between pocket depth and the presence or absence of disease. Symptoms other than increased probing depth should be present to justify surgery. That is subgingival instrumentation. You and I know that as bleeding on probing. I need to exhaust non-surgical therapy and be left with pockets that are 6 millimetres or greater that have bleeding on probing in a non-smoking compliant patient. You can imagine that's not many people. That's why we do less and less surgery. But when we get to that point, then we have options. I consider surgery, like I've just said then, they have to be compliant. I mean like the best of the best. Surgery in non-compliant patients, they lose attachment. They are worse off for having had the surgery if they're not controlling their superficial inflammation. They have to be a non-smoker for me. Smoking is a lack of compliance. It affects wound healing. It affects non-surgical therapy, but we still do it. I'm not going to put the patient through an invasive surgical procedure to have a less than brilliant outcome. And so I'm not going to personally, I don't do surgery in smokers. I need to have exhausted non-surgical options. I need residual deep pockets that have evidence of inflammation. And then lastly, I look around their mouth, and if they can maintain shallow pockets BOP-free, making the deep pocket shallow now makes sense. If I look around their mouth and they can't maintain a 4mm pocket, what's the point of making the 7 into a 4 because they can't maintain 4? Do you know, it becomes very simplistic, hopefully, in terms of your decision-making tree. Let's look at some blood and guts. Classic site, palatal of an upper 6, mesiopalatal. Often get pocket interfications. You can see there's a slight sort of inflammatory hue. Look at the quality of the rest of the tissue. This is a patient who's been through non-surgical therapy. We've got a residual pocket. And surgery is now regularly just site-specific. You know, those of you who did undergraduate periosurgery, you would like open them up from here to here. It was the most invasive treatment. You were at least doing quadrant surgery, even though loads of the pockets had closed and there were still some shallow pockets. It was really aggressive, sort of oral surgery, not periosurgery. And now it's often this site-specific, almost keyhole type stuff. It's tiny. You raise the flap, you can now access it, you can remove granulation tissue, you can get rid of calculus, you can change the shape of the bone to let the tissue lie better. Sometimes we might even resect some of the tissue so there's less tissue at the end than there was at the start. And you can take these patients in a very short appointment, probably a 45-minute appointment, from a deep pocket to a shallow pocket, you know, relatively simply, and actually relatively comfortably. This is not like big max fax type stuff. It's not even as bad as having a tooth out. And these things then become very maintainable. You've made a deep pocket shallow so that Mrs. Jones on a daily basis with a 7 out of 10 cleaning can keep on top of their trigger point. We then have things like root resection. So this guy, he is 38. And so he's young. He's got aggressive periodontitis. We treated him non-surgically with systemic antibiotics. Spot the theme. One trick pony. But we get him to the point where all but 3 of his teeth are shallow with no bleeding. A lower right 6 that had some regenerative surgery, his upper left 6 and his upper right 6. And all of these teeth are rock solid. And all of the pockets are shallow apart from the distobuccal root on the upper right 6. And he's got deep bleeding pocket. And I said to him, oh, that's not great. I said, you know, you've got quite advanced disease. I said, we've probably done as much as we can. I said, you know, probably looking at extraction. He's already lost a premolar from his teenage years having ortho. So this 6 is quite far forward. It's in his smile. And he's 38, single, man about town, you know, bit of a geezer. And he was like, I can't lose that. Because he said, well, okay, if I have to have it out, I'll have one of them screw-in things. And I was like, yeah, about them. Because he's not an extract the 6 and place an implant, is he? Anyone who does implantology in the room will know he has to lose his 6, 7 and 8. He has sinus augmentation, 2 implants and a 2 or 3 unit bridge. £8,000-9,000 worth of treatment in a patient who's periodontally susceptible, super susceptible. He's only 38 years old. How well do we think they're going to fare for the rest of his life? So we educated the patient to understand the risks of the decisions that he was making. And he went, so you're telling me it's £9,000, sinus lift, 3 teeth out, and there's no other options? I was like, well, there's one other option. We could think about chopping that one root off, but... And he went, tell me more about that. So root resections have sort of died a death. Since implants came along, a lot of what people call old dentistry, I like to call it dentistry, a lot of old dentistry seems to have died a death. Post-crowns, we don't do post-crowns, they don't work. They bloody do. They did for years when I was a general dentist. You know, I think we forget that some of these techniques have got an incredible evidence base. So I sent him off to our endodontist. He did 2/3 of a root canal treatment, charged full price, cheeky bugger. And he did like a little NIR core for me. So he's restored that with some, I don't know what they use, some magic paste that, I don't know, lasts forever and is perfect. Probably something like MTA, I don't know, voodoo stuff. And then he comes back to me and he has a root resection. And it's not the prettiest, and he has to keep it clean. But we are now 6.5 years on. He's now well into his 40s. The tooth is in his smile line. It's solid and it's functional. And I think that's pretty cool in the gang stuff. Now, is he going to take that tooth to the grave? Almost certainly not. But am I kicking the implant can down the road a bit longer and hopefully deferring the implant failure? Almost certainly I am. Now, the evidence base for these things is actually quite good. You'll be surprised because they are similar to implants. Controversial statement. Park did a review of his work. This was done over in Far East. He looked at 250 root resected molars and he followed them for 10 years with a success rate of 84%. That's all right. That's not far off implant success. I'm looking around for people whose blood's starting to boil because there must be implantologists in the room. People will be thinking, my success rates are better than that. So I've delivered this at an implant conference. And honestly, the hands were like, just pick me. I'm going to take you on, pick me. And I said, picked on this chap in the front. I said, yeah, can I ask you? And he said, my implant success rate's 98% in the upper jaw and 97% in the other one. And I said, all right, okay. What's that data that you're quoting? And he went, I said, that's 5-year data. He went, yeah, fair enough. I said, this is 10-year data. He went, yeah, but my 10-year data, 92% in the upper jaw, 93% in the lower jaw. I said, yeah, that's great. How do your perio patients get on? How do you know about those? And he went, oh, no, we don't follow that data. I went, no, you don't, do you? Do you expect that to be lower at 10 years than your 92? And he went, yeah, probably. I was like, yeah, shut up. This is pretty good stuff. And I can show you one other paper. Paul Fugazotto, Boston-based periodontist. He retrospectively looked at 1,500 implants he placed in molar sites, and he compared it to 700 root resections he'd done. Now, this is the perfect comparison. He's looking at molar implants, so molar site implants versus molar root resected in periodontally susceptible patients. He's a periodontist. No difference in the outcome of his patients between those two, followed over a 15-year period. What do we know about Paul's practice as a periodontist? Maintenance is great. The supportive care will be great. Case selection will be great. I probably do about 7 or 8 of these a year. And I'm not saying they're for everyone, but equally, I'm here to remind you that sometimes old dentistry is just dentistry and actually can work very well. And actually is not as crazy and wacky. And actually, if you think about the thought process, the alternatives may be just as risky. Sexy perio, regenerative stuff. So many of you will be aware that when we have these vertical bone defects, we have the ability to think about trying to regenerate that lost bone. I've shown you already, and I've said to you that the paradigm is changing within our specialty, that we are now thinking non-surgical first, follow them for anything up to a year, as long as we're seeing a response, before we think about intervening surgically. But that minced approach, that minimally invasive non-surgical approach, we cannot tell which defects are going to heal and which ones don't heal. It's not even the same as with a surgical case. With surgical cases, we know the steeper the defect, the deeper the defect, the more contained the defect, the more predictable the outcome. And with MINTS, the non-surgical approach, we don't see that defect morphology criteria translating through. And that is where that research is moving with Luigi's work down in London. This is increasingly predictable. And so if you have patients who have deep infrabony defects, we've ruled out things like fractures, endoperio, any other pathology, then give teeth a chance. This is more cost effective than taking the tooth out and putting an implant in, and we're putting an implant in to a periodontally susceptible patient. It's about finding someone with the skill set to do this type of treatment. And again, all I would say about it is it's quite minimally invasive. So here we've got patients who's only 34. They've had non-surgical therapy with systemic antibiotics and everything stabilised apart from the mesial of the lower right 6. And so we raised the smallest of small flaps. We've lifted the papilla between the 6 and the premolar. We've lifted the papilla in front of the premolar just to give us a little bit of flat mobility. I've not even lifted that distal papilla of the distal of the 6. We can see our well-contained defect. It's full of granulation tissue. We've cleaned it out. We've put our biomaterials in. So this is BioOS, and then we've got BioGuide. And then we close that flap. It's as close as you get to keyhole surgery. It's tiny. You know, this is inconsequential surgery in terms of patients going about their business. And often if patients say to you, what can they do that you can't? Please don't just say surgery, because why are they going to jump in the car and go, oh, well, let's go to Liverpool and see that Scouse bloke, or wherever it is that you refer your patients to. Surgery is not our only thing, but even when we do get to do surgery, we're selling it in a way that they understand that actually it's not, you know, headectomies like our next speaker is going to be doing. It's really minimally invasive stuff, but equally quite predictable. And all I'll say is, I didn't save this one, by the way, just in case you're thinking, aye, this should be good. You know, I've shown you lots of stuff today that I really genuinely hope you go back and you have a really good think about, you know, how you can adapt this into practice. One of the things I've always say on any sort of course, whether it be a small course or a big audience like this, you can come here for a day and you can have a bit of a giggle and a laugh, and you can think, oh, he was quite funny, and, you know, dinner was nice, and saw my mates, and then on Monday you can go back to work and do the same old stuff. And then I've got to ask you, what's the point? What was the point of coming if it was just for a giggle? You could have gone to the pub with your mate and not listened to me talk all day. The whole idea of going on a course is that you go back, and you're not going to go and practice the way I practice because you don't work in my world. But I would ask you, think about the things that you can change. Think about the things that are within your control and just tweak them. Little tweaks, marginal gains. And as you tweak something and then it becomes the norm, tweak something else. And slowly but surely, you'll start getting better outcomes. It's that simple. Sometimes, doesn't matter how good we are, it would take Harry Potter with a wand to fix some of these teeth. And extraction is something we sadly sometimes have to default to. Merchandise is available, so we do. Ian done action figures if you want to buy one. I'd like to thank you for listening. I really want to thank you for the invitation, and I've enjoyed being the warm-up act for our main event that's coming next. Thanks for listening.
Thanks, Ian. You're happy to take questions? Martin.
For your regeneration, do you just use BioOS or do you use PRF?
For those who couldn't hear, the question was, am I only using BioOS for the regen cases, or do we use any PRF or PGRF? I actually, 90% of what I use is Emdogain. Emdogain from Straumann. It's a wonderful material. Quite technique sensitive, but very, very good. BioOS and BioGuide has a place if you've got a very wide defect to stop the tissues collapsing. The PRF and PGRFs, the regen stuff is a bit tricky around them because when you spin out the plate, or when you spin everything out, and what you get is not that differentiated, as in you can't. A friend of mine's done some work on this in Italy, that you can't titrate the level of growth factors and different bits that you want in that product. So if we could get a medical grade sort of centrifuge and you could exactly titrate exactly what you want, spin it at the right speed, and you'd end up with a product that actually might be quite useful. What we have commercially is very difficult to set, and what you often get is something that has very little potential or too much potential, and that can actually be just as bad. For regen, I'm currently not using any of that stuff. We have it in the practice. We sometimes make little membranes to put over block grafts. So we use it in a few different ways, but I'm not using it for regen. That's an interesting world. That I think we're only just learning how well we can use that stuff. But for me, Emdogain's my default for when I raise a flap, with or without other bits. Thank you.
Anyone got a question I can understand? Stephen.
Is there one there? So, really good question. The question was, for those who couldn't hear it, it's an inflammatory-based disease. Do anti-inflammatory medications help? they've done loads of studies have been done on loads of different drugs. So they've looked at things like, just simple things like paracetamol and ibuprofen. And it does have a reduction in inflammation and a mild impact on perio. But perio is a lifetime condition. You can't be on ibuprofen for life because you'll end up with gastric issues and problems. Where we do see some positive stuff is with bisphosphonates. So it's less about the anti-inflammatory nature and more about the bone reparative nature of the drug. And you've got a drug laying down bone, a disease stripping out bone. So you almost balance things out. It seems to be that patients on bisphosphonates, their disease slows down and is less progressive. Some really interesting studies from India looking at local delivery bisphosphonates, not recommended, not something we should talk about, but interesting stuff. Long-term steroid use, I suppose we might see some benefits, but then there's nothing really that you're going to use that has any sort of significant impact that you can use safely for any length of time. And like I say, when we use the antibiotics, it's to manage that dysbiotic relationship that's going on within the pockets. You've probably also got some sort of bacterial invasion of the soft tissue wall. So when you clean the pocket, there's a reservoir of bacteria in the soft tissues that maybe keeps the inflammation primed. So you clean the pocket, the antibiotics clean the tissue and shift the dysbiotic bacteria to a more symbiotic bacteria, and you redress the balance. But it's short, sharp type treatments, not chronic, drawn-out things. But no, comes up a lot. And the S3 guidelines looked at that, and they're very clear that we don't use them.
Thanks, Ian. Any more?
Oh.
Andrew.
Do we know the reasons for the 8 to 10% of the population that are perio disease resistant?
Do we know the reason why 8 to 10% of the population are resistant? No. We need to find out and give them perio, don't we? Because I need more work. No, we don't. They seem to, I mean, there's all sorts of reasons why some people are more susceptible than others. So there are, I mean, we joked at the start of the day, neutrophil issues, hyperactive macrophages. There's all sorts of things where there's quirks. You've got things I genuinely don't fully understand, like interleukin-1 polymorphisms, the way your inflammatory cascade responds. Some people are just hyper responders, and other people seem to just not respond whatsoever. It would be great if we could harness it and capture it, but I don't think that's going to be, because there's a famous study called the Sri Lankan Tea Workers Study, where they went to a population that was unwesternised, no medical dental treatment, and when they did the epidemiology there, this 8% resistant, 10% super susceptible, everyone else in the middle was there, probably, that was in the 50s, 60s maybe, and you look at all of the epidemiology for the last 50, 60, 70 years, these figures are just a constant. They're not changing. You'd have to ask someone cleverer than me. Maybe Ian Chappell could have answered that better than me, but no. All I know is they're bad for my business. You probably want loads of them. Any more?
Thanks, Ian. Any more?
Headline act, I reckon.
Well, first of all, I'd like to thank my other half for throwing me a hospital pass. And 10 minutes ago, she said, can you do a wee vote of thanks for Ian? Thank you, Patricia. Originally, we asked you to speak, I think, about 15 months ago. And at that stage, we gave you our full wish list, and you agreed to everything on it. You provided your aims and objectives. These were submitted. Since then, you've responded to all our subsequent requests and tweaks to your presentations, even as late as yesterday on your journey up on the train. So, Ian, thank you for your adaptability, your good humour, your pragmatism and your superb delivery. It's been a pleasure to host you, and we are indebted to you for your outstanding presentations. Please join me in thanking Ian. Thank you. Okay, folks, we have got a coffee break, and we're back in here for 10 to 4 for the Caldwell Memorial Lecture. Is Professor McCall here? No, he's outside. He'll be presenting on oral cancer, what you need to know and what you need to do. Okay, see you back here, 10 to. Thank you.
How long is it since your surgery now, John?
3 weeks, yeah.
3 weeks, good. How's it going?
Fine.
Okay. How do you get on with eating now?
I'm doing alright.
Good stuff. For home.
In what respect?
When are we getting you home?
Hopefully tomorrow.
Tomorrow. Okay, dokes. And are you managing?
talks. My messages are pretty short, you know, like, this is where you need to send, and this is how you send it. After graphic visual, this is how we look after people, this is what we do for them. There's some research at the end. I'm hoping I've time to go through some of the microbiome work, which ties into the thyroid disease.
Right, okay.
Same candidate causing cancer.
Right, okay. Well, that's really interesting. That is...
a very relevant time. And it's a real pleasure to talk to this group because every 6 months. I'm also the man standing between them and a drinks reception now, I realise all this. I will say that.
Yeah, coming up. Good. I did say to Jim...
well, Lucy is in the second row.
I'll phone them when we go to the drinks reception.
But listen, don't stress about that, honestly, truly, but okay, if you can. Perfect, okay, wonderful. Both are lovely, you know, that's also one of my favourites. yeah. Lovely winter venue. Okay,
Okay, folks, if you can come on in and take your seats as quickly as possible. Someone can tell the BDS4 students who have been hanging about all day scanning us in that there are lots of seats down at the front and they're very welcome to join us. Okay, let's get started. Good afternoon, colleagues. For those of you who don't know me, I am Robbie Thompson, one of the co-directors of CGDent Scotland and part of today's organising committee. It is an honour and privilege for me to introduce the Caldwell Memorial Lecture. And every year, our final session at the Scotland Study Day is dedicated to the memory of Robert Craig Caldwell. And since 2016, we have been joined by the Glasgow Dental Alumnus Association, the body which established the Caldwell Memorial Lecture. There's a wee bit in our programme about Bob Caldwell. But I'll give you some background. He was born in the United States but raised in Millport, and he graduated from the University of Glasgow in 1950 and embarked on a career in dentistry that saw him return to America as Dean of the School of Dentistry at UCLA. While he was there, he encouraged the recruitment of minority and female students so that all segments of the population could be represented in the student body. In addition, he encouraged students to seek advanced training and considered all students to be his colleagues. After just 3 years in post, Bob died aged 46 of chronic myeloid leukemia. His classmates at the University of Glasgow established the Caldwell Memorial Lecture and set up a trust to ensure that world-renowned speakers could be brought to Glasgow. It is highly appropriate that we have another esteemed Glasgow graduate to deliver this year's Caldwell Memorial Lecture. Please take time to read Professor McCall's very impressive biography in our digital brochure. If I read it out to you now, we won't have any time for the lecture. I can, however, offer some additional personal information that Jim, by his own admission, scraped into dentistry as he thought that his future was going to be as a professional musician. He is an extremely accomplished flautist. Music's loss was a huge gain to the world of oral maxillofacial surgery. Could you please welcome our speaker for this afternoon, Professor Jim McCall, to deliver the Caldwell Memorial Lecture entitled Oral Cancer, What You Need to Know and What You Need to Do. Thank you.
Good afternoon, everyone. It's a pleasure and an honour to present this lecture today. My granny was a Caldwell, actually, and I did wonder if there was a connection in the background somewhere. Now, I know what you're thinking. You're thinking, is that really him? And if that is really him, who's the fat dude they used for the flyer for this meeting? I have lost a pound too. I'm aware as well, actually, that I'm standing here between you and a nice drinks reception, so I promise we'll launder through this nice and quick, okay? And I was going to put my graduation picture up, but I was a bit worried that Billy Cameron would have left again. Is Billy still here? He is, there he is. Billy and me. I couldn't miss that, Billy. Right? So I'm based now in the Queen Elizabeth University Hospital in Glasgow. This is the biggest hospital in Europe, would you believe, by bed numbers. And would you believe also there's still the same 2 roads in and 2 roads out as when it was the Southern General, or the Suffering Genitals as we used to refer to it. And we're based in the Institute at the top left part there. We are the busiest head and neck centre in Europe for the stuff I'm going to show you. Now, what you need to know is how to spot a suspicious lesion. And I'm going to say repeatedly today, just send it. Okay, just send it. If it's not something that you very comfortably, as an expert in the intraoral environment, would say is a mucocele or a torus, then just send it, okay? Every 6 months, at least, somebody's sent in late, to the regret of everyone involved, particularly the patient and their family. And I'll talk about some of these people. And then how you do that is quite straightforward. And you mention the word cancer, and then it comes straight to us. Otherwise, they might languish for 9 months waiting for biopsy somewhere else, and only get to me when they're upstaged to a point where survival is unlikely, okay? I could almost stop there, but I'm going to use the rest of the talk to talk a bit about the focus is oral cavity for us, but you see the oropharynx all the time when you examine the neck, don't you? So I'll talk about all of head and neck cancer and explain what that term means, because I treat all head and neck cancers really, and a lot of the epidemiological data that you see is describing all head and neck sites, not just mouth. But mouth is the most important for us, and it's the most important because it's the most common. It's also fairly deadly, okay? We'll go through all these different categories. I'll show you lots of patients and keep it a very visual talk, okay? I'd like to get to, at the end, my volcanic microbiome research trial, because that ties in really neatly with all the pedio stuff you've been talking about today in terms of the bacteria on and in and around our bodies. Our 16S ribosomal RNA sequencing is showing us really what's going on, and some targeting things that might help us sort people who've never smoked, never drunk, and keep getting mouth cancer, and they're on the up. Big message from today, okay? So I'm not going to say anything about these lesions just now, but I want you just to look at them and have a think about what you might do with them if they rock up to your practice on Monday, or you see them in the dental school. These are from my patient group this week, actually, from the Wednesday clinic. Have a look at all of those, and we'll talk about what happened to these people too. And all of this, it's about outcomes for people and their families, okay? All the people in this slide are happy to smile for a photo. They survived the cancer and they're dealing with the morbidity of the treatment. And some of them can't swallow anymore, some of them can't go out for dinner, some are doing okay. All but 2 have had the face completely split apart and put back together, and I'll show you that. But what about the people not on the slide? And the chance of them being here depends exactly on when you send them, okay? Early stage disease is great. I'll tell you lots of times too that some weeks 19 out of 20 of our urgent cancer referrals aren't cancer, and some weeks 9 out of 10. I don't mind seeing 20 people to catch somebody early. So never let your professional pride get in the way of a referral, okay? Just send them. So let's clear up this term head and neck cancer. It's like everything that happens except skin, brain and eyes, okay? But the commonest site is oral cavity and oropharynx. And don't forget, strictly your mouth stops at the hard-palate junction, at the anterior pillar of the fauces, where the anterior 2/3 of the tongue meets the posterior third. So any cancer of a decent size is extending into the oropharynx anyway. So it's a wee bit of a pedantic thing. And here's the kind of list. More than 90% is squamous carcinoma. Other sites, of course, salivary tumours, 4 to 6%. I'll show you one of those. Sarcomas are rare, but I've got a sarcoma case to show you. And of course, cancer more rarely turns up in other places. So in fact, in the head and neck cancer team at the hospital, and internationally, we're dealing with more than 30 different disease sites and diagnoses. In fact, it's more than that, because we've now decided in the latest revision that in saliva glands, you get 20 different types of cancer, although 3 common ones. I'm one of the authors on the guidelines for what you do with those. And of course, you'll see parotid lumps in submandibular glands that are enlarged. Please remember that there's a 1 in 4 chance that that lump in the parotid gland is a cancer. There's a half a chance an enlarged submandibular gland, if it's a fixed lump, is cancer as well. And even if it's a benign one, they can go wrong. Minor glands, it's 50-50 as well. And the sublingual gland, if it's truly a lump in it, 97% of them are bad news. So just watch them and send them, okay? You've got 800 minor glands around your head and neck. Rarer things like odontogenic tumours we see also. Now, wee bit of sort of the dry epidemiology stuff, which lots of you are aware of in the room. Worldwide, still 4th for men, 6th for women, not quite so common here, but on the up for sure. We had 711 new cases in the last fully audited year, so there's a lot of it. There's about 12,000 in the UK, but more than 10% of those happen in Scotland, although less than 10% of the people live here. This is an international hotspot, and one of the main reasons professionally that I moved back to the west of Scotland as a head and neck cancer specialist. Here's quite old data, but you see the trend here up to 2007. And there isn't an oral cancer graph on the CRQ site, but here's head and neck cancer all going up as well, and it's keeping going up. And the thing is, smoking's going down, okay? So it's not tobacco that's doing this. And alcohol consumption is kind of steady and going up, but other factors clearly involved. So you get different stats depending who you look at, but a 68% increase in the UK over the last 20 years, much higher incidence, okay? I remember when me and Billy were at dental school, Gordon MacDonald telling us that the average dental practitioner working for 25 years would see 1 mouth cancer in their whole career. Not anymore, okay? Not anymore. So you see the numbers, and they're going up and up. So you are or will be seeing more oral cancer, so be suspicious of any lump, ulcer, red mark, or white mark, or mixture, okay? Now, you all had wine at lunchtime, right? And I didn't. So, just show of hands now, okay? Please raise your hand if you've ever sent in a suspicious lesion. Loads of people, great. Keep your hand up if it turned out it was a cancer. Right, brilliant. Add your hand if it turned out to be a pre-cancer lump. Good. And add your hand up if you've got any patients who've had oral cancer under your care practice, right? So there's wide experience in the room already, right? And there's loads of it about and it's increasing. And I'm really intrigued to find out why it's increasing. Going back to these lesions then, top left lady, that's biopsied, moderate to severe dysplasia. Biopsied it twice, quite an old frail lady. Lasered the whole thing off with legal guidance. I'll show you that. Found 3 foci of cancer in it, okay? She went on to full treatment with radiotherapy and survived. Man in the top left, that's a not nice palatal squamous carcinoma. I think you'd nearly all send that in. Oh, back right. Lower left picture there, that lady, a psychiatric nurse, comes in with a decent, we would call that T2 in old money, but maybe a T3 now because it's more than 10 millimetres deep. Tricky cure, we'll see her later. And the man in the bottom right is actually the manager of our general medical practice in Skipton near Bradford, where I was working in 2008. And that's a mucoepidermoid carcinoma in a minor gland. Okay, so kind of innocuous, some of those, but got to send them. Here's this week's few patients I picked out of the clinic with their permission. I need to remember to say to you that I'm hugely grateful to all the patients who let me show the pictures here. I've got express permission from all of them. They're happy to share their stories and their images. And I spoke to 2 of them today, actually, about where they were up to. Top left lady, this is interesting because lichenoid inflammation and dysplasia and silver amalgam restorations are much more neatly tied than we used to be told. I'm certain of it. One thing used to be that you had to have a patch test before you could have your fillings out. But the team that I was managing when I was Research and Development Director at Northwick Park in London, when I was at the Marsden, just missed the Nobel Prize for working out the lymphocytes are post-coded. So in other words, the lymphocytes you find in a blood sample, some of them are for your mouth, some of the other ones are for your back, but they're not the same. So having a negative patch test when things stuck to your back doesn't mean you're not getting a lichenoid reaction off your fillings. So now there's no prior approval required. I routinely get patients to get rid of the silver amalgam, and you can expertly put something else in instead. And it's miraculous how many of them lose their lichenoid reaction. The inflammation doesn't cause cancer, but in the 2011 revision of the Hallmarks of Cancer paper, which is an absolute standout in cancer medicine, we now absolutely accept that inflammation is permissive for cancer developing because the cell turnover in my PhD work was all about telomeres or the end caps of chromosomes getting shorter because of inflammation and cell turnover, and that's what makes you very cancer prone. So That lady in the top left, actually, I lasered that out and it was severe dysplasia and her fillings are away and she'd not got anything now. It looks great. Man in the top right, that proved to be cancer after 3 goes, tooth out, etc. Hemimandibulectomy. This man here, I'm going to show you his CT scans, late presentation, big tongue cancer, positive neck nodes, hard to fix. This lady here, we'll see a bit later, having a central lymph node biopsy to specifically target just the lymph glands that drain that little site using a nuclear tracer and iodosciening green virtual reality, which is quite neat and much less morbid for her. And I'll tell you about her results. So what you need to know is when to refer, and it's just anything that's not clearly, in your opinion, a benign thing. A red bit, a white bit, a lump, an ulcer. Please don't ever let anxiety or professional pride or anything else get in the road of a referral. I'll never dig you up for sending something rubbish. Patients quite often will say to me, look, the 19 out of 20 that aren't cancer, oh, don't like wasting your time, doctor. My response to that is, you know, breaking good news is the nice part of my job. Breaking bad news is the hard part of my job. Here's the nice guidance, and there's various different guidances, but they're all kind of the same. Consider a suspected cancer pathway referral appointment less than 2 weeks for oral cancer in people with either unexplained ulceration lasting more than 3 weeks. And here's one of my bugbears. If they turn up and they've got it, they already had it, right? So here's a 2-week timeline. If it's still in a fortnight, that's more than 3 weeks, isn't it? So don't wait 3 weeks or 4 weeks. Get them back in. A red bit or a white patch or both, or a persistent and unexplained lump in the neck. It's that straightforward. And if you think it's something, then I can't tell what it is until I've got a biopsy. So you can't either. Okay? Just send them. There's some obviously benign things, aren't there? Here are mandibular tori, a quite impressive maxillary tori as well, and there's a mucocele. But any other wee lump in the lip that's not looking like that, especially in the top lip, you need to send that as well, because half of them, if it's a lump in a minor gland, are a cancer lump, and they don't have to get very big before they'll kill a patient. How you send them, you know to use the Sky Gateway referral. If you mention the word cancer, it has to come to our team at Queen Elizabeth, okay? If you don't say cancer, it will sit in a queue and other people will process it, and we get a lot of these referrals, so please use the word cancer. And if you can attach a photo, that really helps us as well, okay? Always send a photo. A bit of epidemiology again. Who are we looking at? Well, there are the peaks. Again, this is quite old data, but the age range is kind of the same. So it's middle-aged people, blokes more than women, but we don't not see it in the 30-year-olds. I've got some horrible stories about young people misdiagnosed, presenting late. And then we get a bit more updated information here about the rates of head and neck cancer overall, and you see the peaks. One of the biggest risk factors for any cancer is just ageing and sticking around. 1 in 2 of us get cancer now, 1 in 3 of us die of it, okay? So lots more mouth cancer. What causes it? Now, you know the stuff. Tobacco exposure, 40 fags a day, 10 times the risk. More than 40 units a week, 10 times the risk. Do both together, 53 times the risk, depends who you read. The alcohol being a solvent for the flat chain hydrocarbons that slot in between your base pairs and mutate your DNA, versus the trauma from the heat of tobacco, allowing the, not ethanol, because ethanol doesn't cause cancer, but the other branched chain molecules which get in and cause trouble. Shisha, by the way, even worse, because when you cool down tobacco smoke by bubbling it through water and make it colder, you can get up to 10 times or more the concentration of carcinogens. A draw in a cigarette gets really hot, so you stop. There are other pathogens in other sites, and there's a big suspicion that the human microbiome might be involved. So let's get through all this pictures of surgery and stuff and get to the end. Here's a thing that's really driving us at the moment. 35% of our female mouth cancer patients are non-smoker, non-drinker, and we've published on this. And that's a steady increase we're seeing, so something else is causing mouth cancer. There are, of course, for completion, rare things that people get, and they get lots of head and neck cancers. This lady turns up, and you see the patch on the side of her tongue doesn't look quite right. We biopsy that, severe dysplasia. So where do I start, where do I stop? Two big research trials. We've used Lugol's iodine. So when we use potassium iodate solution on the tongue, the dark brown bit is where triiodate forms, and that's the normal stuff. But the Warburg reaction happens in precancer tissue, and all the glycogen, and there should be glycogen in every one out of 32 trillion cells, the glycogen disappears because of cytosol glycolysis, and it stays pale. So what we're able to show here is that, is that going to show me? That bad patch goes all the way back here, and we can laser it out. But she's a never smoker, never drinker. Why she got it? here are all the symptoms and signs from the European head and neck thing, and it kind of repeats, doesn't it? But if I put it back to oral cavity, it's the same message. All right? Good. In terms of actually diagnosing it, of course, it's biopsy. Almost everything gets biopsied, unless it's gone away by the time your patient gets to me. If there's a lump in the neck, we'll do a core biopsy, best done under ultrasound guidance, because sometimes it's cystic and fluid and you want to hit the solid part, okay? We scan patients from here to here. It's called neck and thorax, but we get a bit of brain and we get all the way to the bottom of the diaphragm. So we see the kidneys, the adrenal glands, we see liver, we see all that stuff too. Sometimes, of course, silver amalgam, what I did in there, causes problems, and we use MR instead. So here's the man, and I put him back in there. Man in the bottom left, with this thing, which smells as bad as it looks, by the way, in the clinic, and it's very painful. This is a CT, so you can see the extent of tumour here. Not getting very well with the pointer. That's going to be hard to fix. You've got to factor in that I've got to take 1 centimetre to 1.5 centimetre of a margin to get the cancer out. So he's losing his whole tongue. And he's got neck glands involved too. Here's an involved neck node, not a nice one, because it's big and it's irregular and fuzzy at an outline, and it's dark and inside it's necrotic. Oftentimes, metal artefact obscures it. We use MR scanning for that. So the one on the left, quite a nice wee neat tumour, so we can just take that out and sentinel node it. That other one is going to be a subtotal tongue again. We use PET CT scanning. This is for recurrent and advanced disease. And in truth, in honest truth, we're really using the PET CT scan to find reasons to not do the operation. Because if you've got a liver lump or a bone lump or something else going on, we will not cure you. We just control it with the other things. And on this one, my message is send them early because there's an exponential rise in the morbidity of the treatment for cure between a small one and a big one. Okay? A severe dysplasia lateral tongue, laser that out, sore for a fortnight, heals, functions good. T1N0, a lady will show you a bit later. We can take that away, primarily close, do sentinel lymph node biopsy mapping to just pick out the nodes. Home in 2 days, home that day sometimes. A T2N1, decent operation, takes me most of Monday. Every Monday I'm doing one of them, 8 hours at least, sometimes 12. My longest ever is 26 hours. That's a story, but anyhow. Then that's 10 days to fortnight in hospital. Composite flap, where we'll take out the fibula bone you don't weight bear on and transfer that into your face. Longer recovery, much more life-changing. Bundle in radiotherapy. You never enjoy going out for dinner again, hardly. And chemoradiotherapy, I'll tell you, is 500% more acutely toxic at the start and at the end, and changes your life. And people die early after they've it done. So the resection is take the tumour out with a good margin, stage the neck by taking out glands to decide if radiation treatment will help, and reconstruct them. And because of microsurgery, which was pioneered for the whole Western world by David Suter at Carneysborn actually, and then he showed us all how to do it, we can confidently make a hole and take the cancer out. And that actually is the only bit that we can control. We take all the primary cancer out. If it's spread anywhere else or behaving badly, lymphovascular, perineural, non-cohesive invasive front, can't control that. We can just control making the big hole and taking it all away. They might require adjuvant therapy. Sometimes it's clearly the indication for that. Sometimes we're not sure. And immune therapy has been the most incredible advance in the last 25 years. I'll tell you about some cases. We're not allowed to use pembrolizumab to cure patients. We have to pretend we're just going to palliate them. But I'll show you a case where we were able to cleverly, carefully, I think, argue the toss and shrink a tumour enough that we could cure a man. My best paper is in Nature, that AMG 3191. That was an immune therapy experiment with a cocktail of chemokines, which showed that we could boost the immune response to the cancer and get better outcomes. And this is another of my key messages. I really still feel in 2025, you ask the man in the street how you get cured of cancer, they say, oh, radiation treatment or chemotherapy. But it's not. Nothing's more effective than surgery for a solid tumour. 80% of cancer cures involve a surgical operation. And the more I've learned over time about chemotherapy of various sorts, radiation therapy, which is all my PhD, and immune therapies, surgery is less toxic because we leave the rest of your 32 trillion cells alone, okay? We just attack the bit where the cancer is and reconstruct you. Everything else has systemic ramifications for the rest of your life. These decisions aren't made by me in isolation. There's a whole team. This is an old picture because we do it all on Teams now, which is great because on Friday morning at 8 o'clock, I don't even have to brush my hair. I can just go in the meeting, and sound awake. But it's a big squad of people involving all of these folk. This is a wee slide on adding chemotherapy to radiotherapy, because some of these patients will come to your clinic. We get an 8% survival advantage by giving them chemotherapy with the radiotherapy. That's because platinum sticks onto your DNA and the lethal blow from the radiation treatment is a double strand break. A single strand break in the DNA from the radiation will be repaired. But if a bit of platinum stuck to the other side of the ladder of DNA, when you get a single strand break, it chops it into a double strand break. That comes with a 500% increase in toxicity though, in the short term, and all the normal stuff gets hammered by it. And it's an 8% advantage, that's 1 in 12. So I can put it to you that 11 out of 12 people are getting that for nothing to save the one who benefits. Just can't tell who. And this is a wee chart showing you the blue one here. This is the toxicity over here. Hugely upped. And the long-term ramifications of dry mouth, mucosal problems, etc., etc. So let's go into the best part of the operation. Okay, here are the targets. Safe airway. I didn't make dinner last night because somebody didn't do a tracheostomy on a patient. I then had to do a tracheostomy as an emergency last night. I didn't get dinner in Gambit and I'm really sore about it. But anyhow, we'll work on that. Then I got to get out of the tumour because the one thing I control is get the tumour out. The worst thing I can do is leave any tumour behind. If you don't think you get the whole tumour out, we shouldn't start because we've just wrecked the end of somebody's life with an operation and they're going to die of it anyway. We take out cervical lymphatics and nodes and we reconstruct the defect for form and for function, okay? So here's this lady with a smallish thing on the tongue. If you add in that centimetre though, it's still going to be quite a chunk she will lose. This Lugal stained pale back to here, so I took it from here to here and pushed it together, but she still functioned remarkably well after that. We then map, on Wednesday at lunchtime we inject a nuclear tracer around that cancer and she goes into the scanner, and Thursday morning she comes to theatre and you see quite a nice big bright blob in her neck where the lymph glands that we're targeting are. Now, very lateral tongue cancer, but it's both side nodes, okay? There's another wee one further down. And here's the thing, like, how can you miss that? That's a great big lump, but that's the signal. The nodes I had to go and find were 2.9 millimetres and 4.8 millimetres. That's pretty small. So how do we do that? Well, on the day of theatre, we have a gamma probe that detects the radiation, and also inject iodocyanine green dye around about the primary cancer, and use the virtual reality camera, and when we find the right lymph gland, we get a big signal from it, and it glows kryptonite green, and you know you've got the right one. I just got her results back. Nice clear margins, 3 nodes out, all node negative. Great news. There's much less pain, shoulder stiffness and downtime if we do that for people as opposed to a full neck dissection you're going to see in a minute. If any of the nodes got cancer in them though, we do a completion neck dissection. None of us like doing that because the wrong time to be in anybody's neck is 3 weeks after they've just had previous surgery, and it's tricky and it's not nice. And normally neck anatomy is beautiful to work with and work around, but it's tricky. And if you then were truly just N1 and that's all you're getting, they're the losers really. In Glasgow we're a bit more progressive than actually the rest of the world, because if we find you've got 2 glands with cancer in them, we won't do the neck dissection because you're getting radiotherapy anyway, so we just send them for radiotherapy. Now we're on to major resection reconstruction surgery, okay? Tracheostomy, I did last night. This one was a bit less hurried. Halfway between the cricoid cartilage and the thyroid cartilage, curve the liver incision, through the strap muscles, elevate the thyroid gland up, make a Bjork flap window in, perfectly safe area. 70% of our patients have got significant lung disease and they cough and splutter mucus at you for a fortnight afterwards, and it's really to toilet that is the principal thing. But as you might imagine, and you'll see here, people get very swollen up at this part here after we've done surgery, and it's hard to cough and clear, and so the tracheostomy keeps them safe. A lot of the time we can get access peroral or through the neck incision, but sometimes we have to split the face apart. This is Derek. He's a Yorkshire patient. He was a fireman at the Bradford Fire, actually. A very nice man. And he had to have a resection that was tricky. So diagrammatically, you see that the cut edge of mandible is here and here. And we're accessing the back of his tongue and his epiglottis to get this tumour out. Now we do that in a kind of well thought out fashion. Use the curve of the mentor unit, a zigzag across, divide the muscles in the midline because the innervation comes from the sides, step cut in the mucosa. But we go around the corner to make the bony cut, so we leave the digastric muscle attached at the front. We make the bone cuts after we've applied plates and screws, so we know if we just apply the plates and screws after that, they're the perfect spot again. And the last bit of the break is made with an osteotome, so that there's bone-bone contact, okay, and it'll heal. This is a man with actually a maxillary tumour. Yeah, I did cheat a bit because the picture I showed you of Derek was after his operation by 3 weeks, so he's healed very nicely. He's conveniently got a kind of Kirk Douglas wee chin thing there, which we were able to use as part of his incision, but he's healed particularly well. So, 2 things happen when we take a cancer out. Take it out with a 1 centimetre margin. Okay, you think that'll make quite a big hole. The elasticity of oral tissues means and you get an enormous big crater. You think, what have you done to that man? At the same time, the specimen you've taken it goes and it looks really small, so it can be disappointing on 2 fronts. But the point is to functionally reconstruct. And here's a ladder of reconstruction that we use. You can leave things to granulate. If I take a skin cancer off next to your eye here and do nothing, that heals with almost no mark, which is quite remarkable. Skin in your body behaves differently everywhere. It's not the same. We can close things together, of course. We can do skin grafting or local flaps. But what we'll talk about now is free tissue transfer. These are all the bits of your body we can use. Just about half the time we use your forearm because it gives a nice pliable paddle of skin that maintains and allows movement. Bigger ones, anterior lateral thigh. We can turn your 6-pack into a 3-pack and use the other 3-pack to reconstruct at the top. Back muscles for big defects, big facial defects. Fibula bone we'll look at, and these other ones too. So here's a forearm flap being raised on the radial artery and the superficial and deep venous systems, and we can transfer that up. Sometimes we can take some bone with that, and that's really useful for people who've got advanced peripheral vascular disease and we can't use leg bones. We wrote up this one. This is the first report in the world where we used not just the skin and fascia, but some random fascia from further up and the bone all together to make a nice composite tongue reconstruction and a bit of bone reconstruction. So here's a lady towards the end of her operation with her tongue reconstructed. And apart from being a different colour, you can see the restoration of movement she's got and beautifully sealed off. Happy lady. And this chap, cancer at the back there, he actually never got on better with his complete denture than after his forearm flap because the lingual sulcus at the back on the right side was really deep and it sat right in it. Yeah, much happier. Very happy doctor. So that was grand. Now then, this man tragically had been misdiagnosed as a jaw joint problem, and he was the husband of the secretary to the pathologist that did our head and neck work in Yorkshire. So he had a great big cancer in his tongue base, which is mucoepidermoid, so it was one of the more frequent types of saliva gland cancers. So fast forwarding to his access procedures, you can see he's got a tracheostomy. There's a big lip split, okay? And it always looks worse on a slide than when you're there. When I'm there doing this, I've got a real purpose to what I'm doing, so it doesn't feel like watching these slides. So don't think, oh dear God, what's he done? And hold on to the end when I show you him closed up. Just to orientate you, it's not going to work. Tongue tumour is just here. Cut edge of mandible is up there. Other side is the other side. So here it comes out, and for him we're using rectus abdominis to reconstruct him. The crisscrosses are where the perforated vessels run out to the skin, and we use the deep inferior epigastric vessels to reattach into his neck under the microscope, 2mm artery, 12 sutures. We stitch it to itself so it doesn't shear around, you know, because the shearing can just damage the blood supply to the top. And these days we use all dissolving stitches. He got clips, that was back in the Yorkshire days. And then by dint of a not very good photograph, it even looks a bit like his tongue, and his speech is pretty good. So, here's a really big tongue cancer. This man's a challenge because he's going to need combined modality treatment to cure him, and most of his tongue's going to go. A big determinant as well is if you look on the right-hand side, the other side lingual artery is going to be taken out, so all of this is not going to survive. So we reconstruct him with his thigh. Anterolateral thigh comes from halfway between your kneecap and your hip bone, and we use a Doppler probe to find the perforating vessels and isolate them. You can see the depth of the resection to get that cancer out. There's a lot of height. Everything above his digastric muscles, so geniohyoid, genioglossus, mylohyoid, have all gone with the tumour to get clear margin. So we need a chunk to put back in, and we get a chunk out of his thigh, okay, with muscle and fascia and fat. He's had a visor drop-down procedure, so I'll open his neck up across the way. We take a box of bone out of here and drop the digastric muscles down and out. Well, like a kind of Colombian necktie approach. But at the end, we put people back together. When we have students on attachment and some of my students are on the audience, I like them to stay to the end so they see someone put back together again, because we're all programmed to look at intact faces and we're all programmed to look at some of these slides and think, oh my God, what's he done to these people? This should play as I click onto it, and this is John, who's had that procedure.
How long is it since your surgery now, John?
3 weeks, yeah.
3 weeks, good. How's it going?
Fine.
Okay. How'd you get on with eating now?
I'm doing alright.
Good stuff. And what's the plan for home?
In what respect?
When are we getting you home?
Hopefully tomorrow.
Tomorrow, okay, dokes. And are you managing to swallow liquids and solids?
Yeah, no problem.
Okay, good stuff. And you find that you can make yourself understood with speech and things at the moment?
Yeah.
Good stuff. Great. What's been the worst thing about being in hospital?
Boredom.
Boredom. Right, okay. All right then. Well, we'll soon get you home and get you on with the rest of the treatment now.
Yeah.
Brilliant. Okay. Can you just say the days of the week for me? Can you say the days of the week for me?
Monday, Tuesday.
Just pause it there. The only thing about this is John's got a very confirmed Yorkshire accent there. He actually lives in Govan. He doesn't. The kind of test, when I'm really enthusiastic and excited about what I'm talking about, I do tend to speak too fast. I promise I'm trying to slow down. But in Yorkshire, if you could be understood more clearly than Professor McCall, you're doing quite well. So John was doing quite well. And he had his whole tongue out, and that's how he sounds. What's really interesting is your accent isn't your tongue. It's the other shapes that you make, clearly with your vocal cords and the shapes of your pharynx, if you're Yorkshire or if you're Glasgow, you know. So, fibula flap we'll talk about now. This is the leg bone you don't weight bear on. If we leave you 8 centimetres at your knee and at your ankle, you have a stable knee joint, stable ankle joint, and it's extremely useful for reconstructions. There's a segmental reconstruction. The blood vessels to the skin run out around the back of the fibula bone, so we identify those perforating vessels and we base the paddle on it. And these days we use 3D planning software to get exactly the right shape, and I'll show you some nice cases. This is William, and he's very happy to have me talk about his case today. This is an MR scan, okay? And what we're seeing here is the tumour at the front, axial images, so he's lying on his back. But this white bit in the black bone is enhancing because there's cancer all the way around here, so it's all got to go. And here's a CT scan, and you can see the erosion at the front here, but it really underestimates the extent of bone involvement. And 3D scans are often helpful, but again it underestimates it. So here's his 3D planned online with KLS Martin actually. This is how much mandible has to go. And we're able to fashion and design cutting guides for his leg bone to turn a straight thing into a very lovely curved thing, plan the implant placement and plan it with a milled plate that's a perfect size. Each of these segments can't be less than 15 millimetres or the viability is no good. The blood supply is periostal to this reconstruction, and we have to shave off some bits to get it all to work. This is now our routine practice for reconstruction. So in the past, people used to just either die of a cancer or have a horrible Andy Gump deformity, but now we can really fix them right down to 10 millimetre narrow platform Straumann implants. And here's a diagram of how it comes out the leg, and you can see those wedges that are cut out, and they're cut out still in the leg, and the implants are put in still in the leg, and we lift it all out and it clicks round to the right shape. Here's some of the 3D models that we get handed and the cutting guides that we use. So here he is with a big defect. And here's the reconstruction in a panoramic view. And it's much easier to appreciate, I think, on the 3D CT scans. No matter how long you spend looking at imaging, we're all programmed and hardwired for 3D, aren't we? And around the other side too. So you made great progress. Very smiley man. We have a good bit of banter about the football, him and me. We're on different sides of the footballing divide. And he was very happy to show you his pictures today. This is Ian, and Ian presented with a sarcoma. So he turned up with pain from his upper third molar, and it was popped out, and then a wee lump appeared. It turned out his maxilla was full of tumour. So we've marked out the aesthetic subunits in his face that we use for skin cancer work in order to divide it open. And I showed you him a bit earlier, and that's his tumour mass in the maxilla there. And the defect at the back. The pterygoid venous plexus at the back always bleeds a lot. Now, interestingly, the curve of your face is almost the same as the curve of your pelvis. So if we use your iliac blade to reconstruct, based on the deep circumflex iliac artery, it makes a nice curve. Now the thing is, the curve of my face is not the same as the catenary curve of my dental arch. So we have to kind of compromise and bend it in a bit to have the implants in the right place. Otherwise you have teeth in the wrong postcode, you know, and it becomes very difficult. So here's his iliac crest graft, and this is the internal oblique muscle, one of the 3 layers in your tummy wall, and the blood vessels that supply and drain that running down into his groin, and we can transplant that up. So when we shape that and cut it and plate it in, there's a nice crown space for his implants, and it's reconstructed them really quite nicely. And that's him at the end, okay? So if I show you the before and the after, and this is him 10 days after, and then 2 months after having his chemotherapy. You can see how people compensate, can't you? So if you look at Ian on the bottom left, there's excess scleral show because he's lost his musculofacial expression with the tumour resection, and you can see he's got ectropion. But by 2 months out, he spotted that and he tips his head now, so his eyes look a bit more normal. Unfortunately, 2.5 years out, he got brain mets and didn't survive it, so there's lots to do. Now, this picture is the Kutubia Mosque. We were in Marrakesh last week, and I came up from the gents and saw this beautiful picture. And I'd just been off the phone that afternoon with the oncologist in Edinburgh to talk to you about this man. We did a Teams meeting. 48-year-old chap, not a typical presentation, okay, but he's never had a clicky jaw joint, never had jaw joint pain, he's not one of them. And he just said, I just can't open my mouth, and it keeps getting worse and worse. And eventually some pain radiated to his ear. He got sent to ENT. And when they scanned his ears, there was nothing wrong with his ears, but it just caught the top of, very unfortunately, a cancer involving the whole of his masticator compartment on the right-hand side. And the big problem with this is that it goes right up here to skull base, okay? And the first imaging we had, and we sent through here because there's no skull base service in Edinburgh, so we sent to me, to us, you couldn't definitively say that it wasn't through into his intracranial cavity and therefore he wasn't curable. This is a CT scan, and you can see the destruction of the ramus of his mandible, and you can really see why he can't open his mouth. So if we revert again to the 3D scans, you can see the destruction that's gone on for Daniel. So what do we do with that then? Very difficult. I talked to him about it, and I'm just very honest with my patients. I said, Daniel, the trouble is you're very hard to fix. He has extensive T4B, the B delineates, can't resect, okay? And we're not allowed to use immune therapies and chemotherapies as neoadjuvant, which means upfront try and shrink it and see if we can do it afterwards. So we have to say, we're not going to operate on you, but we're going to use palliative chemotherapy and immune therapy. So we did do that. And very quickly, he started to be able to open his mouth a whole lot better. So we carried on with, in the end, 300 milligrams per metre squared of platinum, and with pembrolizumab immune therapy, and he progressively improved. And we got new imaging and got what I would describe as surgical confidence that we could get a margin. So axial scan here, and a heterogeneous tumour picture now. Something's happened, and he's opened his mouth, right? And over here, we now say that must have been peritumoral inflammation and not actually cancer, because there's a margin. So we went ahead with surgery. This is me in the operating room with his planned model. There's the chart on the wall from our pre-planned bits. And this is a scan of him afterwards. Now, he's very swollen at the moment, that's why he's discluded, but as I promised, his occlusion is just fine. And he did extremely well after that. And we got good margins. At a skirt round, the whole medial pterygoid came out, the whole of masseter came out, but leaving his parotid and his facial nerve intact. At the top, got clear margins. At the bottom, 0.99 of a millimetre, but that was to intact mandibular cortex. And below that's a neck dissection. So the tumour is all out, and it's a result I'm very, very relieved and pleased about. The Marrakesh Teams call was about agreeing with the oncology team where the max voluming of his radiation treatment should be. So the yellow is the boosted bit, because that's where all the bad stuff was, and all the rest is getting some. You see his eye outlined at the top to spare that, but you can see that all that area is getting a lot of radiation, even with modern VMAT IMRT. So patients who've had that rock up with a lot of tricky problems in their mouth. And that's what he wrote to me. Another interesting tale. Okay, there's a message in this one. This lady, 64, came to see me at Ross Hall, very frustrated. And she said, I keep trying to get my dentist to send me to the hospital and they won't send me. And they say I can't have cancer because it's really sore. A small cancer lump, we would say, is more likely to be painless, but you can't say cancer's not sore. Sooner or later, the blood supply will be a bit crappy to one part of it, and you get an anaerobic infection in it, and it gets really inflamed and sore then, and quite often you can switch that off with a course of coamoxiclav. But poor Eileen actually isn't very clear in this scan, but that's all tumour, okay? And that's 2 involved neck glands over here, and they're necrotic, so this is not looking good for Eileen. So in terms of our options, she could go the route that John, with his Govan Yorkshire accent, went, and we offered all that, because that would be standard of care in 2025, and she said, no, thank you. So we went the route of palliative, in inverted commas, sacked. And again, it's only approved for palliation, so that's the only way we could spend £20,000, by the way, for a course of pembrolizumab, and it will never get cheaper, because these agents are antibodies and they're made in laboratory mice, and there's no way to make a knockoff, cheaper generic version somewhere else in the world. It's got to be made the same way. So pembrolizumab is a very exciting drug. The initial work showed a durable response in only 15% of people, so 1 in 6. But the Keynote 689 trials now come out, and that's where patients are getting what I've shown you, but they get immune therapy up front and afterwards, and there's already a 10% improvement in all the bad stuff that happens if you do that, but it's 20 grand extra, and it doesn't come without a cost. Eileen, though, miraculously, complete response. 3 years out, complete response. If we could tell who would do that, it would be brilliant, but we can't at the moment. So that's a big research thread. Human immunity is the most fascinating thing, and 10 years go by, we find out something else, you know. When it goes wrong, it's terrible. But anyhow, all this, of course, is teams of people. This is the Yorkshire team, a huge team in Glasgow. Truly, I've never lost that sense of the magnitude of what we do to people to fix them, and the attention to detail to get it right is really important, you know. Yeah. Some of my patients don't think that's funny. Here's a lot of the theatre squad from Glasgow. They're quite a brutal bunch. I took a picture of this on the wall because when you leave, you get X'd off. Look at that. They haven't done it to Jeremy McMahon. He retired last summer. So look, here's a summary of where we are, and I think we're in quite good time if you can stand it. What you need to know, how to spot a suspicious lesion. Anything that doesn't just stack up is obviously a mucosal. Just send it. I will never fall out with you. Do you know how many people have their blood pressure is used to stop one person getting a stroke? It's 100, right? No one needed to treat 100. If on a low week, I see 20 to catch one, I only need to see 20 to catch a cancer early. In a good week, it's 1 in 10. So I don't mind seeing the 9 in 10 and 19 out of 20 that aren't. Just send them. We'll never fall out. Never let professional pride or embarrassment get in the way of a referral, please, okay? Send them out, say cancer, use the Sky Gateway, and please send a picture. Everyone's got cameras now. Okay, we could pause for a second, and I'd like to tell you about the microbiome work. Is that okay? Yeah. Wonderful, right? So, 22. So this is some work that's ongoing. There are actually 160 patients in now, but I'm showing you the detailed data from the first 30 or so, and some other information from a bigger group. Back to this woman, why is she getting this? Don't know. And Michael Ho's work showed that if you've got a patient like that, they're now a separate defined high-risk group, okay, because 50% transform to cancer within a 2-year period, unfortunately, no matter what it seems we do to them. So there's a growing recognition then of a distinct bunch of people and an alternative etiopathogenesis for the disease, all right. Of our more than 700, we've got 35% of the women who are non-smoker, non-drinker. Non-smoker doesn't mean you've never had a shot of a cigarette at school, by the way. There's a threshold below we call you non-smoker, okay? And non-drinker isn't, you've never tried it either, but it's below a certain threshold that can't be causing it. So there's this idea now that symbiosis versus dysbiosis. There are billions of bacteria on and in and around your body, as you know. And when they go a bit wrong, things go wrong. It's a huge research theme. So we're looking for distinct patterns of microbiota diversity by comparing the normal West of Scotland people to the ones that have got pre-cancer and the ones that have got cancer. And within that, the ones who smoked and drank their way into it, we think, and the ones who didn't. So we need a big group for that. So we recruit them in the clinic. And it's an interesting thing, this, because when you rock up with a cancer and we talk to people about treatment, there's kind of just 2 choices and a big loss of control, I think. You can either say, okay, I'll have the treatment, and it's like getting on the roller coaster and you hold on with both hands, white-knuckled, or you say, I'm not doing it. And some people say, I'm not doing it. When you ask them for their help, in a research trial, it hands them back a whole lot of autonomy. Oh yeah, will it help me? Well, it might actually, this one, but it certainly helps somebody else. And almost uniformly, people are delighted to do it. And it's a really nice thing to give them that. So we just take a swab of their primary site, a venous blood sample, and sequence all the ribosomal RNA from bacteria in that. And they bring us in a wee poo sample, like the bowel screening thing if you're over 50. It comes in a universal container with a wee blue spoon. And initially the scientists gave us takeaway tubs. Somebody's going to go back with a full takeaway tub. Don't give them a takeaway tub. So we're not at a full takeaway tub, but I've had a couple of dirty old rascals come back in with a universal container, filled to the top. And there you are, doctor. And you're like, whoa, can you pick that up, Peter? So yeah, it's quite a thing. And then the lab team generate trillions of bytes of data, okay, and it's super expensive, this, because the computational diagnostics are so expensive. AI is really helping with this, actually, but it's still super expensive. And then we sequence and record the 25 most abundant taxa that we find in each of those things. And we found some new things, okay? At this point that I'm showing you, 125 screened, 120 consented, mean age, etc. Men and women kind of 50-50, okay? And that's pre-cancer and cancer, not 4-to-1, not 2-to-1. Women are really catching up, and it's something else. And these are the sorts of things we've found. Having teeth and any form of periodontal problem. And it's interesting, so as one of your colleagues with a dental degree, when I go to international head and neck cancer meetings, I'm the only man in the room that's got a dental degree pretty much a lot of the time. And I'm the one that puts his hand up and says, if you're finding periodontal pathogens in the bowel cancer, did they have any bad teeth? And they look at me and go, sorry, what? But you'll recognise that, and you spent the whole day talking about perio, and the bad things that appear in a periodontal pocket are the same candidates that are rocking up in the cancer science world now, okay? So it might be having bad teeth can be really bad for you, okay? So we do a BPE, and most of our dentate patients for major surgery are seen by Hamza Yusuf for my group at the dental school and restorative team, so we get a detailed perio exam. We collect the samples, and then we sequence 16S ribosomal RNA for these patients, and we get millions of data. So these are the taxa plots. Some of these charts kind of make you cross-eyed, but there's a basic message at the end. If you look at the top row here, this is the blood sample, and this is the gut sample, and you can see that the poo and the blood match up. So the bacterial fragments we're finding in your bloodstream are the same as the ones in your tummy. So you are what you eat, really truly, okay? But the oral cavity is quite different, which I think we kind of always knew. But in particular, if you've got bad gum disease, that's providing a microenvironment for bacteria that might be particularly bad for you systemically and in other ways also. That's the first in the world finding, and it's quite useful because British patients find it easier to give you a blood sample and a poo sample. I think it's the other way around in France. If you don't put someone in people's bottoms in France, they think they've been mistreated. That's what I'm told. These are KEGG orthologs, okay, so statistical analyses of bad metabolism and bad things, and what they're showing really is across the board, the head and neck cancer people are in worse nick than the normal controls. When we look at things, this is carefully kind of guarded data because by these various analyses in terms of the dysbiotic microbiome that we find, it correlates with type 2 diabetes, previous heart problems, all the sort of ageing and decrepitude associated morbidities that we find. And interestingly, having ever been a smoker, even if you're quit, seems to have a long-lasting effect as far as your microbiome goes. Other fancier tests, environmental filtering, same message, quantitative process estimates. This null modelling stuff is just fancier statistical analysis showing that things like stochasticity, which is a fancy word for randomness ratios, you have a more dysbiotic microbiome in our pre-cancer and cancer patients than in normal controls. So we're quite clear that the oral cavity cancer and pre-cancer people have got a different microbiome. And I told you about the concordance and not. So what, you think? Well, it's never going to be a vaccine or antimicrobial therapy because if we give people a blast of antibiotics, it only temporarily shifts the microbiome. 4 weeks later, it's back to normal. Food supplements won't do it, I'm afraid, or probiotics. But bacteriophages, if you cast your mind back, are viruses for bacteria, and that's how virulence factors are passed around, like antibiotic resistance, like the nicotizing fasciitis we get in and the whole half of faces away. That's a virulence factor being passed around between bacteria. We could easily program a bacteriophage to, for example, switch off Fusobacterium nucleatum from releasing acetaldehyde, if that's what's doing it. And so that's the big thrust and the push in case it's that that's causing the cancer in these people. So And these are the people involved in the project so far. I'm just wondering, one last key message. This is one of my favourite slides. All my career, I've bundled research in to what we're doing to try and improve it. And my argument is always you can't stand still. If you try and stand still, you fall behind because everyone else moves forward. So you have to be part of the cutting edge. This is Withrick and Company, who quite late in the day showed what's been shown forever in every other disease type and disease site, that the centres doing the most research get the best results. And this is overall survival, right? And that's a high recruiting centre, and that's a not so high recruiting centre. People sometimes think it's the Hawthorne effect with research. So in other words, that was a factory of factory workers who were given a survey about their working conditions, and then they were given another survey, and nothing had been changed. But because they were given a survey, they thought, oh, someone's doing something about this, and they felt better about it, and they gave better scores, but nothing had changed. That's the Hawthorne effect. But that can't be responsible for overall survival in cancer, can it? So the centres doing the most research work get the best results. And my other contention is, there's a line missing on that, isn't there? There's the places that don't recruit anybody to a trial, must be down there, I think. So clinical research work, key thing. Ladies and gentlemen, thank you very much.
Thanks, Jim. Questions?
I'm looking forward to this after all the wine that there was, you know.
Simon.
Yeah. Oh, it really is now. It's just those kind of time constraints, because HPV, not in mouth cancer, but HPV, the 100-odd strains of that, half of which give you cancer, the commonest is 16 at type 16, type 18. That gets into a tiny zone called the transitional epithelium in your tonsil crypts, in tongue base and in tonsils, and in the cervix actually. So it doesn't cause mouth cancer, and we know that it goes in. So yes, you'll see tonsil lumps and things when you're examining patients. The massive rise in oropharynx cancer, which is the fastest increasing cancer in Western Europe actually, isn't all HPV, by the way. Some of it we just don't know about, but that's a hugely important topic, which is, I could talk for ages, but I was conscious of time and being in between you lot in the drinks reception, and it's Friday, do you know, so I didn't touch on it much, but that's a really important, relevant thing. HPV is necessary but not sufficient for human cervical cancer. The other factors are unknown, okay? In terms of oropharynx, most of us will acquire HPV and clear it within 30 to 90 days, but why it hangs about and causes cancer in some people is enigmatic also. It is, however, much easier to treat an HPV-driven cancer than a tobacco alcohol-associated one. 98% 2-year survival and things like that. 47% 2-year survival if it's HPV negative. But yeah, so that's a huge thing. And vaccination, right, I was part of the campaign to get boys vaccinated. The idea was, if you just vaccinate the girls, one generation later, if none of the girls have got HPV, then the boys don't get it. But that generation of boys go under the bus, potentially, if they encounter someone who has HPV. Went through to a meeting with MSPs not long after I moved to Glasgow, actually. And remember that used to say that there was more pandas than Tory MPs in Scotland at one point. Well, the one guy said, I'm on the health committee, what can I do that'll have impact? Please vaccinate the boys for HPV. And so that changed that. Really important topic. If you see a lump in the tonsil or the tongue base or difficulty with swallowing, please send down as well.
Okay, thank you. Anyone else? Can I ask a question about planning of your cases? So you have a Zoom meeting with the whole team before?
We do teams, yeah.
Okay, and then everyone discusses what is the best way ahead for the patient?
So it's a very insightful question, Robbie, because what will happen in that discussion is this patient for cure or for palliation? Cure, yeah, fine. What's the cure going to be? And it'll either be surgery or non-surgical. The detail of the surgery isn't really discussed on that meeting. And there's only going to be, most Fridays, there will only be 2 or 3 surgeons like me who know how to do that. All the rest of the meeting don't know how to do that. And only those people could make a judgment of whether it's possible or not. So the actual, and it's been a bugbear of mine in some places I've worked where other specialties have tried to creep in what we do, like ENT and plastics. Lovely people, you understand, but when they say, oh yeah, I think a surgical option here, I go, all right, what margin do you think you'll get in that then? And what's the reconstruction? Oh, a free flip of some description. Describe it for me. You know, so the actual detail, That comes on a planning meeting we have every Wednesday. We've got a huge whiteboard with all the people ready for surgery, South Glasgow team meeting, North Glasgow team meeting, minor procedures pending, and we're discussing the screen, like what's going to work here, what's going to not work here. And there's an enhanced recovery clinic the patients go to for assessment, and if we're not sure they're fit for it, we can go to a high-risk anaesthetic assessment. It's quite hard, you know. A wee old Glasgow buddy walks in with the family and sits down in front of you reeking of cigarette smoke. And a key thing sometimes is they don't say anything, and the family are talking for them. Like, what's his cognitive function like? You know, you can't tell. So we walk them up and down a couple of flights of stairs, and if they're less puffed out than me, then they're a good candidate for it, you know. So that assessment process is tricky, but the MDT is just a go, no go. The detail is down to the surgeons. Yeah.
Thank you. Any more?
Good to hear.
If we go to Sky Gateway in practice, how can we refer?
There's an urgent rapid access email, which, do you know, they keep moving the goalposts on us. And would you believe, like, if I see someone at Ross Hall that's got a cancer, I'm not allowed to refer. I have to get you to do it. You have to use the Sky Gateway as the frustrating. Actually, I go to that. I just refer myself in. Yeah. Well, yeah, I didn't know about that. That's really interesting. It's all very well having a single pathway that's meant to work, isn't it? But it has to work then. It has to work. You know, phone me. Just send them. You know, I don't really care about protocols. The time to treatment and the morbidity rise that you've seen to try and fix somebody. And of course, there's a point with the cross where either life's going to be really bad afterwards or we just can't fix them. It's all about time and timing, you know. Does anyone else have trouble with the Sky Gateway? So I think it only lets you send to oral surgery, oral medicine, not OMFS. But if you write cancer, they just bounce it straight to us and it comes straight through as the thing. Okay. Yeah. Perfect. I had that when I gave a talk to the vocational trainers. Urgent rapid access referrals. Yep. Okay. Well, I'll get that to the
we
college team and we can share that.
So that's an email address for OMFS at Queen Elizabeth.
It is, yeah, and that would be routed through to our bookers and straight on the clinic.
John.
You're talking about over 50s and the screening process for bowel cancer.
Yeah.
Do you think there'll be a time, and if so, how long before you can screen for oral cancers?
Well, I mean, there kind of already is. If people are turning up to you guys and you're the experts on what a mouth should look like, you know, or we're the experts, aren't we, is one thing. There might well be, you know, because we find candidate species that are associated with these non-smoker, non-drinkers, and we're trying to reprogram them, then yeah, you could. Billy was talking at lunchtime about a patient with furcation involvement in their molars, and once the molars came out, the perio disease all kind of got better, and once that wee environment was away. And I'm kind of intrigued by that. It might be like having your crappy back teeth out would save you from cancer as well, you know, and surviving with a shortened dental arch, as you've seen me do to a few patients here. I mean, it would be lovely to think that was the case, and then we would have a programme of, right, so my biggest hope is that, rather than just do this sophisticated operation that I can show you here, and then they come back for 5 years at intervals, hoping for the best, and 10% get a recurrence, by the way, on a new primary. And if they keep smoking, it's so frustrating. I'd rather, as well as that, say, and here's a medicine that stops it coming back, you know, and reprogram their, if it's Fusobacterium or whatever, because there's other bacteria that are candidates, and believe it or not, I'm not supposed to tell you, because if that all works out, there'll be a patent associated, and there'll be money to be made, and we won't get anywhere with a pharma company, and they won't do anything unless there's money associated and all that, you know. Yeah, it could well be. That would be another nice thing, wouldn't it? So you do a swab test at the practice, you send it off and you say, you've got such and such. There's the bacteriophage therapy, which would just be a mouthwash probably, you know. It's a great idea.
Yes?
Do you ever see any shortcomings in the rehab of head and neck cancer patient primary dental care?
No, I think if you're good at your job and just look after your patients all the same and are careful, just look after them like anybody else. I think fundamentally these people need to feel that life's as normal as possible after this has all gone on, you know, and be looked after. And the stuff that goes wrong for them, I mean, if any of their teeth will let them down during therapy, like if I think for sure they're going to get radiotherapy, there's a 1.3% survival detriment for every day you miss in your radiotherapy. It's 5 days a week for 6 weeks. So if a bad tooth goes off and you get an abscess, that wrecks your radiotherapy. So they go. But afterwards, in the looking after them later on phase, being as normal as possible and looked after like a normal person is important. If they've had RT, it's not just less saliva, it's different quality saliva. Saliva is a massive repairer, don't forget, you know. And what they lose is the watery bit of saliva, because the saliva glands components that make the thick, claggy stuff survive the radiotherapy best. The watery stuff's missing, so they most often got a bottle of water in their pocket. But that lack of protective saliva means they're more at risk for things. A lot of them get that Durafat 500 parts per million, whatever, toothpaste, etc., etc. But no, there's no detriment in my mind as a dentist and doctor to them being looked after in primary care. I think you should embrace them as your normal patients. And if there's anything going wrong, just phone me.
Thanks, Paul. Any more, folks? Oh, yes. Paul.
Just a quick question, Jim.
Yep.
Any tips about the language we should use when we're talking to a patient we're going to refer them?
Yep.
And also what we should do if a patient just doesn't show, disappears, so to speak, when we're suspicious that they might have cancer.
Yeah. Language is crucial, you know. When I'm talking to patients about cancer, I never use the cancer word at the start unless they bring it up. Because when you say cancer, they think of the last person that died of it. It's not likely to be an oral tongue T2. It'd be something else. It'd be anti-GSA lung cancer or something. When you're referring, I think this just needs a check. Would be something, you know, they might do a wee test on it just to make sure it doesn't need any more treatment. And that's perfectly truthful, isn't it? Because 9 times out of 10, it's not going to be, or 19 times out of 20. And you can use that stat if you like, you know. When I get them in, I talk to people, and I'm always honest. And if they ask me, I'll tell them. But the only important take home they need from me is, can I cure it, or are we just going to control it? So it's all framed in the positive. Right, we're going to fix this. And I'll use the cancer word if it's appropriate to do it. But I also tell them what I just said. Look, if you're thinking cancer, it's not going to be what you think, unless somebody in your family's had a head and neck cancer, and our plan is to fix you. And also tell them, truthfully, that where I'm working just now is one of the best places in the world to fix it, because we've got such a volume going through. There's now 4 people a week having that kind of major surgery, so it's a high throughput environment. So I think language is really important. And it's like the Breaking Bad news thing, you know, a warning shot, and then you have to pause, and if they bring it up, just be honest and truthful. But 9 times out of 10, it's not. 19 times out of 20, it's not. It's a great one. What was the second part of your?
Oh, it's just if you refer them and then they disappear, so to speak, if there's anything.
Yeah. Well, if they don't show for us, they always get a second shot. And if they don't show twice, a letter goes out to them and to the referring practitioner to say he hasn't showed up. But I think you've discharged your duty of care if you've tried twice. And if you felt like trying to call them to get them to come in, I'd appreciate that. But non-engagement is difficult, and someone who's not doing that at the start would quite often not make it through all of that, you know. And I think, unfortunately, it's a bit of defensive medicine, isn't it? So if you thought it was and you sent them and they never showed up, try and chase them once or communicate with us. We'd always tell you, like, they never came, but we sent them one more, and after you fail twice, you don't get a third one, but you get a letter, you know. There's somebody there in the question.
I don't actually have any problems with Sky Gateway, but obviously you'd mentioned Rossville earlier, and a lot of our patients do like to go private for lots of things. I was just wondering, is there a private referral pathway if they want to go private from the offset or at all?
Yeah, Tuesday morning, my clinic.
Yeah, so a lot of mine have got A, either money or B, health insurance.
Yeah.
So they're probably going to want to go private, a lot of them. So I just wondered, because I've never actually thought about this.
Sure.
I've never actually thought about a private referral.
Yep. So very happy to see people. Oftentimes I can see people faster on a Tuesday there than in our system. We've struggled a bit recently to see people within, we're supposed to see them within 2 weeks of the date of your referral, and the system's been a bit overloaded and short of people, so I think an increasing number of people are doing that, and they just rock up to the clinic. Unfortunately, sometimes they misfire and they book for someone who doesn't deal with cancer all the time, because of the 5 max fax people at Rossville, I'm the only cancer one. Because if they go to someone else, they won't not get charged for that, but they'll just send them to me to pay twice, and it's another week or something, you know. I don't at the minute, actually, because their admin was terrible. I live down the road from it, and it's almost a bit too close for comfort, actually. Your biopsy's bleeding. No, it's not. Yeah, but yeah, so it's just Ross Hall just now, actually. Look, very happy to see people. Actually, as I alluded to, it's a bit of a rigmarole getting them into the NHS system, but there's an easy way to do it, and it can often cut down a bit of the timeline and the anxiety, because the worst thing is about if you've seen something you think, I think needs to check, and they've then got a 3-4 week hiatus before anyone even sees them, then that's quite a psychological burden for people, I think. But yeah, absolutely.
I've got the occasional patient that goes to Edinburgh. Do you work in the spires in Edinburgh, or is it just an Edinburgh surgeon, different surgeon altogether?
Yeah, it's different people. When I worked at Royal Marsden, these kind of operations were done for private patients because it was the same operating theatre, just different wing of the hospital. But up here, there's no private facility to do the bigger stuff. So they'd always end up in the NHS anyway. And if the Glasgow postcode, an Edinburgh surgeon would send them back. And it's just about a faff the paperwork for the biopsies getting back and the scans and stuff. But it's very easy to do that if you have people who want to quickly get seen. Also, in complete honesty, the cancer clinics get really busy and always running behind in them because we never turn anybody away. So there's generally, if your appointment's 10 o'clock at Russell, you'll likely get seen at 10 o'clock. If it's 10 o'clock at Queen Elizabeth on a Friday morning, bring your book, you know, that kind of thing.
Tuesday morning, basically every Tuesday morning they can be seen at Russell.
Yeah, that's when I'm there, yeah.
Thank you. Stephen, one last question. Yep.
So a lot of people nowadays are doing, nicotine pouches or snuff security.
Yep.
Is there a link to them and cancer?
It's a really interesting topic, right? To get cancer out of tobacco, you've really got to turn it into smoke to generate flat chain hydrocarbon molecules, benzene rings. And the accepted wisdom is that they slot in between DNA base pairs and push them apart, and they change the triplet codon interpretation. That's how you mutate P53, cyclin D1, PRB, all the important genes, right? Smokeless tobacco doesn't really do that. There have even been programs in North America where they've tried to substitute nicotine-addicted patients into smokeless than smoking, okay? Now, it's not without hazard, right? But there's a much reduced risk of using those things. While we're on the subject, vaping is very topical and very criticised. But in my clinic full of patients with dysplasia, I kind of push them towards a vape to try and get them off smoking, because the nicotine is what they're addicted to, and whatever else garbage is in the liquid, it's not flat chain hydrocarbons. And there's bronchiolitis obliterans is the fancy name for popcorn lung, but that's an order of magnitude safer at the moment than actual smoking. And the dosing from a vape is like the dosing from a cigarette. It's different to a patch. It's like taking a tablet on a cigarette, the dose timeline. Vaping's kind of similar. The amount of nicotine in the liquid is limited because they're not medical devices. So you have to warn patients, use it a bit longer than you would normally. Don't come back and tell me it made you cough, a smoker, and don't come back and tell me it didn't work. So, so the smokeless tobacco debate, just tobacco in general is kind of bad. It's definitely not as bad as smoking tobacco. From time to time there's like a research call and they'll give us £1 million that are available for smokeless tobacco research. So of course at that point I don't say it's not that bad, actually I say, oh, have the money please. Interesting topic, but and then I guess we're going to find out in the next 20 years what nicotine addiction in 12 and 14-year-olds does to you by the time you're 30 and 40, and I don't think it's going to be necessarily good news. Interesting topic though, the smokeless tobacco in methyl quids that's responsible for mouth cancer in India and places being the 4th commonest cancer for men is because it's combined with betel nut and areca nut, and independently they're carcinogenic, but the tobacco has a role. And head and neck cancer, don't forget, is the absolute standout in human cancer medicine. It's the only one associated with low BMI rather than high BMI, because if you're skinny, if atrophic mucosa, it's more susceptible to transformation.
Okay, I think, shall we close at that? Thank you, Jim. Thank you for accepting our invitation to speak this year. You have been a very worthy contributor to the Caldwell Memorial Lecture. Thank you. Take-home messages, urgent referral for anything that's suspicious. Don't worry about being stupid. And thank you for giving us such a keen insight into the work that you're doing for your patients and how you care for them. Thank you very much. bear with me, we're almost there. I have a few people to thank before we can nip upstairs. Firstly, staff at the Glasgow Science Centre, who has fed, watered and cajoled us throughout the day. Special mention must go to Craig Rooney and his AV team for supporting our speakers, dealing with their IT issues and streaming all presentations to our online participants. Plaudits to our BDS4 helpers who have scanned you all into today's lectures. Their contribution is greatly appreciated and may even result in improved lift-up scores from grumpy old Mr. Thompson. Thank you to all our sponsors for their continued support of this event, and particular thanks to our platinum sponsor, Scottish Dental Care, and all of our gold sponsors. We're indebted to our speakers, Ian and Jim, for their meticulous preparation and superb delivery of their presentations today. I trust that we will all take something on board, hopefully be inspired to seek further learning to improve the care we provide for our patients. I'm extremely grateful to NES and the University of Glasgow for supporting the study day and introducing our colleagues to the general dental practice community in the west of Scotland. To all of you, our delegates, online and in person, thank you for your support today, and hopefully we will see many of you next year on the 4th of December. Our speakers for 2026 include Nolan Naidu, Murali Srinivasan, and Professor Jerry McKenna and Helen Caney. They will be contributing on a day outlining how digital dentistry can make your career more enjoyable and hopefully less stressful. On behalf of my co-directors Paul Cooney and my wife Patricia and the committee, I'd like to thank and praise our multi-talented events coordinator Patricia de Vries. To organise an event of this magnitude is quite an undertaking, and Patricia has done just about everything by herself. Promoting the conference to our mailing list, booking delegates, liaising with sponsors and Glasgow Science Centre, putting up with me and the rest of the committee are just some of the burdens Patricia must carry. She has delivered an outstanding day for all of our delegates. Please join me in appreciation of Patricia's outstanding work. Okay, anyone not joining us for the drinks reception, please ensure you leave your lanyard in the box in the Link building, and all coats are in the Link building for collection. Thank you for your support today. Good evening.